Okay, guys, so this will be your discussion of CBoT 5 medicine paper. So, without wasting time, let's get started. So, 35-year-old patient, first hint is always age, experiences pain that is radiating to his shoulder, accompanied by dyspnea and sweating. So, maybe they are telling you about chest pain, which could be an angina or MI. So, that is the meaning of entire this line. Patient is known case of CKD. So, you have two things: CKD patient with chest pain, diaphoresis, sweating. So, it could be two things in my brain now. It could be unstable angina, or it could be MI, or third thing it possibility it could be uremic pericarditis. So मेरे पास तीन differential आ गए, क्या क्या? MI, angina, uremic pericarditis. Let's see. Following statement is correct. Above is a case of MI. Yes. So they're asking you इनमें से correct क्या है? So this could be a true statement. This is true. CKMB is far less sensitive and specific than troponin. ये सबको पता है. That is a true statement. Troponin is much better. तो ये भी true है. Moving to third one, rise in cardiac troponin level over 10 hours is needed for diagnosis. So, to make a diagnosis, we will see rise in cardiac troponin over 2 to 6 hours, not 10 hours. So, this is a wrong statement. So, these two are correct statement. This is a wrong statement. अब देखो इस टाइप के क्वेश्चन क्यों डाले, because nowadays in exam they are asking you this type of question, only 1, 1, 2, 3, 1, 2, 4. So that's why like we have added this type of question. So you can see first two statement A and B are correct, and third is correct. So remember, for MI to be positive, cardiac troponins we measure like rise will be seen after 2 to 6 hours, not over 10 hours. So answer will be A and B. So answer क्या होगा इसका? 3. Simple. And I told you like DDs in this case. So it could be unstable angina, first possibility. Second, it is MI, like so they are telling you more information of MI. Third possibility in this case will be uremic pericarditis, because uremic pericarditis can also present with I can say sometime ST elevation, and even like in CKD patient, many CKD patient they have a false positive troponin and CPKMB. So that is again, so these are the differential diagnosis in my case. आगे चलते. A 28-year-old woman, so young female, visit the doctor because she has difficulty sleeping at night. Insomnia हो रहा है. She feels crawling on her legs, which get relieved when she move her legs. So this is the hint. She is having a feeling of crawling, and that is improved when she move. So this is a classical, means I can say symptoms are improved on moving. That is the classical case of restless leg syndrome. So they have mentioned how many statements are correct. So it is a case of restless leg syndrome. So here you will see like patient will have like abnormal I can say sensation or abnormal feeling in the legs, and when she will move there will be improvement. So this restless leg syndrome, remember it is a case, so this is a true statement. So ये भी correct है. So it's a true statement. It is autosomal recessive. No, it is autosomal dominant in nature. So this is a wrong statement. It is autosomal dominant in nature. Do we give pramipexole? Again, it's a true statement. So in treatment of restless leg syndrome, we give pramipexole and we use ropinirole. Can it be associated with low serum ferritin? Means is it seen in patient with anemia, in anemia? Answer is yes. So it can be seen. So again, there are a multi-factorial reason, multiple causes for this condition. So it is not due to single one reason. There is an aggregation of multiple factors. So iron deficiency anemia could be one of the factors. So A, C, D, these three are correct statements. So let us see the option. So answer for this question will be A, C, D. So I don't see the option here. So remember, it is like I can say A, C, D means 3 are correct. They are asking you how many statements are correct. So answer will be 3. 3 are correct. अगले पे चलते हैं. Okay, you can notice a patient came to hospital. A test shown below was performed as a part of examination. So I think this is one of the easy. अब ये easy question मैंने क्यों डाला? Because it's a repeat question. So this is a repeat topic. INI-CET they are asking again and again. Even in NEET PG also they have asked. So simple, it is Babinski sign. So what you will notice in Babinski sign? You will notice like there is dorsiflexion of thumb, of toe, and there will be fanning of fingers. In a normal people, what you will see plantar fraction. So this is Babinski sign positive. It is a feature of upper motor neuron lesion. Ankle jerk, you will get an image of ankle. So maybe here when we tap on with the knee hammer. Sometimes, so ankle jerk, whenever we suspect any pathology related to S1. So ankle jerk means that's simple. They will tap one ankle, then you can see the movement. Now coming to a Jandrasic maneuver, it is a maneuver. So sometime like when we do the knee test on a same patient again and again, what happens? There is adaptation. So adaptation means then you cannot see knee jerk or ankle jerk or supinator, pronator or biceps jerk. So in that case, what we tell the patient to close both arms and do like this. This is something. When a patient will do like this, this is what we call this Jandrasic maneuver. So this is again not in the image. It is not a normal response. So this is a classical case of Babinski sign. Simple. This is, you can see how to perform ankle jerk, or we also call this Achilles jerk. Then if you notice like this, I told you this is Jandrasic maneuver. Moving to next one, this is something where I know many of you made a mistake. So mononeuritis multiplexa. Now mononeuritis multiplexa, it is something which we can see in many vasculitis, right? So we have studied this in giant cell arteritis. So understand this, but they are telling you not only this, they are telling you mononeuritis multiplexa, skin lesion and neutrophilia. These three things together. So just try to understand this question. Churg-Strauss syndrome will have mononeuritis multiplexa, right? So I am writing in short mononeuritis, मैं mono लिख दे रहा हूँ, plus you will see skin lesion here, that is true, but इसके साथ में क्या मिलेगा? What else you will see here? You will see here patient will develop eosinophilia, not neutrophilia. So ये छोटा सा silly mistake जो आपने करी है, don't worry. So यहाँ पर करिए, you will not do this mistake in exam. Now coming to giant cell arteritis, here you can see mononeuritis multiplexa plus headache. There may be slight increase in neutrophil count, but you will not see skin lesion. Skin lesions are unlikely. Cryoglobinic vasculitis is a rare form of vasculitis, so which is mostly associated with hepatitis C and sometimes with hepatitis B. So again here you will not see this. So understand this thing. Giant cell arteritis and Churg-Strauss में मिल सकता है, but giant cell में क्या होगा? Headache होगा. Skin lesions are unlikely. So PAN is the only condition where you can see the classical three things. Means you can see mononeuritis multiplexa, you can see skin lesion, and you can also see neutrophilia. Is it clear? So closest differential. देखो इसका आंसर why it is not Churg-Strauss syndrome, because Churg-Strauss syndrome में eosinophilia होगा, and why it is not giant cell arteritis, वहाँ पर generally skin lesion नहीं होगा. Simple. So answer will be B. Okay, moving to next one. A 30-year-old male visit OPD. 30-year-old with complaint of numbness in forearm. Forearm पे numbness है. It means कोई ना कोई neuropathy, some sort of neuropathy. During the night, a patient has following visible features. So you can see like a prominent jaw. So a classical finding, you can see it's a case of acromegaly. So acromegaly आपको दिख रहा है, तो acromegaly का patient है. What is correct about diagnosis? So I can tell you like it's a case patient with acromegaly who is coming to you with some neuropathy. So कुछ ना कुछ neuropathy हो रही है. So what is a common neuropathy which we can see? We can see like patient can develop. Yes, very good. Carpal tunnel syndrome. So acromegaly के patient में क्या होती है हमेशा? There is risk of carpal tunnel syndrome. So actually they are asking you an anatomy question. Carpal tunnel syndrome कौन सी nerve से होगा? So ulnar nerve entrapment will cause cubital tunnel syndrome. There is radial nerve entrapment, no. So in here you will see median nerve. So carpal tunnel will involve median nerve. There is no musculocutaneous nerve. So answer will be C. Simple. तुक्का मारा तो भी सही. Again, but remember the logic. In acromegaly in late stage only you will see patient will have neuropathy. That is, there can be risk of carpal tunnel syndrome. Now coming to a patient was diagnosed with Whipple disease. How many statements are correct? So let us see disease of middle age and elderly. So remember, suppose you don't know this, so let me keep it. So Whipple disease we are studying in medicine, so of course you will not see this in pediatrics. So again, it is a disease of middle age and elderly. So this becomes a true statement. Correct. Is it autoimmune? No, it is an infection. It is due to Trophirema Whippeli. So Trophirema Whippeli से होता है, which is a bacteria in actinomycetes group में आता है. So that is not an autoimmune. This is an absolute false statement. It involves GIT, Whipple disease patient. So remember, Whipple disease patient will have weight loss. Patient को और क्या होगा? There will be hyperpigmentation. Then you can notice there is infection, and infection with Trophirema Whippeli. Then patient can develop polyarthritis. Polyarthritis. So इसका मतलब this statement is also correct. This is true statement. Then a patient you will see like PAS positive macrophage in lamina propria. Then patient can develop loose stool. There will be enteritis, and patient can develop steatoria. And two more things I will add here, like with enteritis, there can be encephalitis like feature. So just I can say encephalitis like feature. So we call this neurovipples. And there can be culture negative endocarditis. Culture negative endocarditis. So these all features of Whipples you can remember by mnemonic Whipples. Whipples. So देखो CNS इन्वॉल्व हो रहा है, GIT हो रही है, जॉइंट हो रही है. दिस इज अ ट्रू स्टेटमेंट. Proximal and distal small intestines involvement. Yes, it can involve both proximal. Proximal is more involved. So this is again a true statement. So क्या गलत है? This is a wrong statement. So A is correct, C is correct, D is correct. So answer will be A, C, D. They are asking you how many are correct. So कितने correct है? 3 correct है. So answer will be 3. Simple. Whipple disease. आगे चलते. ओके, देर आस्किंग यू अबाउट GCS, ग्लास ग्लूकोमा स्केल पूछ लिया, कैसे याद करना है. सो जस्ट रिमेंबर इन GCS यू कैन रिमेंबर बाय निमोनिक. तो ग्लास ग्लूकोमा स्केल को कैसे याद करना है? सो वी हैव 3 कंपोनेंट. वी हैव आई कंपोनेंट, वी हैव वर्बल कंपोनेंट एंड वी हैव मोटर कंपोनेंट. राइट? आई, वर्बल, मोटर. इफ आई टॉक अबाउट आई, so maximum score is 4, verbal 5, motor 6. So 4, 5, 6. So if you see the net, अगर आप total देखोगे, so maximum will be 6 plus 5, 11, 11 4, 15, and minimum score we give is 1 to each. So minimum एक भी होगा तो कितना होगा? 3. Minimum will be 3. The problem is every time we teach student, they make mistake in GCS. So let me make it very simple. ESPN. ESPN sports channel. E means eye opening. खोल रहा है आँख. S means only opening due to sound. P means opening because of pain and no response, not opening. Then we give 1. So अब इसको descending order में लिखना है. So score how we will write? We will write score like this: 4, 3, 2, 1. Simple. Eye opening automatically, spontaneously. ESPN sounds means चिल्लाने पे खोल रहा है आंखें 3. To pain, 2. Not opening, 1. Now coming to a verbal component, we can remember. How we can remember? Again here maximum will be 5. तो कैसे याद करना है? We can remember this like oriented to time, place, person. Confused. So oriented means 5. Confused means 4. If he is using inappropriate word inappropriate, so मैं सिर्फ W लिख रहा हूँ. Then incomprehensible sound means he is just moaning and no response. So remember the mnemonic R, country, win. R means oriented, country means confused, W means word inappropriate, I means incomprehensible sound, and not opening means कुछ नहीं कर रहा. So how we will label this? 3, 2, 1. Now coming to motor component, so here we have 6 cores. So इसको कैसे याद करोगे? Remember the mnemonic can't live without fan. Can't live without fan. Can't live without fan का मतलब क्या होगा? Understand this thing? Can't means he is obeying command. C for can't, C for command. Command obey कर रहा है 6. Right? Then if he is, I can say localizing to pain 5. If he is showing, I can say a withdrawal response to pain 4. If he is having a flexed or a decorticate type of attitude, abnormal extension, decerebrate like this posture, and no response 1. Now simple देखो आपको क्या करना है? ESPN, R country win. R country means oriented, confused, word inappropriate, incomprehensible sound, no response. Can't live without fan means command obey, localize to pain, withdraw to pain, flexion abnormality that is decorticate posture, abnormal extension that is decerebrate posture, no response. अब देखते हैं localize to pain. तो localize to pain कितना आ रहा है? 5. Withdrawal is coming how much? 4. Command obey how much? 6. And no response 1. So थोड़ी सी यहाँ नंबरिंग सही करनी है आपको. This is 1, this is 2, this is 3, and this is 4. और अगर इसको सही करेंगे तो यहाँ पर होगा ये this is A, this is B, this is C, and this will be D. तो अब क्या आंसर होगा? फर्स्ट विल बी B. 1 का B तो एक ही में दिया है. 1B, 2A, 3D, and 4th C. So answer will be B. Simple. तो ये आपको याद रखना, GCS is always important. Like in past time नहीं है, GCS is always an important topic in NEET PG, be it FMG or INICET exam. हर जगह क्वेश्चन आता है इसका. Moving to next one. Condition which have raised D dimer level include. So D dimer level you can see in many conditions. Can it increase in MI? Yes. So it can increase in MI. Can it increase in pneumonia? Yes. Pre-operative state D dimer levels are unlikely increased. अगर बड़े होते हैं तो आप ऑपरेशन नहीं करते हो. So mostly you will see they are increased in post-operative, not pre-operative. Post-operative में बढ़ते हैं, so एक ऑप्शन गलत है. First trimester of pregnancy, no. So they are generally elevated in second and third trimester, not in first. Second, third trimester. So answer will be 1, 2. 1 and 2. Other than this, you can see in many cancers, sometimes due to side effect of certain drugs, in sepsis also D dimers can be increased. So यहाँ पर आंसर क्या होगा? 1 and 2. Clear? Okay, moving to next one. Immune mediated platelet destruction is seen in all except. Now try to understand. Drug induced thrombocytopenia. Suppose if there is any drug induced allergy, so drug can cause allergy or it can produce an idiosyncratic reaction, it can cause allergy or it can trigger the antibody. So यहाँ पर तो antibody बन सकती है, so it can be immune mediated, it can be, except पूछ रहा है. Infection can there can be antigen antibody response. So again, so here you can also see antibody formation. So infection can also cause immune mediated destruction. ITP in ITP there is actually antibody. This antibody will be directing against GP2B3B, GP2B3A. So ITP में basically होता क्या है? Like previously we were using the term idiopathic. अब इसको बोलते हैं immune. So here you will see antibody against GP2B3A. Now coming to Bernard-Solier syndrome, this is not immune mediated disease. Here actually what we see, you will see there is absence of absence of I can say GP1B. So absence GP1B, we call this Bernard Solier. So basically here platelet adhesion will be defected and you will see ristocertin test will be abnormal. Now agar I can say if you see GP2B3A is absent, if you see GP1B is absent, Bernard Solier, GP2B3A is absent, we call this Glanzmann thrombosthenia. अब इसको याद कैसे करना है, सिंपल है, B कम्स फर्स्ट, 1 कम्स फर्स्ट, पहले B आता है अल्फाबेट में, 1 आता है, ऐसे बाद में G आता है, बाद में 2 आता है, सिंपल. So remember Bernard Solier and Glanzmann, these are like genetic congenital absence of these GP1B and 2B3A. इसमें antibodies नहीं होते, so answer will be C. Following is a list of statements regarding Wilson disease. How many are correct? So in Wilson disease, what happened? There is a deficiency of ceruloplasmin. Ceruloplasmin कम होता है. This is correct. Ceruloplasmin कम होता है, so copper transport is basically affected. So copper will go somewhere. Copper will be accumulating in different tissues. So tissue में copper बढ़ता है. This is correct. And copper is going into urine. So this is also correct. But remember, when this copper is going somewhere, it is going into some tissues, it is going into, I can say, urine, some tissues, like it is going into brain, it's going into your liver, it's going into sometime nails, sometime your skin, sometime heart. Predominantly, mainly this will go to 3 places, like it will go into your liver, it will go into your eyes, you can see a KF ring, or you can see sunflower cataract, or sometimes it can go into brain, so patient can develop dystonia and sometimes secondary Parkinson-like feature. So copper, when it is going somewhere, in serum it will be normal. So serum में ये बड़ा नहीं होगा. This is not a correct statement. So they are asking you how many are correct. So again here 3 are correct. So remember, serum copper is normal or sometimes it is decreased. So that's why for screening we have 2 options. To screen this condition, either we can check for 24 hours urinary copper, ये बढ़ा हुआ मिलेगा आपको, this will increase, or we can check for serum ceruloplasmin. And what Harrison says, if values of ceruloplasmin are less than 15, that is I can suggestive of Wilson, less than 5, that is confirmatory. So ceruloplasmin will be less. But remember, gold standard test to confirm, or I can say investigation of choice, will be a liver biopsy and quantitative copper estimation. So this will be liver biopsy plus quantitative. आपको लीवर के अंदर देखना है कितना कॉपर है, quantitative copper. So here answer is 3. Okay, physician show you a case in OPD. OPD में आपको केस दिखाया, where a 30-year-old female patient complained of painful swelling on his hand since 3 months. 3 महीने से हाथ में सूजन आ रही. Positive rheumatoid factor, anti-CCP antibody. So okay, so diagnosis simple. It's a case of rheumatoid arthritis. So ये तो easy question हो गया. What drug you will use? Supportive therapy दोगे इसमें? No. Rheumatoid arthritis. So treatment of choice. Now what we do? We start straight away with DMARD. आपको DMARD देने. Penicillin नहीं दोगे. Penicillin, right? It is an antibiotic. Febuxostat you will use in a patient who is having chronic gout. ये तो chronic gout में देते हो आप, right? So even like now DMARD of choice, the drug that we start is methotrexate. So आपको methotrexate देना है. So there are different physicians. So starting dose generally we start with 7.5 mg tablet once in a week. हफ्ते में एक बार देनी होती है. If it is not controlled, like we can give 10 mg or 15 mg once in a week. But remember methotrexate sometimes can cause toxicity, so उसके साथ में आपको folic acid भी देना होता है. And if toxicity develop, in that case we give folinic acid or leucovorin. So to prevent toxicity, folic acid. In treatment of toxicity, what we give folinic acid, we call this leucovorin or citrovorin. So answer क्या होगा यहाँ पे simple है B. All are following are infectious cause of relative bradycardia. So relative bradycardia you can see in many patients who develop fever. So again salmonella typhi में होगा, yes, it's an infection. So typhoid में तो होती है. Malaria can cause, yes. Legionella pneumophila, yes. So a factitious fever is like you are acting like you have fever, or I can say self-induced fever. तो बचपन में होता था कि कई बच्चे हाथ पे ना नींबू लगाते थे, तो फिर टीचर ने डंडा मारा तो हाथ सूज गया, जल्दी सूज जाता था, फिर टीचर देखता था इसके तो अभी से सूज गया और नहीं मारना चाहिए इसको. ऐसी फैक्टिव फीवर मीन्स बुखार चढ़ाना खुद को. So that is a self-induced fever or malingering type of fever which can be a sign of some psychiatrical condition, or sometimes there will be some job benefit in this. So factitious fever is self-induced acting to have fever. So there is no bradycardia in that case. Simple. So easy question है. अगला देखते हैं. विद्या, a 13-year-old girl comes to OPD with her mother. 13 साल की बच्ची है, मम्मी के साथ आई. After recording the history, it was found she had been on antiepileptic for about 8 months. So 8 months she is taking antiepileptic drugs. She has not experienced seizure during this tenure. अभी सीजर नहीं आया 8 महीने से. Her EEG stand normal of late. EEG normal हो गया. Mother is also known case of epilepsy. So it means it is some form of hereditary epilepsy. So if I assume like when you can see genetic history in that case, my brain is telling me it could be, you can see the age, 13 साल की बच्ची है, मीन्स puberty age hit करिए, so it could be a case of myoclonic epilepsy which have some hereditary component. इसको हम बोलते हैं juvenile myoclonic epilepsy. So it could be this. Again, I am not confirming this without doing the changes, without seeing the changes in EEG. The doctor advised her to continue the treatment for another 16 months. Why do you think doctor advised so? Like I told you in the class, so we give antiepileptic drugs, right, unless for a seizure free period of 2 years. अगर 2 साल से कोई दौरा नहीं पड़ा है तब तक आपको देना है. और यहाँ पर जहाँ पर भी जेनेटिक रिस्क फैक्टर है, मीन्स हेरिडिटरी कंपोनेंट है, यू कैन सी मदर इज ऑल्सो हैविंग, इन दैट केस समटाइम यू हैव टू गिव इट लाइफ लॉन्ग. तो लेट्स सी ऑप्शन. ये आपसे पूछ रहा है कि अगले 16 महीने और क्यों चलाना है. व्हाई वी हैव टू गिव? बिकॉज देयर आर हाई चांस ऑफ रिकरेंस. ट्रू, वेरी ट्रू. It is a genetic form of epilepsy, so there are high chances. They're asking you true statement again, because the drug can be withdrawn only when there is seizure period of about 3 years. No, this is false. This is false statement. यहाँ पर 2 year होना चाहिए. Drug can be withdrawn after a seizure free period of 2 year. Again, this is correct. आप बंद कर सकते हो अगर पेशेंट को पिछले 2 साल में कोई सीजर नहीं आया. Most of the patient treatment has to be given lifelong. Yes, I told you like जब genetic history है तो आपको बार बार दवाई कई बार lifelong देनी पड़ती है. So this is again a true statement. So 1, 3, 4 these are correct. 2 is not correct. So answer क्या होगा? 1, 3, 4 B. अगले पे चलते हैं. Following is not a side effect of growth hormone being administered to patient for short stature. अब now when I see this question, suppose if I don't know this question, मुझे सच में नहीं पता, I am not knowing few things about growth hormone because we routinely don't use this in practice. So if you give growth hormone supplementation, so nowadays many bodybuilders are also taking growth hormone supplementation. So growth hormone देने के बाद क्या नहीं होगा? So growth hormone will have an analog action on your glucose. So growth hormone, देखो अब when I see this question, अगर क्वेश्चन में हाइपो हाइपर दोनों दिया है तो आंसर इन दोनों में से एक होगा. There should be one answer definitely, right? So when you give growth hormone, this will increase glucose, right? Even we do OGTT in acromegaly. तो आप growth hormone दोगे तो उससे hyperglycemia होगा, hypo तो नहीं होगा. So what is not side effect? Hypoglycemia. Hyperglycemia is seen. Yes. Excess growth hormone can cause acromegaly. It can cause gynecomastia, and sometimes like it can cause tinnitus also. So hypoglycemia you will not see. So easy question था ये बिल्कुल. Simple. Okay, 38-year-old male is found to be positive for HBs antigen. So hepatitis B surface antigen is positive, and HBe antigen is positive. So hepatitis B surface antigen is positive means virus entered. HBe antigen positive means virus is replicating. इसका मतलब ये infective disease है. So he was diagnosed with chronic hepatitis B. I should add a word, chronic infective hepatitis B. Viral load is 2 into 1, 2, 3, 4, 5, 10 to the power 5. And SGPT was found to be doubled. To understand this thing, just I am writing a flow chart here. Hepatitis B, if it is acute, which is seen in less than 5% patient, or it is chronic. So in acute, we give IV fluid. Chronic agar hai, so in chronic form, understand we need to see like how all patients don't need treatment. Treatment you will give only in those patients whose LFT, SGPT, SGOT, they are increased by more than 2-fold. तभी आप ट्रीटमेंट करोगे. So understand this, chronic may be this person who is coming to you early, or maybe that person coming to it in I can say CLD state, cirrhosis के साथ में आ रहा है. So chronic form, understand this. In chronic form, when you can see 2 into 10 to the power 4 in those patient who comes early means cirrhosis नहीं है. And those patient who develop cirrhosis which can be compensated or decompensated, लीवर काम करे या ना करे, पेशेंट को हालत खराब हो रखी है, पेट में लीवर में नोड्यूल्स हैं, पानी भरा हुआ है, in that case 2 into 10 to the power 3 means patient is coming to you late with cirrhosis. Early means without cirrhosis. तो अगर पेशेंट आपके पास इसके साथ में क्या चाहिए आपको, प्लस यू विल सी LFT will be doubled. So when we start treatment we start when LFT is increased by more than 2-fold, right? And you can see viral load 2 to 10 to the power 4 or more, and in early cases and late cases 2 to 10 to the power 3. In that case we start any one of the drug. We have tenofovir or we use entecavir. So entecavir is 0.5 mg. Tenofovir we have 2 option available. Tenofovir like we can use 300 mg, and we also have like 25 mg of tenofovir. That is nowadays we preferred. So एक अल्फामाइड करके आती है tenofovir अल्फामाइड, so that we can use. So lamivudine दोगे नहीं दोगे, pyrrole interferon no. So what we recommend, tenofovir for more than 40 weeks. Simple. So any one you have to go. इन दोनों में से कोई एक देना है आपको. Coming to next one. 68-year-old patient who is suspected to be suffering from infective endocarditis. Evaluate under Duke's criteria. Following is not included. Intracardiac oscillatory vegetation on 2D echo. This is the major criteria. ये तो है. Not पूछा आपसे. At least one culture positive for IgG titer more than 1:800 for a Coxiella. ये भी true है. This is also a true statement. So it is not the answer. So this is true. Partial dehiscence on 2D echo. ये भी echo finding होती है, ये भी true है. At least more than or equal to one positive culture for typical organism causing infective endocarditis. ये true है कि नहीं है? At least 2 होने चाहिए, not 1. So it is a false statement. Clear? This is a false statement. ये तीनों आंसर correct है. समझ आए? So this is true, this is true, this is true. They are asking you. Following is not included. So क्या included नहीं है? This is not included. So answer for this question will be D. We need at least 2 positive cultures. So let us see this. You can see positive histological culture. Then you can see major criteria 2 positive culture. यहाँ पर 1 दिया था उसमें. Then you can see Coxiella की serology positive है. This was given. In echo you will see dehiscence, or you can see vegetation, abscess, or any knee regurgitation. So you can see यहाँ पर क्या दिया? You can see here. You can see dehiscence is given and vegetation is given. So answer will be D. 59-year-old a man present to medicine OPD with chief complaint of frequent episode of bone pain, high fever, fatigue. Order various lab tests which reveals calcium 12, calcium बढ़ा हुआ है, hemoglobin 8.4, anemia है. Serum electrophoresis report patient is given below. Following statements correct with respect to most probable diagnosis. So you can see hypercalcemia, renal involvement, anemia, and bone features. So CRAF features, these are features of multiple myeloma. Then you can see this is called Child-Spire pattern. So अगर आप देखोगे first spike is of albumin, then second spike you can see in IgG area. Gamma area means IgG area. This spike is called M spike. So M spike दिखी हुई है, classical case है multiple myeloma का. So they're asking you what is incorrect about multiple myeloma. So what is incorrect? Let's see. Flow cytometry of this patient can be positive for CD 138 or 38. Yes, it's a plasma cell disorder. So flow cytometry 138 38 के लिए positive होगी, 90 20 के लिए negative होगी. Clonal plasma cells more than 10% can be used as one of the diagnostic criteria. Yes, clonal plasma cell 10% से ज़्यादा होने चाहिए. This is true. This is true. Primary amyloidosis is most common cause of renal failure in these patients. No. Most common cause of kidney failure in these patients is hypercalcemia. Amyloidosis नहीं होता. So this is a false statement. Beta macroglobulin levels are used to assess a median survival period. So in these patients, yes. So international prognostic index के हिसाब से we use this beta macroglobulin level. So ये भी क्या है? ये भी true statement. Now they are asking you, statement is incorrect. So C is incorrect. So that will be the answer. Cause of renal failure will be hypercalcemia. So this was our discussion. I hope you enjoyed this. Thank you so much. Keep working hard. Bye bye.
Alright, hi guys, I hope you have appeared for computer-based offline test 5, and in that there were 13 pharmacology question. The detailed discussion or the detailed description of all these question will be given to you in a form of handbook, but here we are quickly going to analyze all those questions and we'll understand what is the correct answer for this and what is the reason behind that correct answer. The very first question that we are having is choose the correct option about this image. So whenever you see this image, this is one of the question that is influenced by previous year NICT question only. So whenever a drug is acting at the receptor and there is a maximal activity, we call it as a agonist, and when there is a submaximal activity, we call it as a partial agonist. Next that we are having is antagonist if there is no intrinsic activity. Antagonist मतलब ये occupy करेगा site को, it will occupy the site but will not produce any activity, and if something is going to produce opposite action, we call them as a inverse agonist. ठीक है. So these are the different type. Now whenever you are going to look at this, number 3 is agonist, right? So if you already know number 3 is agonist, then look for agonist किसके साथ है. So number 3 is agonist is available with one option. बाकी किसी में number 3 के साथ agonist नहीं है. So देखिए आसानी से क्वेश्चन निकल के, now you can cross check as well. 4 is partial agonist, so 4 is partial agonist. Antagonist 1 is antagonist, 1 is antagonist. So most likely C is the correct answer. Very easily we have got this one. In the upcoming examination, what is the potential MCQ? The potential MCQ, they can give you which of the following drug can produce this kind of response. That means inverse agonist. So a very good example of inverse agonist that we know is known as your beta carbolene, that happens to be inverse agonist of benzodiazepine receptor. Apart from that, H3 receptor का inverse receptor होता है, H3 का inverse agonist, that is known as your tiprolisant. They will increase the wakefulness, can be utilized in narcolepsy, and other one is a pitolisant. So please do not forget, very soon you might see this drug in your examination, tiprolisant and pitolisant. Okay? In which phase of clinical trial efficacy of the drug is confirmed? So confirmatory trial, whenever they use the term confirmation, confirmatory trial is none other than your phase 3. है ना? Determination of efficacy, they will determine efficacy. They are going to determine the efficacy. Phase 3 is going to confirm the efficacy. And do you know that the other name of phase 3 itself is a confirmatory trial? Phase 3 का दूसरा नाम ही होता है confirmatory trial. Phase 3 का other name itself is a confirmatory trial. Phase 4 actually is PMS. What is PMS, guys? PMS is post-marketing surveillance. This is done once the drug is launched in the market. Phase 0 is one of the microdosing study. It is a non-mandatory trial, microdosing study. It is going to do pharmacokinetic analysis. After giving a microdose, the drug will be radiolabeled and it will be followed inside the body to check it out whether the first pass metabolism is so high or how much is the absorption. Okay? Next is about a 42-year-old diabetic female was on regular insulin. ठीक है. So regular insulin currently according to New Goodman-Gilman, they are classified still under the short acting. पहले जो था वो ultra short, long, intermediate ऐसे था, but now they have classified just into short acting, long acting, and in the last they are saying कि when we combine two insulin, of NPH, we call them as an intermediate acting. ठीक है, तो again that we have discussed in our detailed discussion, but here regular insulin is a short, they are the IV insulin, okay, was added with Afrezza. So Afrezza is the new insulin, we already know. And what is the route of Afrezza? So Afrezza is given by the inhalational route. Now whenever we are going to give via the inhalational route, the response is not coming directly for the respiratory system. The response is coming systemically. They are trying to reduce the glucose level. That means there is a systemic absorption, right? So they are subcutaneous? No, not at all. Subcutaneous injections they ही नहीं रहे. They are the intranasal, है ना? They are intranasal. They are transdermal. Transdermal patch तो है नहीं ना? They are not patch. IV भी नहीं है ना? तो I think they are intranasal. That is again one of the I would say inhalational है, that will come classified under the systemic route, है ना? Systemic route में आएगा. So intranasal route से देते हैं Afrezza. You already know. इसके जो कैटरेजेस होते हैं, that is blue, green and yellow, and ये कलर कोडेड जो कैटरेज होते हैं, इसमें इंसुलिन होता है 4 यूनिट, 8 यूनिट, 4, 8, 12 यूनिट. ठीक है, तो कलर कोडेड इंसुलिन, कलर कोडेड कैटरेज होते हैं, उसमें अलग अलग यूनिट ऑफ इंसुलिन मिलते हैं. ठीक है, 4, 8, 12. रिमेंबर द Afrezza alone they are not going to be effective. Afrezza as an inhalational insulin alone they are not effective. We never start them alone. We are going to give them as an adjunct with the other insulin. So whenever we are going to give them as an adjunct or as an add-on insulin, we always try to reduce the dose of the original insulin or the parent insulin का dose को थोड़ा कम करके then we introduce this one. ठीक है, so this is your Afrezza. We avoid them in a patient with the COPD, of course, है ना? They have shown to increase the risk of precipitation. Apart from that, smoking भी avoid करते हैं, या अगर कोई chronic smoker है उसमें भी avoid करते हैं. You are a doctor working in a PSC in a remote village. A female presents to you with her 3-year-old child in a comatose state. Okay, the pupils were dilated. Okay, on examination pupils were dilated. So dilated pupil, that means कुछ बढ़ा हुआ है ना? Skin dry, heart rate is high, heart rate भी बढ़ा हुआ है. Everything is on top. So whenever I say everything is on top, body temperature on top, ठीक है, body temperature on top, pupil size on the top, heart rate is on top. His mother show you the fruit that he found. Even if they do not show this image, in which type of poisoning everything will be on the top. तो इसको क्या बोलते हैं? एट्रोपिन, है ना? मैं जानबूझ के इसको एटोपिन लिखता हूँ, है ना? एटोपिन, एट्रोपिन. That means everything will be on the top in the atropine poisoning, especially with respect to eyes, with respect to your body temperature, with respect to your heart rate. They will be on the top. And atropine is derived from Atropa belladonna. So maybe this could be a fruit of Atropa belladonna. And they are telling you ki what is the definitive drug of choice. So definitive drug of choice that we are having is going to be your physostigmine. Physostigmine is the drug of choice for atropine poisoning. ठीक है. Oximes are mainly utilized. They are utilized as acetylcholine esterase reactivator. So after organophosphate poisoning, when we treat them with the atropine, after atropine introduction, we can utilize oximes. ठीक है. Next is about a 18-year-old girl went for dance competition outside India. Since it was her first competition, she was feeling anxious. Pulse rate is 140. Okay. Okay. So sweating, feeling like she should quit the competition. So I think feeling anxious, and she has a stage performance. So possibly this is going to be a performance anxiety. They are possibly trying to tell you about performance anxiety. Now let's read further. क्या बोलता है? She should quit the competition, now go back to her country without giving the performance. On knowing about the same, her dance teacher took her to a physician nearby. Which of the following drug can be given orally to release her anxiety? So for the performance anxiety, the drug of choice is none other than your propranolol. I think ये तो बड़ा आसान था. Tamsulosin happens to be the drug of choice in a patient with a BPH. Why will you give tamsulosin to this 18-year-old child? And they are the 5-HT1A antagonist. Isoprenaline, they are the beta-1, beta-2 agonist. They will further increase the heart rate. ठीक है. Dobutamine, they are the beta-1 agonist. Dobutamine is beta-1 agonist. ठीक है. That can be utilized in a patient with the acute heart failure. Acute heart failure. ठीक है. Which anti-glaucoma drug causes the given ocular manifestation? Now this is possibly a case of cornea verticillata, This is mainly we used to teach can be associated with the drugs like your chloroquine or hydroxychloroquine. Also, we used to teach that they are associated with the amiodarone. There are few reports that are saying that this one can also be associated with the nitarsodil, one of the Rho kinase inhibitor. One of the Rho kinase inhibitor. Pilocarpine as a drug, remember guys, they are the M3 agonist. They can be associated with problem like broache, frontal headache because of the ciliary muscle spasm. M3 receptor is also present on the ciliary muscle. They can cause broache as a problem. Apart from that, this M3 agonist, pilocarpine that we know, they can also lead to a condition called pseudomyopia. Why pseudomyopia? Because again, their ciliary muscle contraction will lead to zonule relaxation and the lens will become more globular. Okay, apraclonidine, brimonidine, they will not have this kind of side effect. They can cause side effect like sedation, apnea, drowsiness. They will be associated with side effect like sedation, drowsiness, apnea. This explains the reason why we are not using apraclonidine, brimonidine in pediatric and elderly population. Latanoprost, it's one of the PGF2 alpha analog. And if you have attended my class before, I used to tell you that PGF2 alpha analog ka side effect itself is PGF2 alpha. And they are very, very easy to remember because P stands for your pigmentation of iris. Pigmentation of iris. So, sometimes they call it as a heterochromia iridis. Hetero means the two eyes will have different colors. So, hetero. Or in whichever eye we are giving, the iris color will be little on the darker side. So, we call them hyperchromic iritis. Again, the same thing. Pigmentation of iris, heterochromia iridis. Then they can even lead to growth of eyelashes, जिसको बोलते हैं hypertrichosis. They can also cause problem like your foreign body sensation. Foreign body sensation. Fat atrophy of the orbit. Because of the fat atrophy of the orbit, there is going to be enophthalmos. There is going to be enophthalmos. Enophthalmos मतलब eyeball अंदर की तरफ चला जाएगा. And they can also lead to condition like acute uveitis. Acute uveitis. ठीक है. Which of the following inhibits granulocyte migration? So, chemotaxis granulocyte migration. Only drug that we are having here is colchicine. Celecoxib is a COX-2 inhibitor. They are the selective COX-2 inhibitor. Allopurinol, it's a xanthine oxidase inhibitor. Adalimumab, it's one of the TNF alpha inhibitor. TNF alpha inhibitor. Granulocyte migration को inhibit करने के लिए colchicine है. Colchicine is a drug that can be utilized in a resistant case of acute gout. That means a gout non-responsive to NSAID and steroid. है ना? They are associated with side effect like bone marrow suppression. GI side effect सबसे common होता है. Nausea, vomiting, diarrhea, abdominal pain. है ना? Bone marrow suppression can also lead to problem like hypersensitivity reaction. So chemotaxis is the mechanism of action through which colchicine work, and they are having 3-4 other mechanisms as well. About a 26-year-old female presented to emergency with injury after a road traffic accident. In the hospital, she developed seizure. To rule out the cause, a CT scan was done which suggested cerebral edema. So, they are asking which of the following diuretic is used in cerebral edema. So, in diuretic, we only one diuretic that we teach that can be utilized in cerebral edema, especially in cases like this, like trauma, that will be mannitol, one of the osmotic diuretic. This was a straightforward question, right, guys. All of the following are class 1B antiarrhythmic drug except. What did I tell you about 1B? 1B, B for brave. They are the brave group of people, and they say that I am so brave that they all like to phone me. Remember the story of the kingdom? A grade, B grade is the brave grade, and C grade, those who are doing all the cleaning work of the kingdom. So, like to phone me. Like to phone me is going to be drug like your lidocaine, tocainite, phenytoin, and me for maxilitine. So, they always say that I am so brave that they all like to phone me. So, one anti-epileptic that is having anti-arrhythmic property, phenytoin. So, all of the following are 1B except procainamide. I told you A grade people are queen, prince and dasi. So, procainamide kya hai? It is class 1A. Lidocaine, lignocaine, that is 1B, tocainite, phenytoin, they are all 1B. So, the only answer here is going to be, let's quickly recap. 1A wala, so I told you A grade people in the kingdom will be queen, prince and dasi, quinidine, procainamide, disopyramide. B, the brave one, those who are taking care of the kingdom, that is going to be like to phone me. And then there is C grade in the same kingdom, those who are doing all the cleaning works, that is floor per mopping, etc. Floor per mopping, etc. is flecainide, propafenol, moricigin, encainide. Which of the following is not included in the drug therapy of H. pylori associated peptic ulcer disease? So peptic ulcer disease may we utilize either triple therapy or quadruple therapy. So in that we use a PPI and we use two antibiotics out of CAM. CAM stand for your clarithromycin. CAM stand for your clarithromycin, amoxicillin and metronidazole. ठीक है. So अगर देखा जाए तो pantoprazole definitely is a PPI, can be utilized. Domperidone, the D2 blocker. Clarithromycin, amoxicillin is a part. So domperidone का तो कोई रोल नहीं है, it's a prokinetic agent, है ना, that can be utilized for the treatment of prokinetic effect and also for the vomiting we use. All of the following antimicrobial agent binds to 50 years subunit except. So I used to tell you that if you're getting stuck at 30s at मतलब aminoglycoside and tetracycline getting stuck at 30s, and if you want to target 50s, they are 30s inhibitor getting stuck at 30s aminoglycoside tetracycline, and if you want to target 50s, then I should tell you line से MCQ करो, this stand for linezolid, macrolide, that is having drug like erythromycin, azithromycin, clarithromycin, clindamycin. Then we are having other like your quinprestin, and dalfoprestin. Caro will be your chloramphenicol. So this will be your line say MCQ Caro. So we are having chloramphenicol, that is a 50s inhibitor, clindamycin and linezolid also. Doxycycline is a tetracycline, that is one of the 30s inhibitor. Which of the following antimicrobial agent dose adjustment is not required in case of renal failure patient? A case like this is very less likely to be asked. There can be cases like this. In that option A will be, है ना, let's say drug like your doxy, option A कैसे कह सकता है, doxy, ceftriaxone, clarithromycin, है ना. So there are chances there will be case like this. Option B, there will be 3 drug combination. Option C, there will be 3 drug combination. Option D, the 3 drug combination. Cases like this could be or commonly seen in USMLE pattern cases, है ना? But you never know what is the mindset of the examiner. In upcoming examination there can be, है ना? But if given this kind of scenario, this is going to be really not easy, I would say. So dose adjustment is not required in renal failure. That means they are asking which drug is excreted via the hepatic route, excreted hepatically or excreted via the biliary secretion, So definitely we know doxycycline is yes, ceftriaxone yes, that is why ceftriaxone is also associated with the pseudocholedithiasis. Biliary sludge syndrome is the condition that we call. Amoxiclarithrosephem, they are all excreted via renal route. Erythromycin also could be, है ना, बाकी सारे के सारे हैं, they are excreted via the renal route only. So I think we could go with the 1, 2, 7, 8, 9, 10, 1, 2, 7. D is the correct answer, most likely correct answer. But as I told you that this type of question is they are having very lesser chances that they will be asking this type of question. Which of the following alkylating agent causes both hemorrhagic cystitis and pulmonary fibrosis as a side effect? Hemorrhagic cystitis. So hemorrhagic cystitis जब भी word आता है, we always think about cyclophosphamide, and cyclophosphamide has also been associated with the pulmonary fibrosis. So इसका एक मेटाबोलाइट होता है. One of the metabolite is known as your acrolein. Acrolein is toxic to the bladder and they can cause hemorrhagic cystitis, and to prevent this one we run an infusion of mesna, IV mesna is what we run. ठीक है. So this was your 13 question for pharmacology. I hope most of the question you got correct. And I'm pretty sure एक दो गलत भी हुआ होगा, एक दो सिली मिस्टेक भी हुआ होगा, but again अगर 10 से ऊपर अगर आ रहे हैं तो very good, you are doing good. Just keep revising. I'll see you in my upcoming class. Thank you very much.
Hello everyone. Let's discuss the forensic question of our CBoT examination. I'm your Forensic Faculty Dr. Sumit Tellewar. Let's take up our first question. Our first question is, a 15-year-old boy was brought to the emergency with history of ingestion of oil of vitriol 2 hours ago. So an important information is given that there is ingestion of oil of vitriol 2 hours ago, and this is a boy of 15 years of age. Which of the following is incorrect about the management of this patient, right? So the first thing that we need to highlight in the question is, what is oil of vitriol? Oil of vitriol is another name for sulfuric acid, and we know sulfuric acid is the most potent, most strong mineral acid, right? And if there is an ingestion of sulfuric acid, there is bound to be heavy corrosion in the digestive tract, starting from the mouth itself, involving the esophagus, the stomach, and everything. Because sulfuric acid is very, very strong, one thing which is definitely contraindicated in the sulfuric acid poisoning is attempting to neutralize the pH of strong sulfuric acid with a base. Okay, because if you are going to give a very strong base into the stomach, there is going to be an exothermic reaction, a huge exothermic reaction in the stomach, and the stomach wall can perforate, which itself can happen with the sulfuric acid ingestion only, but then we don't want to induce it, right? So if you see option number 1, neutralization with base, it's an absolute non-choice, that we don't need to neutralize sulfuric acid with giving a very strong base. So correct option here is option A, that we do not try to neutralize sulfuric acid. So if you see that what can we do in acute emergencies, we can give very mild bases, but definitely not attempting to neutralize the strength of sulfuric acid. The mainstay of the treatment is demulcent. It coats the stomach membrane and delays the further absorption and acts as a barrier. Yes, endoscopy can be done in the initial hours, up till 4 days of acid ingestion, but not beyond it, because there is huge risks of stricture formations. And chest X-ray, PA view, yes, that may be a required investigation to see if there is any kind of perforation anywhere else. So all other statements are absolutely correct. They may be utilized during the therapy of the patient, but attempting to neutralize is absolutely not a choice. The second very important thing that we need to remember about sulfuric acid poisoning, time and again we keep on repeating it over and over again in our lectures, और हम इसको मेमोराइज भी काफ़ी अच्छी तरीके से करते हैं. वो चीज़ क्या है? Sulfuric acid poisoning is a situation which is an absolute contraindication for gastric lavage. Okay, so remember, this is a situation which is absolute contraindication for gastric lavage. The reason is same. अगर सल्फ्यूरिक एसिड की इंजेक्शन से स्टमक वॉल की थिनिंग होती है और अभी तक स्टमक वॉल परफोरेशन नहीं हुई है, हम गैस्ट्रिक लवाज ट्यूब इंजेस्ट करके वो परफोरेशन कर सकते हैं. सो सल्फ्यूरिक एसिड के केस में गैस्ट्रिक लवाज नहीं करना है. लेट्स टेक अप आवर सेकंड क्वेश्चन. क्वेश्चन में हमें एक ग्राफ दिया हुआ है एंड द क्वेश्चन सेज एनालाइज द ग्राफ given below. Which curve represents the post-mortem lividity changes? The answers are red line, yellow line, blue line, or green line. Okay, so in the question, it is being talked about post-mortem lividity. What is postmortem lividity? Postmortem lividity is postmortem staining. Is postmortem staining, also called as PMS, also called as hypostasis, also called as vibesis, also called as darkening of death, and also called as livor mortis, right? So postmortem staining के बहुत सारे synonymous name है. The question is very simple. Which graph represents postmortem lividity? Okay. To understand this question, let's try and draw all the postmortem changes, the common ones, and let's see उनका graphical representation किस तरीके से होगा. So commonly what do? We simply draw an x-axis and a y-axis, right? y-axis में x-axis में time है और y-axis में duration है. So duration नहीं है, y-axis में magnitude होगा change का. So अगर हम सबसे पहली बात करें, a very prominent graph that we observe is graph of post-mortem cooling, also known as alger mortis, right? So अगर ये time है तो this is 0 hour, यानी कि right at the time of death the temperatures of the body are high, close to 37 degrees. So at 0 hours we will find that post-mortem cooling will start from a higher temperature. What will happen then? वो धीरे धीरे over a period of time नीचे आना चालू होता है, right? Having the phase 1, phase 2 of the curve and phase 3 of the curve. ये तीनों phases हम अपने classes में पढ़ते हैं. So this is phase 1, then it starts to decline, which is phase 2, and then it keeps on coming down, and then after a while it plateaus again, which is called as phase 3. So this is an ideal graph of post-mortem cooling, which is a sigmoidal shaped graph, as you can see, or an inverted S shaped curve, right? दूसरा जो हम देखने वाले हैं वो important curve कौन सा है? That is about rigor mortis. So rigor mortis is something which does not start right after death. Okay, so we are going to observe building of rigor mortis few hours after death, which means it will start to build up somewhere from here. And the rigor mortis builds up. It keeps on going with increasing time, right? And then after a while it peaks up, and after peaking it starts to come down. So when it starts to come down, a time comes when it is completely gone. So it will originate from x-axis and it will come back to the x-axis itself. This is the graph of rigor mortis, right? Which is basically a parabola. Third thing that we need to see is post-mortem staining, जो हमसे question में भी पूछा हुआ है. Now post-mortem staining is also something which begins around rigor mortis and it keeps on getting more and more as the post-mortem staining keeps on building more and more in the dependent portion of the body. Then when it has built up enough, it doesn't really go down. So when it is built up enough, it just stays like this till the time the decomposition of the body starts and the outer discoloration, that is the blackening of the body at the time of decomposition, starts. So it kind of camouflages the appearance of the rigor mortis. Rigor mortis उस external blackening में थोड़ी छुप जाती है. So with increasing decomposition, the rigor mortis may just post-mortem staining may just be seen going little bit down, but वो कभी खत्म नहीं होगी, तो वो x axis पे दोबारा नहीं पहुंचेगी. Okay? और चौथी चीज क्या है? चौथी चीज है the decomposition of the putrefaction itself. And again, the putrefaction will start somewhere around the time of when enough time has elapsed. हम अपनी classes में पढ़ते हैं generally the first sign of external sign of putrefaction is around 18 hours when the right iliac fossa discoloration is seen. Okay, तो प्यूट्रेफैक्शन कहीं यहाँ से स्टार्ट होगी और फिर ये बॉडी के डिकम्पोजिशन के साथ बढ़ती ही जाएगी. इट विल नॉट कम डाउन, इट विल कीप ऑन गोइंग अप एंड अप एंड अप. सो इस तरीके का एक लीनियर प्रोग्रेसिव ग्राफ इट सजेस्ट putrefaction, right? So the first one was alger mortis, the second one is rigor mortis, the third one is post-mortem staining, and the fourth one is putrefaction. So after this discussion, if we come back to our question and if we observe the graph given in the question itself, which graph do you see representing post-mortem lividity? It is the blue line. So correct answer here is option C, blue line, right? You can see the red line represents alger mortis. This orange line represents rigor mortis, and this green color line represents putrefaction. Okay, let's move to our next question. Cadaveric spasms may be seen in all except. Cadaveric spasm कब कब मिल सकता है और कब नहीं मिल सकता? The four choices are drowning, suicide by firearm, electrocution and traumatic asphyxia. Okay, तो सबसे पहले देखते हैं what exactly is cadaveric spasm. Cadaveric spasm is a condition where muscle of body goes into spasm, or you can say rigidity, just before death, and it remains like that after death. Okay, so रिजिडिटी तो डेथ के बाद में राइगर मोर्टिस में भी मिलती है, बट राइगर मोर्टिस डेथ के बाद एकदम से दिखाई नहीं देता. राइगर मोर्टिस विल टेक टाइम टू बिल्ड अप. अभी पिछले क्वेश्चन में भी हमने देखा राइगर मोर्टिस इज नॉट सीन एट 0 hour एट डेथ, बट कैडेवरिक स्पाज्म इज समथिंग which will be seen right at the moment of death, because just before death certain group of muscle it has gone into a rigidity phase and remains rigid at the time or after death also, which means the normal cycle of primary muscle relaxation or the normal phase of primary muscle relaxation जो muscle में first change आता after death, that phase is bypassed. We straight away see rigidity, and that's called as cadaveric spasm. Now, why this condition develops in a dead body? It does not develop in every death. So there are certain conditions where cadaveric spasm is seen very commonly, or they may develop in those kind of deaths. Let's see what are these. These are situation of death due to excitement, fear, severe pain, exhaustion, cerebral hemorrhage, firearm wound to head, drowning and strychnine poisoning. मोस्ट कॉमनली जिसके बारे में हम बात करते हैं और जहां से बार बार क्वेश्चन आता है एग्जामिनेशन में, वो ड्राउनिंग का कैडेवरिक स्पाज्म है. रिमेंबर लॉट ऑफ टाइम वी शो यू फोटोग्राफ्स ऑफ हैंड्स होल्डिंग ऑन टू वीड्स from the bottom of the sea or bottom of water source where a drowned body has been found. That's an example of cadaveric spasm, indicating that it's an antemortem death, right? So if we go back to our options, what are the situations where cadaveric spasm may not be seen? That's traumatic asphyxia. As you can see, that's traumatic asphyxia. It can be seen in drowning, it can be seen in suicide by firearm if there is a shot to head, it can be seen in electrocution, severe exhaustion of the muscles of the hand, but traumatic asphyxia is something where cadaveric spasm may not be seen. Next question. Which of the following organs of the body offers maximum resistance to electrical injury? वेरी स्ट्रेट फॉरवर्ड क्वेश्चन. हम अपनी क्लास में डेफिनेटली इस क्वेश्चन की बात करते हैं व्हेन वी टॉक अबाउट थर्मल डेथ्स एंड इलेक्ट्रिकल इंजरी, राइट. द सीक्वेंस इन विच द tissues of the body offer resistance to electricity is skin offers maximum, followed by bone, followed by fat, followed by muscles, followed by blood, right? Which means if you look at these sequence, skin is most resistant to करंट. सो गॉड ने हमारी बॉडी को भी ऐसे ही बनाया है, जो सबसे आउटर मोस्ट लेयर है हमारी बॉडी की, वो ही करंट को सबसे ज्यादा रेजिस्ट नॉर्मली करती है, राइट. एंड ब्लड, if you'll see, is the last in the list, which means it is the best conductor of current in the body, because resistance सबसे कम है, which means it will be conducting the current best. So after reading this kind of a flow chart, what do we see? The option is option C, skin is the maximum resisting tissue of the body for electrical injury. Next question. A 45-year-old chronic alcoholic became agitated following abstinence from alcohol. So one important thing which is given in the question itself is abstinence from alcohol, and he is abstaining from alcohol for last 3 days. Last 3 days means close to 72 hours. Okay. He developed tremors, confusion, delirium, and disorientation to time, place, and person. He can hear the voices of his late mother, who died 6 months back. Okay, these kind of things are called as horror hallucinations. Hearing the voices of dead, seeing somebody who is dead, horror hallucinations. Okay, so he's having horror auditory hallucinations. What is the drug of choice for the above condition? See, the first thing that we need to see here is what is the condition, what is the emergency that has precipitated in this person. The emergency is called as delirium tremens, right? The emergency is called as delirium tremens, right? Delirium tremens is a condition that often precipitates in people who are chronic alcoholic, number of years or history of number of years of alcohol intake, and then suddenly they stop taking alcohol, and it typically precipitates 48 to 72 hours later. So 2 to 3 days is the precipitating time. What happens in delirium tremens? The situation or the symptoms, those has been written: tremors, confusion, delirium, disorientation, horror hallucinations. One important thing to remember in case of delirium tremens is the person becomes violent. He can hit other people who are trying to calm him down. So it's a situation which is well attached to violence, right? And in this situation of agitated behavior, confusion, many people kill themselves also. So it is well known for committing suicides also. Okay, so remember, suicides are committed, and when I say the person becomes violent, what can it lead to? It can lead to attack on others. He can attack other people and injure other people. This is called as delirium tremens. Okay, so it's a very important situation where the person has to be calmed down, where needs to be taken care of as soon as possible, and the best choice of drugs are benzodiazepines, preferably long acting benzodiazepines. And once the delirium tremens has precipitated in that person, the fastest acting methodology would be giving him an IV benzodiazepine. So correct option here is option C, right? And once the person is calm after IV benzodiazepine, later on you can put the patient on oral long-acting benzodiazepines like diazepam or chlordiazepoxide. But to take care of the acute emergency situation, an IV drug would be preferred. Okay, a 19-year-old girl visited the OBG department for pain in her genitalia. On examination, she reveals that last night she had sexual intercourse with her boyfriend. The doctor found some contused abrasions with minor lacerations around the genitalia. The doctor also observes and documents that the hymen is relaxed and intact. This is a case of. The options are rape, medical negligence, true virgin, or false virgin. Okay, the first thing is age of the girl is 19 years and she has had sexual intercourse with her boyfriend, which means she had a consensual sexual intercourse, and because her age is more than 18, it does not amount to rape. It does not amount to rape, right? So rape as a choice is automatically out of the window, right? uh, the doctor has examined the female and observed what are the clinical findings in her and has noted down all the findings, so it doesn't look to be a case of medical negligence, right? Nothing like that has given in the question also. So what remains with us is true virgin or false virgin. Now, who is a virgin female? Normally we say it is the female who has never experienced sexual intercourse, right? What is the most expected finding in her genital examination? That her hymen will be intact. Hymen may rupture or it does rupture as early as first sexual intercourse, right? So true virgin would be a female who has never experienced sexual intercourse, and on examination her hymen would be found intact. But in this case, the female has a history of having sexual intercourse with her boyfriend, but on examination the hymen is relaxed but intact. You can see it is intact. What does it mean? It means although she has had sexual intercourse, but the hymen is still intact, which is giving a false sign that she may be a virgin, right? These kind of females are called as false virgin. So correct choice here is false virgin. Okay, so let's see what other examination findings can we see in cases of false virgins. So this table gives us the findings in cases of false virgin. So if you look at hymen in both the cases, that is true virgin or false virgin, in true virgin the hymen is intact, elastic, covering the vaginal opening. The edges of the hymen are distinct and regular. Okay, whereas in false virgin, the female who has had sexual intercourse but the hymen is intact. So intact hymen is found in this setting also, but the hymen is little less elastic, it is relaxed, The edges may be found rough and thick because of repeated penile penetration through that relaxed hymen, and 1 to 2 finger penetration may be possible through that intact hymen into the vaginal cavity. Clitoris is small in true virgin. It will be enlarged in false virgin. Fossa navicularis will be intact in true virgin, and it would have disappeared after sexual intercourse in false virgin. Okay, vaginal walls in true virgin, they are opposed vaginal walls, collapsed vaginal walls होंगी, उसमें स्पेस नहीं होगा, रूमी नहीं होगी. So rugosities will be very prominent. इनको बोलते हैं रूगेज. So vaginal wall के रूगे जो होंगे वो बहुत prominent होंगे. So vaginal walls will be rugose. Walls are opposed, narrow cavity. Whereas what will be seen in false virgin, very roomy vaginal wall. Okay, breast firm and non-pendulous in true virgins because they have not yet experienced in sexual intercourse, and we are expecting to see large and flabby breast in cases of false virgin. So these are some very important clinical examination signs to differentiate between true virgin and false virgin. Very commonly हमारे examination में यहाँ से question आता है. Okay, our next question is, a dead fetus was found in a dustbin. Police started an inquest and along with the inquest brought the fetus to the forensic department to know the age of the fetus. On examination, the length of the fetus is seen as 25 centimeter. 25 centimeter, if you recall, rule of Haas, according to rule of Haas, the 25 centimeter fetus would be 5 months of intrauterine life, right? 5 का square 25 और 25 का under root 5. In the first 5 months, the length of the fetus is square of the number of months. Okay. Which of the following statement is true regarding this fetus? So let's read all the statements. The first statement is the fetus was viable. It's a false statement because viability starts at 28 weeks, which is 7 months, right? The second statement is the ossification center of talus has appeared, which is again a wrong statement. This appears again at 7 months. It's an indicator of viability of the fetus itself, the ossification center for talus. The ossification center for calcaneum though appears at 5 months, right? तो अगर यहाँ पर talus की जगह calcaneum लिखा होता तो हम उस statement को right मान सकते थे. Third statement is crown to rump length is medico-legally more important than crown to heel length. It's a very correct statement, right? Because crown to rump length is from the top of the head to the bottom of the buttocks, which is a very standard length for fetus. उसके बाद में crown to heel में उसके lower limbs भी आते हैं, वहां पर length variable हो सकती है in different fetuses. So crown to rump length is more accurate, so medico-legally more important than crown to heel length. And testes was found at the external inguinal ring. ये फाइंडिंग जो होती है ये 7th to 8th मंथ की फाइंडिंग होती है. दिस फाइंडिंग अगेन इज 7th to 8th month. In fact, more towards the 8th month finding, right? So, which means the only correct statement is crown to rump length is medico-legally more important than crown to heel length. This question is all about understanding different changes that happens in the body of the fetus. So हमें रूल ऑफ हैस भी पता रखना है, हमें ये भी पता रखना है कि कौन से इंपॉर्टेंट ऑसिफिकेशन सेंटर्स हैं बॉडी में, वो किस टाइम पे आते हैं, ताकि हम इंट्रायूट्राइन फीटसेस और या इंट्रायूट्राइन डेथ में फीटल की जेस्टेशनल एजिंग कर पाएँ. और डिफरेंट टाइम पे नेल्स की ग्रोथ कैसी होती है, एक्सटर्नल चीज़ें जो हमें आराम से दिखती हैं, टेस्टिकुलर डिसेंट किस तरीके से होता है, राइट? तो ये सारी चीज़ें देखते हुए क्वेश्चंस हमारे एग्जामिनेशन में फीटस के एजिंग पे आते हैं, और ये सारी चीज़ें हम अपने क्लासरूम में कवर करते हैं. राइट, आगे चलते हैं. While recording evidence in court of law, the lawyer asked the witness, "Did you see that Mr. A killed Mr. B?" This type of question is permitted in. Okay, this type of question is permitted in. The options are examination in chief, cross examination, re examination, या direct examination. The correct answer is cross examination, because if you read the question says, "Did you see that Mr. A killed Mr. B?" It's a leading question. Leading questions are commonly asked in cross examination, right? And who is the cross examining lawyer? By defense lawyer to prosecution witness, राइट. तो प्रोसिक्यूशन का विटनेस है तो उसको क्रॉस एग्जामिनेशन डिफेंस लॉयर करेगा और डिफेंस लॉयर क्रॉस एग्जामिनिंग करते समय उससे लीडिंग क्वेश्चन पूछेगा एंड लीडिंग क्वेश्चन का आंसर यस या नो में ही हो सकता है. द विटनेस विल बी बाउंड टू आंसर इन यस और नो. So that's the idea of asking the question, that do students know that cross examination is the time period when leading questions are asked by the lawyer of the opposition to the witness of the opposition. Right. With that, we come to the end of discussion of all the questions in CBoT. Stay tuned for the next one. I'll meet you again. Till then, जम के पढ़ाई करते रहिए.
Hi everyone, welcome to this anatomy discussion for CBoT 5. I am Dr. Ankit, your anatomy faculty. Here is the first MCQ. A 27-year-old patient presents with a foot drop following the trauma to the anterior leg, okay, front of leg and foot drop. On examination, there is weakness in ankle dorsiflexion. Ankle dorsiflexion. Dorsiflexion is same as our extension. So it is same meaning of foot drop. Foot drop, just recognize if this is the foot, this is the foot drop. So inability to do dorsiflexion is same as foot drop. So weakness in ankle dorsiflexion and toe extension. The patient also reports numbness between the first and second toes. So there is also some sensory issue between first and second toes. Which nerve is most likely injured? Fair enough. So here we are dealing with a problem, a motor problem, that is foot drop. Okay, foot drop. That also represents the same thing. What is that? That is, there is weakness in ankle dorsiflexion or ankle extension. So these are the motor findings. The sensory finding over here is that there is numbness between the first and second toes, right? Suppose this is the great toe over here with the nails over here, and that is the second toe, right? So there is some numbness at this point. Okay, the sensory supply of this area is which nerve, and which nerve will supply the muscles over here, that we have to find out. Now, weakness in ankle dorsiflexion is due to the muscles in the anterior leg. Now, leg we all know has various compartments. One of the major compartments is obviously the anterior compartment. And the nerve for the anterior compartment is which nerve? It is the deep peroneal nerve. It is the deep peroneal nerve, also known as deep fibular nerve. Deep fibular nerve. And does that also supply the sensory finding between the first and second toes? The answer is a big yes. The deep peroneal nerve, as it lies deep in the leg, it does not supply any of the skin in the leg region. But as it terminates, it then reaches slightly superficially close to the skin between the first and second toe, and there it supplies sensory as well. So going with both of these, the answer over here will be the deep peroneal or the deep fibular nerve. If you look at other options, see over here, sural nerve is only sensory. It is pure sensory, and it supplies just in some, say, lateral part of the leg and lateral part of the foot. Tibial nerve, what does it do? It supplies the posterior leg compartment, posterior leg, right? Superficial peroneal nerve supplies the lateral leg compartment. So these two nerves are the nerve for the posterior compartment, lateral compartment, and deep peroneal is for the anterior compartment. Now let us see some images over here. Here is an image showing us the main common peroneal nerve as it winds around the neck of fibula. Then you can see it divides into two main branches, a deep peroneal and a superficial peroneal nerve. This deep peroneal is going to go anteriorly and the superficial is going to go laterally. And here you can see the superficial peroneal nerve is supplying which two muscles? Peroneus longus and peroneus brevis. These are both supplied by the superficial peroneal nerve, right? And the deep peroneal supplies the anterior. Now, what are the various muscles which lie in the anterior compartment of the leg? These are all the extensor. Extensor hallucis longus. Then we have extensor digitorum longus. Then also we have a tibialis anterior. And we have one more muscle, very important one, which helps in eversion of foot, that is peroneus tertius. Remember this. These are the main four muscles which are supplied by the deep peroneal. Now see over here, this extensor hallucis longus and extensor digitorum longus, they are actually going in front of the ankle, or you can say passing deep to the extensor retinaculum. They also help in toe extension, as was given in the question, also the ankle dorsiflexion. Tibialis anterior also helps in inversion of foot and also helps in ankle dorsiflexion. So inversion and ankle dorsiflexion. So with this answers deep peroneal, let us look at a couple of more images. These are all the muscles lying in the anterior compartment of leg. You can see tibialis anterior, extensor digitorum longus, extensor hallucis longus, and one over here is the peroneus tertius. And here you can see over here, this is the deep peroneal nerve which is lying over here along with the anterior tibial artery, right? And now try to trace this nerve over here, this yellow color nerve. As you trace this nerve over here, I'm putting some blue arrows. As it reaches at its termination, then it becomes superficial and gets sensory supply between the first and second toe. This is the first toe, that is second toe, this is our third, that is the fourth, and this is the fifth toe. I hope the point is clear, right? Artery over here is anterior tibial artery. If you are still confused that, sir, what about this artery? Anterior tibial artery is nothing but a branch of which artery? It is a branch of popliteal artery. It is a branch of popliteal artery, remember that too. And as it crosses the ankle, it becomes what? It becomes the dorsalis pedis artery. This you can actually palpate. It is one of the most terminal arteries that you can palpate on the lower limb. It's very important to palpate it. Why, sir? Because if you start to palpate it, and if you can actually palpate this artery over here, then you are sure that the blood from the proximal vessels is fine. There is no obstruction over here. There is no thrombus over there. So if you get a palpating dorsalis pedis artery, you know that the blood is going okay. When the proximal, the whole vascular system is fine. The anterior tibial artery is okay, popliteal artery is okay, femoral artery is okay. Other questions come that where do we palpate this artery? I'm actually telling you what are the other questions that can come from this topic. The dorsalis pedis artery can easily be palpated between two tendons. Which are those two tendons? One tendon is this over here and one tendon is this over. Which are these tendons? This is extensor hallucis longus, this is extensor digitorum longus. Both are over here. You can see these muscles over here. The dorsalis pedis artery is palpated between these two tendons, right? You've seen the artery, you've seen the nerve, and you've seen the muscles over here. And these are the extensor retinacula. They are like the modifications of D fascia which hold the tendons. Okay. Let me show you one more image over here. This is actually a transverse section around the region of the ankle. A very good image. Why? Because it teaches us all about the compartments of the leg. Here, this area is represented anterior, this area is obviously posterior, and which will be the lateral area? This will be the lateral area, this is the medial part. You are looking around the ankle region, a transverse section. Now, if we focus over here, the anterior region, you are seeing the extensor hallucis longus, tibialis anterior, then you are seeing the extensor digitorum longus, peroneus tertius, and along with that you are seeing this nerve over here, deep peroneal nerve, right, and the anterior tibial vessels. Now these are all lying beneath the retinaculum. Now if you look at the posterior compartment, okay, in the posterior compartment there are two compartments. One is superficial, one is deep. So here you are looking at the tibialis posterior muscle, FDL, flexor digitorum longus, posterior tibial vessels, tibial nerve, right, and here you have the flexor hallucis longus. All these are posterior compartment lying deep. In the superficial you see this tendocalcaneus along with the plantaris tendon. So this dark green highlighted area is actually our what? It is our posterior compartment. It is our posterior compartment over here. Okay. And this light green is the anterior compartment. Now coming to the lateral compartment also. Lateral compartment we see these two muscles, peroneus brevis and peroneus longus. Okay. You can see the tendons over here and the various vessels. Superficial structures also we can identify over here. Like medially, if you see, the questions normally come over here that great saphenous vein is associated with which nerve? Answer is saphenous nerve. The nerve is also superficial and the vein is also superficial. Going laterally, we see this couple over here, small saphenous vein and sural nerve. They are lying laterally, and they are lying where? Posterior to lateral malleolus. Posterior to lateral malleolus. So where is lateral malleolus? This is the fibular malleolus. That is our lateral malleolus. And this is the tibial or the medial malleolus. So these two structures lie where? They lie anterior to medial malleolus. Anterior to medial malleolus. I hope the point is clear. A very good structure over here. In the center, what we are seeing? We are seeing the trochlear surface of talus. So this is articulating above with the tibia and fibula. So this over is the talus. That is the tibia. That is the fibula over here. I hope the point is clear. Okay, let's see the next question. A 25-year-old patient presents with a pain in the buttock region and experiences difficulty in walking due to weakness in hip abduction. So there is pain in the hip or the buttock region. There is obviously some pain in walking because the hip and the buttock region over here, there are anti-gravity muscles. They are very important for walking. But now the question, the examiner is specifically saying that there is weakness in hip abduction. That is the examination finding over here. Very important finding, that there is weakness in abduction. Which muscle when weakened or injured can cause these symptoms? So is there any abductor muscle which is lying in the buttock? That we have to find out. Abduction is what? See, if you look at the lower limb over here, these are the two lower limbs over here. I'll just imagine for a while. Okay. Abduction is when you move this lower limb outside, away. This movement is abduction, both the sides. Abduction. Now, how or which muscle can cause it? There has to be a muscle. There has to be a muscle which is on the lateral aspect. On the lateral aspect. Why so? The reason of this is that once this muscle contracts, it will bring close to each other. Once it brings close to each other, obviously it will pull the lower limb away. So muscle has to be on the lateral aspect and it has to cross a joint. Now, which joint it has to cross? There has to be a joint over here which this muscle has to cross. A muscle has to cross a joint. And this joint over here has to be which joint? It has to be a hip joint. So this muscle should be coming from the hip bone and should be going to the femur bone, and other condition is it should be lying laterally on both the sides to cause abduction. And obviously in the buttock region, hip bone is in the buttock region. Answer for all of this question is our gluteus medius and gluteus minimus. Mainly it is gluteus medius over here. So therefore this is the answer over here, gluteus medius. We will see how it lies laterally. A couple of things to remember. Gluteus medius is supplied by a nerve known as superior gluteal nerve. Very important. The main action of the gluteus medius or gluteus minimus is they cause abduction. Abduction at which joint? That is the whole point. They will cause abduction at the hip joint. Are they lying laterally? The answer is a big yes, they lie laterally. And if this muscle does not work, there is problem in the hip abduction. Now you might say that, sir, when there's no need to abduct the hip, normally we walk, and why in a walking process we need hip abduction? Reason is that once you take your one foot off the ground, right, the other foot which is on the ground, that side, this abductors, they come into role, they come into play, so that the one foot that is off the ground, the pelvis is stabilized in that part. And if that is not working, that brings us to a very important topic, that is a Trendelenburg's gait over. It leads to Trendelenburg's gait, which is very, very important question that is frequently asked. So gluteus medius is the answer over here. Now looking at the other options, let me tell you. Now you might argue, sir, what about this maximus? This also lies in the gluteal region. Very correct, but it does not lie exactly laterally, it lies posteriorly. And therefore it will not mainly cause abduction, it will move the whole lower limb behind posteriorly. That movement is known as extension. So it will mainly cause extension at the hip joint. Then you might wonder that, sir, is it also supplied by the superior gluteal nerve? No, it is supplied by the inferior gluteal nerve. Remember that too. Vastus lateralis over here is actually a muscle lying in the anterior thigh compartment, and it is basically causing movement at the knee joint. It causes extension at the knee. It is a part of what? It is a part of quadriceps femoris. We will see in the images. And lastly, tensor fasciae lata is a small muscle lying laterally. It inserts into your iliotibial tract. Okay, just to give you an overall idea of what is happening. Now let us see a couple of images over here. This image is showing us the muscle. Which muscle? It is the gluteus medius over here. And you might say, sir, it is lying posteriorly where? See, this bone is the femur bone. This is the iliac crest. This is the iliac crest. This whole is the outer surface, that is the gluteal surface of the ilium bone or the hip bone, right? This is the head of femur. This is anteriorly, that is posteriorly. Understand? Other things that you might wonder is this space which you are seeing over here. This is actually our greater sciatic notch, which after the ligament comes, it becomes greater sciatic foramen. This below over here is the lesser sciatic notch. And what is present over here, this bony thing over here, this is the ischial spine. This is the ischial spine. So basically we are looking at which view? Is it a posterior, anterior, lateral, medial? It is a lateral view. We are looking at a lateral view around the hip joint, showing us the gluteus medius muscle, which is supplied by the superior gluteal nerve. Now you might imagine that if this muscle contracts, it will move this whole lower limb outside abduction. Okay, now see the other muscle over here. Now previous image, focus again on this image, is the lateral view. This image over here, now this over here is the posterior view. As I told you, the gluteus maximus muscle mainly lies posteriorly. So you can see it is coming from the sacrum part also, coming from the gluteal surface also, sacrotuberous ligament also, inserts into the iliotibial tract and your gluteal tuberosity also. This whole muscle is gluteus maximus. Now, if this muscle contracts, it will not abduct the lower limb, it will move the lower limb behind. It will move the whole lower limb behind, and that is what we said, it causes extension. And that is how we rule out the answer. This image over here is the anterior view of the thigh. Here we have very important group of muscles known as quadriceps femoris. Quadriceps femoris have 4 muscles. One is vasti lateralis, one is vasti medialis, one is vasti intermedius, and the fourth one is rectus femoris. They all actually reach the patella, and from patella they will form a ligament that will go to the tibia. So basically these muscles are crossing which joint? They are crossing mainly the knee joint. So they cause extension at the knee. Nothing to do with abduction. If you want to trace the muscles over here, here is our vastus lateralis. On the middle side, vastus medialis. This is rectus femoris. Now you might argue, sir, where is vastus intermedius? The point which you need to remember is that this vastus intermedius, it lies where? It lies deep. To which muscle? Deep to rectus femoris. So once you cut the rectus femoris, if you cut the rectus femoris from these 2 areas, we remove this part over here, right? Deep to it, you will see the vastus intermedius, right? Fair enough. Let's see the next question over here. A 3-month-old child has a congenital malformation characterized by a fistula. 3-month child, so some congenital issue, had a fistula. Fistula has an opening extending from the tonsillar area inside to the lateral neck. So there is a fistula from the tonsillar area inside to the lateral neck. There is a fistula. There is an opening. This condition most likely occurs due to persistent structure derived from which pharyngeal structure? So in the whole question, we recognize that the question is basically from the embryology topic, embryology of head and neck, which is the pharyngeal arches. Now they are asking, there is a fistula. There is a fistula. Fistula is actually a opening. Okay, an opening from 2 surfaces, outside to inside. There is an opening. There is a tract which has been formed. Now from opening is from where to where? Inside you have the tonsillar area, and outside obviously we have the lateral neck area, right? This fistula. Now they are asking, okay, fine, but theoretically can you tell it is due to a persistent structure from which pharyngeal structure? For that, the specific thing over here, now listen carefully, is the tonsillar area. Neck, they have said lateral neck, so there's nothing specific over here. Though we know that the second pharyngeal arch, it comes down and it covers everything. So it is giving us a hint that, okay, it might be the second arch, but tonsillar area is a specific term. Now this tonsillar area, if you remember the pharyngeal arches, I will show you. It is derived from the second endodermal pouch. The second endodermal pouch over here, which is basically endodermal of a second pharyngeal pouch. So there is a tract from inside second pouch or outside lateral neck, which is also second. So everything is second, and second answer has to be the second cleft over here. Try to understand. Now look at a couple of images for clarification. Look at this image. Now this image is what? It's nothing but a coronal section, right? It is a coronal section like this through the developing neck region. If you look at the coronal section, the inside areas are actually the endoderm, the outside areas are the ectoderm, and between you have the mesoderm or the mesenchyme. And if you combine all of this, it forms one arch. This is one arch, that is second arch, this is third arch, this is fourth arch, this is sixth arch. So there's 6 arches. Number are 6, but total 5 arches are there. 1, 2, 3, 4, 6. Fifth is actually missing. Now if you see the developing site over here, if you move to the right hand side, this image, you will see that the arches were 5 in number. But let me just clarify one more thing. Where these arches meet, suppose this is first, second, third, fourth and sixth. Where these arches meet on inside, this is known as pouch, as this is endodermal. So if I show you my 5 fingers over here, how many gaps are between these 5 fingers? 4 gaps are there. 1, 2, 3 and 4. So there are 5 arches. So how many endodermal pouches or ectodermal cleft would be there? 4 only. Here is number 1 over here. This is number 2, this is number 3, this is number 4. So 4 pouches are there. Now in this image, if you look at what is derived from these pouches, we can understand here also the numbers are given 1, 2, 3, 4 for the pouches. And here on the left hand side of this image, the derivatives are shown. First pouch, if I show over here, what is coming? External or the inside is the auditory tube, not the external over here, because external will be outside. So first pouch is giving rise to auditory tube. This is the eustachian tube and also the middle ear. So let me add over here. This is also forming the middle ear, also represented by the tympanic cavity, but in simpler words we can say middle ear. So first pouch is giving rise to middle ear and auditory tube. The second pouch over here giving rise to this tonsillar. That was the one that was asked in the question, tonsillar area. The third pouch over here is giving rise to what? It is giving rise to the inferior parathyroid and the thymus over here. The fourth pouch giving rise to what? Superior parathyroid and the ultimobranchial. So what is this ultimobranchial? Gives rise to C cells of thyroid gland. C cells of thyroid gland. So if I just start to number over here as well, this is number 1, 1 pouch. This is number 2 pouch. This is number 3, both thymus and inferior parathyroid. This is number 4, both superior. So here the fistula was going from where? Fistula was going, if I try to make a fistula, from this tonsillar area outside. So there is this fistula that has been developed. So it is problem in the second cleft. Let me show you one more final image over here to show you all these fistulas being developed over here. Now here what we realize is these region of the lateral cervical cyst and fistula, they are opening on the lateral side of neck. The positioning can be varied over here. Why varied? Understand why? Because you can see over here in this area, if you see, you realize that the second arch has gone down and it is spreading throughout. So it can be varied. So now if you see over here and if you look on the right hand side of this image, you will realize internal branchial fistula where it is opening in the second pouch. What was it giving rise to? It was giving rise to the tonsillar area, palatine tonsil. And you can see this cyst and therefore it is coming out and out. As it will open into the neck, there will be the development of the fistula over here. Fistula over here. I hope the point is clear. Why the answer is second cleft. Second cleft, that is on the outside part, the second cleft, because this is our second cleft which might have developed all throughout this area. Okay, here also look at the external fistula and it will actually go and open like this. Coming to the next one, a fairly simple question if I may say so, that a renal biopsy of a 45-year-old patient with impaired kidney function shows a tubular structure lined. So kidney biopsy shows a tubular structure lined by cells with a brush border. So tubules, kidney have tubules, nephrons have tubules, both PCTs, DCTs, both of them are tubules, proximal convoluted and distal convoluted tubules. Now which type of epithelium would be the most characteristic of this finding? So they're basically asking that they have either PCTs or DCTs, they have the tubules, right? They're asking, find the renal biopsy was done through the tubules. They found an epithelium with a brush border over here. Find brush border just to increase the surface area, because we know in the nephrons what is happening. And they also have shown an image over here. Now in this image you can see the epithelium, the size or the length or the width and the height of the cell is sort of similar. But in the center you see a central rounded nucleus. This is a pathognomic feature of which type of epithelium? It's a pathognomic feature of cuboidal epithelium. And is that type of epithelium found in the tubules? Answer is a big yes. So it has to be cuboidal epithelium found in tubules. And if you start to search for the options, this is option number C over here. Now if you want to rule out the other options, see the squamous epithelium over here. Squamous epithelium is actually, it's a basement membrane and there will be a simple flattened nucleus, right? If I may enlarge it a bit. And then there will be minimal cytoplasm and the cell is just rising like this. So there is a small flattened nucleus and there is minimal cytoplasm. If you look at the columnar epithelium, what happens in columnar epithelium? Again, you have a basement membrane. But here there is an enormous amount of cytoplasm, due to which they have a nucleus over here and the height of the cell is obviously longer. Where do you see columnar epithelium and where do you see squamous epithelium? See, squamous epithelium is also known as the pavement epithelium. So it is seen in areas where you have diffusion of gases or structures. For example, in the alveoli you see simple squamous epithelium, easily diffused. Where do we see columnar? Because it has a lot of cell organelles. So wherever the secretion is needed, you have a columnar epithelium. Examples, in the entire gut, you have columnar epithelium. Now where do you see a cuboidal epithelium? Cuboidal epithelium is seen where you have somewhere in between. Neither it is squamous nor it is columnar, where the where the height of the cell is same as the width of the cell with a centrally rounded nucleus. Somehow in the middle you have this cuboidal epithelium. It is found in tubules as well, because there you have to reabsorb also, you have to secrete also. Transition epithelium is the one which is found where it is also known as a urothelium. Now, with the uro, we might think, okay, uro means kidney, it should mean the kidney. No. The transitional epithelium or the urothelium is found in areas where you need a distension of the epithelium or distension of the layer. Transition means you are transitioning from one type of cell to other type of cell. The best example for this is our urinary bladder. Urinary bladder, also the ureter, but not in the kidneys, right? So transitional epithelium is seen over there. It's a multi-layered, and obviously imagine once the person has micturated or urinated, the bladder is very small in size. And slowly through the kidney and the ureter, the urine starts to fill the bladder. The bladder starts to expand, right? Once it starts to expand, obviously the epithelium needs to change. So in a contracted state, there is multi-layered, right, with the umbrella shaped cells at the top. Now once it starts to stretch or expand, obviously the epithelium starts to change slowly. Therefore, it is known as a transition epithelium. It is transitioning from one type of epithelium to the other type of epithelium, right? Here the image is also given. It is very straightforward question, cuboidal epithelium. Let's see the next one over here. A 28-year-old involved in a fall presents with weakness in shoulder abduction. So he falls somewhere and there is weakness in shoulder abduction, and reports numbness over the lateral aspect of the upper arm. There is some numbness over here, and also there is weakness in abduction. Which statement regarding the axillary nerve is incorrect? Basically, they could have simply asked you this line also, that which statement regarding the axillary nerve is incorrect, but they tried to show you a clinical picture over here, some relation we can find out. Now, shoulder abduction, we know it is started or begun by which muscle? The supraspinatus muscle actually helps in just the beginning part, but the major chunk of it is done by the deltoid muscle. Up to 90 degrees. This is up to 90 degrees. 90 degrees is this one, right? This is 90 degree. Then after this, after 90 degrees is attained, we need to abduct our arm above our head. So that is known as overhead abduction. OHA is overhead abduction. Now this is done by which muscle? It is done by the muscles, basically our trapezius and serratus anterior muscle. These two muscles are the ones which will cause the overhead abduction. Remember this. But they also given a question that there is numbness over the lateral aspect of the arm. If you look at the arm lateral aspect, the two nerves over here are supplying the sensory supply. What are those? Let me draw this neck and the shoulder over here and the upper limb over here. So if I try to show you this area, this is the lateral arm. There are two nerves which will be supplying this sensory. Upper part is basically innervated by the axillary nerve, and the lower lateral part of arm innervated by the radial nerve. Remember this. So in the lateral part of arm, you have two main nerves, axillary and the radial. And also in abduction, this deltoid, which is mainly involved, it is also supplied by the axillary nerve over here. Now they're asking about the axillary nerve. So basically the question is all about axillary nerve. I'm just expanding the question. I'm telling you relevant points which can be asked. Other options, if you see, what is wrong about the axillary nerve? Let us see that too. Innervates the deltoid muscle. Yes, axillary nerve innervates the deltoid muscle number 1, and the other muscle which it innervates is a teres minor. So this statement is correct. Does it innervates the teres? No, I just told you it is teres minor, not teres major. So we can go with this as the answer. Then the other question that should immediately come through your mind is, then which nerve innervates the teres major muscle? The teres major is innervated by the lower subscapular nerve. By the lower subscapular nerve, a nerve coming from the brachial plexus, coming from the posterior cord of brachial plexus. So second is the B option is the answer, but let us see other as well. Paresthesia in the upper part of arm. Yes, that is the correct statement. It is also known as circumflex nerve, obviously. Why? Because it is circumflexing around the which area of the humerus. But which area of the humerus? This axillary nerve, it revolves around over here, around the bone humerus, and that area is known as surgical neck of humerus. So while giving a intramuscular injection over here, we have to be cautious not to damage or not to irritate, injure the axillary nerve, because it is circumflexing around it. Let me show you a couple of images over here. This image is actually a frontal view. You are looking at few things. Let me highlight. This is the scapula, obviously, right? This is the H for humerus. This over here is the coracoid process, and this is the acromion process. Understand this, okay? Now look over here. These are the parts of brachial plexus. These are the parts of brachial plexus. Basically, these are the roots. Root, then the trunk is formed, then the cords are formed, right? And finally, from the cords, the branches are given. So here, if I might tell you the even which cords we are able to decipher over here, this is L for lateral cord. This is M for medial cord. Why I'm saying so? Because you can see the axillary artery over here. The cord lateral to the second part of axillary artery is lateral. Then where is her posterior cord? Posterior cord, let me now show you. The posterior cord is right over. This is the posterior cord. P for posterior. Now posterior cord gives mainly two terminal branches. What are those? One is the radial nerve, one is the axillary nerve. Now radial nerve is going down, and then you can also see how the radial nerve goes behind, spiraling around the spiral groove posteriorly, also known as radial groove. But here we have to focus more on the axillary nerve. You can see axillary nerve vanishes over here. It then goes around the surgical neck of humerus, right? Okay. Now there was one more image over here. What is this image? This is again a cadaveric image. What you're looking at, it is a posterior view around the region of shoulder. The muscles, first of all, we start to identify. This is our deltoid muscle. Okay. Now this muscle over here, which muscle will this be? This is the teres major over here, right? This will be the teres minor over here. This is what? This is the long head of which muscle? Long head of which muscle? It's going in the posterior part of arm. This is the long head of triceps brachii. This is long head of triceps brachii. Now this image actually, apart from the question, this image is showing us few other structures lying over here and here. I made this few white color spaces. This is actually the upper triangular. This is the lower triangular. This is the quadrangular space. If the question comes, where do you feel the axillary nerve should be present? The axillary nerve is actually present in the quadrangular space. Here you have the axillary nerve. It is circumflexing around and supplying these two muscles over here, deltoid and teres minor. The upper triangular space has circumflex scapular vessels, and the lower triangular space, yes, what are this structure you can think of over here? Running posterior. I've told you already, it's a posterior view you are looking. Which nerve will be over here? It is mainly the radial nerve which will be present over here, and it supplies these triceps. Radial nerve passes along with the vessels, also profunda brachii vessels, branch of the brachial artery, profunda brachii vessels. Similarly, axillary nerve passes with the posterior circumflex humeral vessels, branches of axillary artery. Fair enough. Now let's see the next one over here. A question from the general anatomy. Which of the following are examples of saddle joint? Now, first of all, we should know what are saddle joints. Saddle joints are actually multi-axial joints. It is like saddle, no? Saddle, when we sit on a horse, we put a saddle over the back of the horse and then we sit over it, right? So wherever a horse moves, he can also move. So it is a multi-axial joint, means movement can occur in more than 2 axes or 3 axes. Multi-axial joint. Now, synovial, obviously. Let's look at the options. First option is sternoclavicular joint. Is it a saddle variety? Answer is yes, it is a saddle variety. Sternoclavicular, yes. You have seen this as the clavicle over here, right? And this, understand, this is the sternum over here. Now this joint over here, this is the sternoclavicular joint. You have an articular cartilage also inside the joint. Even if you just put your finger over the sternoclavicular, because clavicle is a subcutaneous bone, you can put your finger over here, and if you move your upper limb in any direction, you feel the movement over here. Don't just go with what I say. Feel it on your own body. Put a finger on the SC joint, say on the left thumb or left index or left thumb on the right SC joint, and I move my right upper limb. I'll feel the movement deep to my pulp of my thumb over here. Okay, so this is calcaneocuboid. These are the tarsals over here, and yes, it is also comes under the saddle variety. Understand the arches of the foot. There are too many movements which you need in the foot. Temporomandibular joint. Option number C over here. Temporomandibular. It also has a cartilage, articular cartilage deep to it. But these joints over here, you have a rounded condyle as the head of the mandible. So they are bicondylar variety. They are bicondylar variety, not saddle. The upper two examples, these both were saddle and saddle. Interphalangeal joints, now between the phalanx. Now, is this movement in how many axes? Only one axis. Interphalangeal are hinge joints. So they are basically hinge joints. Movement is only in one axis. Finally, you have a carpometacarpal. These are the carpals, these are the metacarpals. Whenever we move our fingers, it is not just movement of the fingers. It is not just movement of fingers. Put your hand over here also on the carpal and metacarpal, right? And then you move your fingers. The moment you move your fingers, you feel that there is some movement occurring here also, wherever you move your fingers. This actually also falls under the saddle variety. So we have option number 1, 2 and 5 being the saddle variety, and I hope option number B over here correctly represents what is the answer over here. 1, 2 and 5. So the topic over here is what? The topic is joints from the general anatomy. Basically types of synovial joints are must know topic. Let me show you a couple of images also over here. Here you are seeing at the thoracic cage, but basically we are focusing on the clavicle and the sternum over here. This is the sternum over here, right? This joint is the one that is the sternoclavicular joint. Recently questions have come from the joints in the thoracic cage as well. For example, here you can see the manubriosternal secondary cartilage, and this is manubriosternal joint. This is costochondral joint, primary cartilaginous. Costochondral, right? It is costochondral joint, right? Again, secondary cartilaginous. This is the intervertebral disc between the body of the respective vertebrae, right? So these are the various examples which you should know. This is acromioclavicular joint over here. It is actually a plain type of synovial variety. Other image over here is showing us the bones of the hand over here. Now see, these are the carpals. These are the metacarpals. The first metacarpal, the second, the third, the fourth, the fifth, and these are the phalanges. These are the phalanges. The interphalangeal joint already they are representing being the hinge joint. Now this carpometacarpal over here, they mainly fall under the saddle variety. Also remember, the first carpometacarpal is very famous. It is obviously a saddle variety. Though the others, they somehow fall into the category. But remember, the first carpometacarpal. Why? Because you see the movement of the thumb and related to the movement of the fingers. The first carpometacarpal over here, let me put a highlight over here. Just a second. Yes. First carpometacarpal is a typical saddle variety. First carpometacarpal, right? So this is mainly the saddle site of synovial joint. Others also might fall into the category, but not as much as the first carpometacarpal. Okay, remember the thumb over here has more prevalence. Regarding, just to complete this thing over here, we have this area. What is this? Here you have the radius and ulna as well. They are from which joint? Meaning the radius forms with the carpals as the wrist joint. Now, somehow they might ask, wrist joint is which type of joint? Wrist joint will come as the ellipsoid variety. Ellipsoid variety. And this joint over here, what is this joint? This is MCP, metacarpophalangeal joint. It comes as a condylar variety. It comes as a condylar variety. You should know these basic things over here. Saddle, again, I am repeating, first CMC is a better example than the other CMC. Is a better example. Here, the medicine or medical science, nothing is all or none over here. It's just a transition between. When we say saddle, it's not like all the saddle joints will have equal amount of movement. No. It will be some axes which are having more movement, some axes which are having less movements. Remember that part. Coming to this also, the final image and the tarsals over here, the saddle joint over here, this is the calcaneum bone, this is the cuboid bone. This is the calcaneocuboid over here, saddle variety. And this is the talus bone over here, and that is which bone? This is the navicular bone over here. So talonavicular is a ball and socket. Here we can write ball and socket, talonavicular, and saddle variety, calcaneocuboid. Right? Okay, next question. Which of the following statements regarding the cubital fossa is not true? Direct question. Cubital fossa, we all know it's a depression in front of the elbow over here, where we put our stethoscope for measuring blood pressure. We take a syringe to take a venous blood from here. Right? So this area is a cubital fossa. It's a very important anatomical area of the human body. Remember that. Now, which is not true over here? Let us see. The lateral border is formed by the brachioradialis. It is perfectly fine. The lateral border is by brachioradialis and the medial border is by the pronator teres muscle. That's a statement. So in questions like these, when they ask you which is not true, actually you are getting 3 true statements. So that actually strengthens your knowledge of the topic, be it any subject. Second question is medial border is demarcated. Yes, that you already said in the first statement itself. The base is marked by the imaginary line drawn between the lateral and medial epicondyle. Yes. So you have the base margined over here, and you have the lateral and the medial border and the base over here. I'll show you the images as well. Obviously, we know that fourth option should be the answer. We are already pointing it out, right? So fourth option is saying that the contents of brachial artery. Yes, I told you we put our stethoscope to measure the blood pressure. Biceps tendon. I mean, you just flex your forearm over here. You feel the tendon over here. Don't go with what I say. Feel on your own body. Ulnar nerve is not present over here. Then, sir, which nerves are present? Instead of ulnar nerve, we have the median nerve and we have the radial nerve over here. Then, sir, where does ulnar nerve? How does the ulnar nerve reach the forearm in the hand? We all know ulnar nerve is known as musician nerve. So it supplies the muscles in the hand. Also, it has some sensory innervation over here in the hand. How does the ulnar nerve reach the distal part if it is not going through the cubital fossa? Now, if a structure is not going through the cubital fossa, it also obviously has to go from behind. But then the point comes, if it is going through behind, and once we flex our forearm, isn't the ulnar nerve always stretched? Because once you flex the arm over here, flex the forearm over here, if the ulnar nerve is going like this, it will be stretched all the time. And do we feel it at the tip of olecranon? Answer is no. Then where it goes? It goes on the medial side. Neither cubital fossa nor exactly on the olecranon. It goes medial side where? Just behind the medial epicondyle. Remember this. And here we can actually palpate it. I'm writing over here just behind the medial epicondyle. So if it is going behind the medial epicondyle, it won't be a content of the cubital fossa, right? Let me now show you a couple of images. This is from the skin and the veins intact. Here you are looking at a cubital fossa over here. This is the most common vein which is used for taking the intravenous blood. The median cubital vein, it is actually joining the basilic and the cephalic vein over here. That is one use of the cubital fossa. Other image, if you see over here, it is showing us that is the base of the cubital fossa, a line between the two condyles. This is brachioradialis, that is pointer teres, and if you remember the margins, this is the lateral margin, that is the medial margin, that is the base. So this area over here, this is our cubital fossa, right? These are the boundaries of cubital fossa. Now, if you look at the contents over here, suppose you remove the skin, the fascia, all of that, then you start to see the contents. The contents we can all remember if you go from medial to lateral. Suppose this is the medial side, that is the lateral side, right? The contents are remembered by M, B, B, R, from medial to lateral. What is M over here? M is the median nerve. Let me highlight that median nerve for you. This is the median nerve. Not easily palpated because it is lying deep over here. Then, just lateral to median nerve, we have what? We have this as the brachial artery. Now, this is the brachial artery. Let me directly put an arrow over here. This is the brachial artery. You can see it is bifurcating below into radial and the ulnar artery. This is where we put our stethoscope to measure the blood pressure. Just lateral to it, what we have the biceps tendon. So this over here, this is the biceps brachii tendon. And lateral to it, we have the radial nerve. So it is MBBR from medial to lateral. Remember, sometimes students confuse with these two B's over here. And do remember, if you want to remember with any mnemonic, fine, but understand, with the practice, things come into our reflex. Now, I urge all of you to slightly flex the forearm. If you just flex the forearm, then what you will feel is, you will feel this strong tendon in the cubital fossa. This tendon is what? This tendon is tendon of biceps. You can feel it. And then move your finger just medial. Now, initially your finger was over here, you can feel the tendon. Now move your finger just medial to the tendon. Okay, like this. And then straighten your arm or straighten your forearm. Your finger will be directly sitting over what? Your finger will be directly sitting over this artery over here. Here you can take the pulsation as well. Now, if you move your finger laterally, obviously there is no artery over here. So again, you will not be confused in the examination hall that, okay, was it bicep tendon or the brachial artery? Suppose you know this trick over here, that is nothing a trick, it is just a practical way to determine the exact location of the brachial artery. If you know this point over here, you will never ever confuse, right? So therefore, answer was of ulnar that actually passes behind the medial epicondyle. The next question asks that during abdominal surgery, a surgeon identifies a major artery. Okay, just a second. Yes, a major artery supplying the foregut structure. Abdomen was opened, a surgeon was doing a surgery over the abdomen. He saw an artery supplying the foregut. What is foregut? Foregut is basically our stomach part, our liver part, right? Our proximal part of duodenum, that is all foregut. Which vessel arising at the level of T12 is likely to be encountered? So they are giving you multiple ways to answer this question. First hint over here was artery supplying the foregut, first hint. Second is artery coming at T12 vertebrae. In both the situations, the answer is one only, that is the celiac trunk or celiac artery. Is it a branch of abdominal aorta? Yes, it is a branch of abdominal aorta. It supplies foregut? Yes. It comes at T12? Yes. In both ways, the answer is fairly straightforward. Celiac trunk is the answer. But now, if they have asked you today about the foregut, tomorrow they might ask you about the midgut, they might ask you about the hindgut, so be prepared for that too. That is how our study should be. The artery supplying the midgut is actually the option number A, that is superior mesenteric artery. Which vertebral level it comes? L1 or L1 L2 junction. The artery supplying the hindgut is actually our option number C over here, the inferior mesenteric artery. At which level it comes out? It comes out at L3. Then sir, nothing comes between L1 L3. Yes, option number D over here, if you look at the renal artery, it comes out at L2 along with the gonadal arteries as well. So there are also gonadal arteries. Gonadal artery meaning by testicular or the ovarian artery. They are also branches of the abdominal aorta. Remember this, and here you can see it in image. This image is showing us both the IVC as well as the abdominal aorta over here, and this here we can see the celiac trunk or the celiac axis as written over here. Below this you can see the superior mesenteric artery, below this you can see the inferior mesenteric artery. On the sides you are seeing the renal artery and the gonadal or the testicular artery. Okay, in this diagram do also focus on one very very important point, that is the left renal vein crossing in front of the abdominal aorta, and over it is lying, what is lying? This superior mesenteric artery, which is over it. Let me put this black box over here. So that's the left renal vein might be compressed by the superior mesenteric artery sometimes, and that is known as SMA syndrome, also known as the nutcracker syndrome, right? Or yeah, this image also, what this image is actually showing us nothing but these parts of the midgut and the hindgut and the stomach and liver, but they are parts of foregut. In this developmental image, we can also focus on this aorta that is lying posteriorly. And here, if I just zoom it, can you see these three arteries coming out? These are our celiac trunk, these are our superior mesenteric, and for hindgut, we have the inferior mesenteric artery over here. Okay, do remember this. And also see how the midgut is going out with low intestinal duct. That is a separate question. Okay, now let's see another question, that during physical examination, a physician identifies the structure that spans from the anterior superior iliac spine to pubic tubercle. This structure is recognized as. Now, if you have gone through the basics of the abdominal wall, anti-abdominal wall and inguinal canal and all those things, then you will realize that there's a structure that goes from anterior superior iliac spine to pubic tubercle. What is going over here? There is actually the aponeurosis of which muscle? Today they're asking you ligament, tomorrow they ask you something else. From ASIS to pubic tubercle, there is aponeurosis of the external oblique muscle. And what happens is between these 2 points, these two are bony points. The aponeurosis of external oblique, actually what happens is that it turns down on itself, or it turns down like this. So the lower margin will do what? This will be the lower margin, and the lower margin is thickened. And actually what is happening is that it is the aponeurosis of external oblique whose lower margin is thickened, and this is forming the ligament which is spanning between ASIS and pubic tubercle. And what is that known as? Inguinal ligament. So answer over here is straightforward, inguinal ligament. Answer over here is straightforward, option A, inguinal ligament. Is there any other name for inguinal ligament? Yes, it is also known as POUPART, Paupert's ligament. Now look at the other option. Let me first of all show you the, suppose this is ASIS, this is pubic symphysis, that is pubic crest, and this is PT, pubic tubercle. Now I am trying to show you the inguinal ligament going from ASIS to pubic tubercle. Actually, it is the lower edge or lower margin of axon oblique aponeurosis. We just call it as inguinal ligament. As this inguinal ligament reaches the pubic tubercle, it starts to go behind. Now this is actually forming the lacunar ligament, option number B over here. And then this lacunar ligament actually goes posteriorly as the pectineal ligament. Okay, so remember B and C are actually continuation. And let me show you an image over here. This is just an image. Actually, the image was to show you the differences between the two types of hernia. But here, look at the ASIS over here. Exact ASIS is this spine over here, right? This point is ASIS, and this is pubic tubercle. You can see this inguinal ligament. Again, I am saying, keep that in mind. This is not actually a ligament like a ligament which you see between the bones of the joint, like iliofemoral ligament or some other ligament. This ligament is actually lower thickened edge or inferior thickened edge of a muscle tendon or aponeurosis of which muscle? Answer is external oblique. So tomorrow they can ask you about the muscle as well. Considering the other point, the femoral hernia, you can see it's coming from the femoral canal. So basically its location is below and lateral to, what is this green circle over here? Pubic tubercle. So if there is a globular mass below and lateral to pubic tubercle, it is most probably femoral hernia, right? And if there is a globular mass coming above the pubic tubercle, it is most probably inguinal hernia. That also might differentiate into a direct or indirect. That is a different point altogether. Let's see the next one over here. 25-year-old patient presents reports experiencing pain and discomfort while swallowing. So while swallowing, pain and discomfort. Upon examination, it is noted that the patient has weakened tongue movements. So tongue movements are weakened. Tongue movements are weakened during the swallowing process. So during swallowing, the tongue movements are seen to be weakened. Which muscle primarily contributes to the upward and backward movement of the tongue? Very good question. So, which muscle primarily contributes to the upward and backward movement of the tongue during swallowing? Now, see, swallowing in itself is a completely different process. It's a complicated process having an oral phase, a pharyngeal phase, and a esophageal phases. There are three to four phases in the process of swallowing. Fine. But forget about the details of swallowing. Although I urge you to just go and just have a look at the act of swallowing. What are the different movements that are occurred? But forget about it for a while. That's a totally different big topic. Try to swallow. Suppose we take a glass of water, right? You have a glass of water. Try to swallow it. The moment you try to swallow water, now close your eyes or just think about what are the movements occurring inside your oral cavity. Now focus on the tongue. How the tongue is moving during swallowing a glass of water or any food item, whatever it is. The tongue is actually pushing back whatever the content is in the oral cavity to push the content from oral cavity to the pharynx, right? So now they are specifically asking now which muscle is actually contributing to the upward and backward movement of the tongue. Now see over here, that tongue in itself is basically a group of muscles. Now this group of muscles, they move in which direction? Let me tell you all the directions. Tongue can move up, down, right, left, come out, go in, anywhere. You name it, you have it. Tongue might change the shape also. It might widen itself. It might lengthen itself. Tongue is it's a totally different game. The muscles are present in all the directions. You have intrinsic muscles, you have extrinsic, various movements. But the point over here is, if you look at the tongue, suppose you're looking at a tongue over here. This is the anterior part, that is the posterior part. Now they're asking us in the question that which is helping in upward and backward movement, meaning by this movement. Now if you look at if you have some idea of the extrinsic muscles of the tongue, there are basically four types. What are those? One is the genioglossus, number one. Number two is the hyoglossus, hyoglossus. Number three is the palatoglossus, palato-G. And number four is the styloglossus. How do we name it? We name it from where the muscles are coming. Let me just try to show you. The genioglossus over here is coming from the genial tubercle like this. This is genioglossus. Genial tubercle is right behind the mandible over here. Tongue is over here, right? The hyoglossus will come from here because hyoid bone is over here. This is the hyoid bone just above the thyroid cartilage. The palatoglossus will come from the palate. Soft palate. Soft palate is where? Above and behind the tongue. The styloglossus is coming from the styloid process. Suppose we number it as 1, 2, 3, 4. 1 is genioglossus, right? 2 over is hyoglossus, and 3 is say palatoglossus, and number 4 is say the styloglossus. So which out of these 4 you think will move the tongue upward and backward, not just upward and backward? Answer is option number 4 over here, applying simple common sense, and option number 4 is styloglossus will be our answer, right? Styloglossus will be our answer, and here option number C, simple as it. Now let me show you the image over here now. If you understood this, then just let us look at the images quickly. This is the genioglossus, that is the hyoglossus, this is styloglossus coming from the styloid process. Palatoglossus is not shown, but actually if you just try to understand that this will be the soft palate over here, and here we will have the some small muscles coming down as palatoglossus, right? Now all of these muscles are supplied by which cranial nerve? They are supplied by the 12th cranial nerve, except the muscle that is known as the palatoglossus, which is supplied by the pharyngeal plexus, or we can roughly say vagus nerve, 10th nerve. All other muscles are supplied by the 12th or the hypoglossal nerve. Okay, fine. Next question: which of the following are examples of what? Examples of the unpaired dural venous sinus. Now, dural venous sinus. So dura is what? It is the meninges. So inside the meninges we have dilated veins known as venous sinus, which is unpaired. Unpaired means it is unpaired, it is not paired. So apply common sense. Whichever is unpaired, will it be on the lateral side or will it be in the midline? Think about it. Any structure which is unpaired has to be in the midline. For example, we have an unpaired sternum midline. We have an unpaired vertebrae are in midline, right? So any structure which is in the midline is unpaired. So let us see which are unpaired now. Now they over here are giving us few options. Let us just apply our English language skills and then we'll look at the image as well. Don't worry. Now sagittal sinus, as the word says, sagittal sinus. Sagittal means what? It is midline. So they has to be midline. Unpaired here have to be midline. Transverse sinus over here. Transverse means what? They are going transversely on the side. So transverse sinus doesn't look like it will be on the unpaired aspect. Sigmoid is S-shaped. Sigmoid continues as what? It continues as internal jugular vein. How many internal jugular vein we have? 2. Again, this doesn't fit into the midline or unpaired by. Straight sinus. Straight means straight over here. Straight over here is also coming into the category of an unpaired. Let me show you this image over here. Now let us highlight the unpaired ones. This is obviously superior sagittal sinus. Then you have inferior sagittal sinus. This is these are 3 basically unpaired sinuses. The 3 basically unpaired sinuses over here. Also the vein of Galen, you can also call it as an unpaired. The other sinus that is not actually being shown over here, but there is a very small sinus coming from the we can say between the cerebellar hemispheres. And this sinus over here, this is known as the occipital sinus. This is it also an unpaired? The answer is yes, it is also an unpaired sinus. This occipital sinus will also be an unpaired sinus. Now talking of the paired sinus, suppose I show you over here that this is, now I'm trying this color as being for the paired sinus. Look at the transverse sinus over here. Look at the sigmoid sinus, continues as a jugular vein. They are going on the sides, transverse sinus, sigmoid and internal jugular vein. Even the cavernous sinus, they are also 2 in number. Petrosus sinus also are paired 2 in number. So these are all paired sinus. Okay, occipital sinus, superior inferior sagittal, straight sinus. This will be unpaired one. In unpaired, let me just for completing the topic put another example over here. Let me first write unpaired superior sagittal sinus, inferior sagittal sinus, ST dot sinus, O dot sinus, occipital sinus. Even we can put a Galen vein as well. Apart from this, you have anterior and posterior intercavernous sinus. They're also unpaired sinus. In the paired part, we can already say the transverse sinus, the sigmoid sinus, then the petrosal sinus, both superior and inferior petrosal, then cavernous sinus. These are quite famous sinuses. They're all paired. So here we know that option number 1, 3, and 5, and therefore we can easily go with option number C over here. These are unpaired, right? Let's see the next one. A 29-year-old presents with difficulty in lifting the shoulder and extending the neck. Think about lifting the shoulder. Which muscle causes lifting the shoulder? This is like shrugging of shoulder. Which muscle does this? The muscle which causes the shrugging or lifting the shoulder is basically main muscle is TPZ, trapezius. And extending the neck. This movement is extending the neck. This is flexion of the neck. That is a lateral flexion of the neck, both the side. This is rotation of the neck. This is extending the neck. This will be done by muscle present obviously on the back, right? And therefore again extending the neck will be basically be done by either trapezius or some parts of the like sternocleidomastoid might also come, but trapezius. On examination, weakness in elevating the shoulder and extending the neck, again so is noted. Same thing. Which nerve is most likely? So which nerve supplies trapezius? Simple as that. The motor nerve supplying trapezius is our spinal root of accessory nerve. Spinal root of accessory nerve, also known as 11th nerve over here. Simple as that. Basically, what they're trying to ask in the question is that do you know basic bigger movements of the human body and the major muscle supplying it? Like initially we did a question on a hip abduction, we did a question. Like, right? Over here, answer has to be accessory nerve, and you can see it as one of the options over here. Let us see the other options as well. Hypoglossal nerve is for the tongue, right? Vagus nerve from the pharyngeal plexus, and what muscles will it supply? It basically supplies the muscles of soft palate, the muscles of pharynx, the muscle of larynx, and then it forms the parasympathetic. Parasympathetic for what? Understand this too. It forms the parasympathetic roots for the involuntary muscles of heart, understand, for the lungs, right? Then it goes below into the foregut and midgut for all the areas till the proximal 2/3 of transverse colon. We have this vagus nerve. Glossopharyngeal nerve is basically a sensory nerve. So where does it supply sensations? Supply sensations to actually it is also being a part of pharyngeal plexus. So wherever we have the soft palate and pharynx and all, it provides sensation along with sensation in the posterior part of the tongue, along with the middle ear. Doesn't it supply any muscle? It does supply one muscle, and that also not a very huge muscle, a small muscle over here, and that muscle is known as stylopharyngeus. Just one muscle over here. Just to put an extra point, this is the nerve for which pharyngeal arch? This is the muscle for the third pharyngeal arch. Okay, third pharyngeal arch. Vagus nerve is for the fourth and sixth arch. This is for the fourth and the sixth arches, right? That's an extra point over here. Let me show you the muscle over here. These couple of muscles just have a hold of. This is the sternocleidomastoid, but over here this is your trapezius. And what actually happens is, let me show you one thing over here. Can you name me which triangle is this which I'm trying to make over here? This triangle over here is which triangle? This is known as the posterior triangle of neck. Why I have drawn this posterior triangle over here? Try to understand. Because here you will feel a nerve over here. A nerve lies very close to the roof of the posterior triangle, right? And this nerve is your accessory nerve. What it does, it supplies both of these muscles, sternocleidomastoid and trapezius. And this nerve can be damaged in an incision over the posterior triangle. In doing a lymph node biopsy over here, you have the cervical lymph nodes over here. This nerve might be damaged. Remember that. Fair enough. Let's see this movement also. This is your just a way to show one movement that is known as overhead abduction or lifting of the shoulder. You can see this involvement of this muscle over here, this is trapezius, and how it helps in elevation of the shoulder for overhead abduction along with this muscle that is serratus anterior. This is deltoid being shown, this LBS is the pound. So basically in this image they are showing us the overhead abduction or the abduction at shoulder and lifting of the shoulder, right? abduction at the shoulder. Okay, just go through it. It's very simple for me to understand. This question over here, probably the last question, probably the damage to which artery or its branches might lead to Wallenberg syndrome. What is Wallenberg syndrome? You read it in anatomy also, then you read it in a bit of path also, then obviously you read it in detail in our medicine also. The Wallenberg syndrome is our lateral medullary syndrome, quite a famous syndrome. What is medullary over here? Medullary is the medulla oblongata. So even the first line itself is sufficient that damage to which artery might lead to Wallenberg syndrome, characterized by symptoms such as ipsilateral facial pain and temperature loss and contralateral body pain and dysphagia and hoarseness. This we all learn by the structures lying in the brainstem. Okay, these are all brainstem vascular syndromes category. Identify the number of the marked artery that is most likely to be affected. Now see, basically they are asking that, okay, this area, imagine this is the medulla oblongata, okay, and this is the midline of it. Now there is a lateral medullary syndrome, meaning by some part of the lateral medulla has been damaged. Let's try to put on both the sides. They're asking you which artery can cause this. Actually, you should know that medulla oblongata continues down as what? It continues down as the spinal cord. So this continues down as what? This is the spinal cord. Now, which opening will be over here if I put it like this? This will be the foramen magnum. Let's try to imagine. Which artery enters the foramen magnum? On both the sides, it is the vertebral artery. Which artery? Vertebral artery. Then this vertebral artery actually goes like this, and at the upper part of medulla, it joins to form a single basilar artery. So vertebral artery is present where? Is it in the midline throat or is it laterally? It is laterally. So which artery is supplying the lateral part of medulla? Vertebral artery. Although it will give a branches over here, which is one of the important branches, is the pica artery or posterior inferior cerebellar. Let me write its complete name. Posterior inferior cerebellar artery. Vertebral artery basically try to apply logic, common sense, going from lateral to medial. And where it becomes medial? At the pons, not at the medulla. So in the medulla, it is lying laterally. Therefore, answer has to be the vertebral artery or its branch. Now, if we have to, the other job of us is to identify. Can we identify the vertebral artery? Now, let us see over here. This green circle they have already labeled it as, it has to be the circle of Willis. Okay, fair enough. Now, what are the different arteries over here? Obviously, this is the area for the medulla oblongata. Number 3, we can very well see it is the vertebral artery. Number 3 will be the answer. But number 2 will be what? It will be the basilar artery lying over the pons. And basilar artery then divides into number 4. This is posterior cerebral artery. Posterior cerebral artery. And number 1 over here is the internal carotid artery. Then it gives rise to this middle cerebral and all that. So answer is our, we know answer we are basically referring to option number 3 over here being the vertebral artery. And therefore answer will be option number 3 over here. Let me show you a cadaveric image of the same thing over here with a cadaveric image of the brain and the arteries. Now, first, let me just try to show you. This is P for pons. This is area is M.O medulla oblongata. Focus on the arteries. Can you see this big 2 arteries? These are the vertebral artery. This artery will be B.A. BA, basilar artery. Right? This over here will be the posterior cerebral artery. This is the internal carotid artery. Lateral medullary syndrome is basically occurring where? On the lateral part of medulla. Which artery is over here? It is the, got the point, vertebral artery. Right? So that was all about our discussion. I hope you enjoyed it, and all the best.
Hello dear friends. So let's discuss up the questions of microbiology in this particular CBoT. And as the exam have got postponed, the only challenge is to maintain that streak which you are having, okay, that flow of your studies. And I know like after some distractions and all, you will come back, and in that series only, let's start up with this particular discussion so that you can get up most of your questions in and around these particular stuffs right in the exam. Okay. Now let's see the first one. A 24-year-old male presented to the emergency with complaints of abdominal pain. The patients gave a recent history of consuming undercooked ground beef. The patient has no complaints of fever. On examination, the skin turgor decreased, and the investigation revealed the presence of RBCs on the stool microscopy. Okay. So, which of the following bacteria is responsible for his condition? So, one thing is understood. Skin turgor decrease means the dehydration happened, and there is a presence of RBCs. So, means it's a sort of blood which is coming up in the stool, a sort of dysentery type episodes, bloody diarrhea, as you can say, and there is a history of eating up this. So, this characteristic history is regarding the enterohemorrhagic E. coli. Okay, guys, you already know that enterohemorrhagic E. coli O157H7. This particular serogroup O157H7 is responsible for doing up HUS, which is termed as hemolytic uremic syndrome in the children, and it does hemorrhagic colitis in the males. Okay, and this particular HUS presents with what? It presents with renal failure, it presents with anemia, okay, and thrombocytopenia. Thrombocytopenia. So these particular things are there. That is renal failure, anemia, and thrombocytopenia. That is happening in the HUS. Regarding the hemorrhagic colitis, this one happens in the adults mainly. Okay. Now, other than that, this is a favorite of examiner in the NEET PG. A lot of questions are being asked in and around this. So, we should discuss them also. So, what should be the other ones? That it have certain toxins like VT1 and VT2. Okay. And these VT1 and VT2, what is the other name of them? They are also termed as virocytotoxins 1, virocytotoxin 2. Okay. And they are termed as this also, SLT1 and SLT2. And what is SLT, guys? Shiga-like toxin. Okay. So that suggests what? Shigella. Shigella does what? Invasive infections. So this also does invasive infections, and that's the reason why you are getting up the RBCs in the stool microscopy here. Okay. So that is one of the reasons. Another important question which was asked in one of the exams is, this is being produced by whom? A gram-negative bacteria. So gram-negative bacteria mainly produces what? A endotoxin or exotoxin. So mainly they secrete endotoxin. But to your surprise, this particular thing is what? This particular thing is exotoxin. Another question asked. Then if somebody asks you regarding the culture media of it, the culture media is also unique because it does not ferment the sorbitol. That's why use of what? A media termed as SMAC agar. And what is that? Sorbitol McConkey agar. That is the SMAC agar. And why we intentionally use it? Because it does not ferment the sorbitol. Okay. The other one, other than SMAC is, other than SMAC, you can use up the rainbow agar. Other than that, what you can use up? You can use up the rainbow agar for this particular one. Is it fine, guys? So answer is B. And this characteristic history also associates with this only. So next time, this association should also be in your mind, that eating up this particular product can lead to enterohemorrhagic E. coli stuff. Is it fine, guys? Now, 14-year-old boy with fever, joint pain, a recent history of sore throat. On the hospital admission was necessary for this particular child. The hemoglobin levels were found to be 8.8, less only. The total leukocyte count is 11,000 per cubic mm. ESR 65 mm. On examination, the heart rate was found to be 112 per minute. A loud murmur is heard on the auscultation, and echo suggests the vegetations are present in the cardiac walls. Okay. So basically now as you measure with the ESR and all, so that is termed out to be 65 mm here. So basically vegetations on echo, that comes in the major criteria of Duke's. That is the Duke's criteria, and we are talking about what, guys? We are talking about infective endocarditis. We are talking about which particular disease? Infective endocarditis, which have in the major one and the Duke's criteria, the echo findings, vegetations, and other one is culture, and that is blood culture. Is it fine? So this is one of the points, and other than that, the minor ones, the major and minor criteria is there, na? So the minor criteria, you have the other ones like those who must be knowing Jan-based lesions, Osler's node, okay, all those particular ones, they are observed in the infective endocarditis, Roth spot, all sorts of those lesions, they are there in the minor one. So basically, you should know here, obviously, that which one does what, and the most common cause of infective endocarditis, as such, also you know, that is termed as native valve endocarditis, and the native valve endocarditis most common cause is Staph aureus. Okay, so this you need to know first of all, that what is the most common cause of NVE, and what is NVE? Native valve endocarditis. Other than that, there is this particular thing termed as SABE. Okay, SABE everybody knows is being done by whom? Streptococcus viridans. Okay, and remember here only the other name of it, that is termed as ABE. Okay, so might be by this name the question came like in one of the exams, and again it can come. So ABE is what, guys? Acute bacterial endocarditis. And what is SABE? Subacute bacterial endocarditis. That is being done by this viridans. And the native valve is done by what? Native valve is done by Staph aureus, which is also known as ABE. ABE is acute bacterial endocarditis. Another thing is IV drug abuser. If somebody is an IV drug abuser, overall also the most common cause is Staph aureus, and right-sided valve involvement, that is tricuspid valve, is involved by whom? That is the Staph aureus. So in IV drug abusers, you should remember up Staph aureus as the main culprit in doing what? Infective endocarditis. And now the question which came in the last exam, that early prosthetic valve endocarditis. If I talk about this, early prosthetic valve endocarditis, if I'm talking about this particular one, then what we are talking about, early prosthetic valve endocarditis, means somebody's valves got damaged and you repair them, and within 1 year they also got damaged. That is termed as early prosthetic valve endocarditis, and it is being done by what? It is being done by Staph epidermidis, and you know this particular name comes where? This particular name comes in the cons. Okay, this particular name comes where? In the cons. So after this particular one, like I like to tell up, if there is a history of dental surgery and all, then you have to like focus upon sanguis and mutants. Otherwise, these particular names is there for the infective endocarditis, various stuffs. Fine. Now coming to this, a 5-year-old child brought by her mother to the general physician. She complains of recurrent wheezing and sneezing episodes of her child, which occurs mostly in the month of April. Okay, so basically the season is being given, that to the spring season, which are the following immunological mechanisms responsible for this symptom. So obviously this is seasonal allergy. Okay, so a sort of allergy stuff, and obviously toll-like receptors by pathogen-associated molecular patterns, that doesn't go with this. It is mast cell activation through the IgE binding. This is what is the best answer, because they are asking regarding the hypersensitivity stuff, and this is what is the type 1 hypersensitivity is all about, allergies. Okay, IgE mediated, mast cells are involved up, there is a primary sensitization and re-exposure again. So those things are involved in this. Important is which particular helper cells are there in the type 1 hypersensitivity. So remember, in type 1 there is T helper 2 cells, and they secrete up interleukin 4. What they secrete up? Interleukin 4. And what these interleukin 4 does? They do the isotype switching. Isotype switching is what? That IgM changes up to IgE. That sort of isotype switching is being done by this interleukin 4. And what you have? IgE now, and these will sit over what? These will sit over the mast cells, and in the second exposure, when they are sitting over it, this particular mast cells ruptures. Okay, this particular mast cells rupture, and rupturing of the mast cells release histamine and serotonin, and this is what you find in the type 1 hypersensitivity. Okay, So this is logical regarding the B option of this, regarding the allergies and all. So here I am like to tell you, in the type 1 hypersensitivity, T helper 2 cells are involved up and they release up interleukin 4, whereas in the type 4 hypersensitivity, somebody asked up, T helper 1 cells are involved and interleukin 2 is released along with interferon gamma, and they does what? They does the formation of granuloma there. Okay, so remember that particular point also. Okay, now coming to the next question. In order to reduce the risk of severe dehydration, which of the following childhood infections can be prevented by administration of vaccine? So, options are Group A, rotavirus, enterovirus E. coli, then Norwalk virus, and then Campylobacter jejuni. These are the various options, and obviously you know the vaccine is there for rotavirus. So, answer is Group A rotavirus, which is the most common, which does the rotavirus diarrhea. Okay, other than that, there are like 9 others which can, the various groups of rotavirus, and this is what is the most common cause of diarrhea in children. This is what is the most common cause of diarrhea in whom? In children. Okay, so this is an important point to be known, that most common cause of diarrhea in children is rotavirus infection, and that too which rotavirus? Rotavirus A, that is Group A rotavirus. Is it fine, guys? Other than that, what else needs to be remembered regarding rotavirus is that this is a double-stranded RNA. Okay, this is a double-stranded RNA and it is having a segmented genome. Okay, this particular one is having a segmented genome, and like total number of this particular one segments are around 11. This is having the segmented genome, that is RNA, double-stranded RNA. And is it enveloped or non-enveloped? So this is non-enveloped. So guys, this is also very important, which you should know. And what is the investigation of choice for this? Rotavirus antigen detection by ELISA. Rotavirus antigen detection by ELISA. This is what is the investigation of choice for this rotavirus infection. Is it fine, guys? So remember this particular one. Other than that, those particular names like NSP4, non-structural protein 4, responsible for what? Secretory diarrhea. And other than that, what you need to know is that NSP4 responsible for secretory diarrhea, and Rotavirix and Rotatic, these are the vaccines. It comes by the name of Rotarix also. They are the ones which associates with the side effect that is termed as intussusception. And now they are in our national schedule also. So that is also an important point to remember regarding the rotavirus. Now coming to the next one, Geobacillus styrothermophilus spores. They are used as a biological indicator in which of the sterilization methods. So you know this simple one, autoclave and plasma sterilization. Autoclave, you know the temperature autoclave, 121, okay, for 15 minutes at a pressure of 15 psi. So actually what happens in this particular one, that is the usage of biological indicator, so that they come in the form of vials, Bacillus styrothermophilus, and basically what happens, you put them into the autoclave, you raise the temperature to this particular temperature for 15 minutes, 15 psi, and after that you keep this into the incubator. Okay, you keep this into incubator for growth. So if the growth happens up, nowadays the newer versions of this have come, in which there will be a color change. There will be a color change if the spores are not killed. Okay, so there will be a color change. They will become colorful after some time, after the incubation, and if they do not change the color to the blue and all, that means your indicator is working fine. You got my point? Before they used to culture it on the culture plate, but nowadays they see the color of the change which happens up. And why the color will change? Because they will grow and they will try to produce up a color which is being already put up into the biological indicator. Otherwise they could not able to produce that particular color. Okay, so basically nowadays it's about the color. If it is there, then it's a control failure. You should check your autoclave. It is not achieving the temperature of 121. Okay, so that particular thing is there by this, and which is the latest method for sterilization, plasma sterilization. And the question of AIIMS was that which particular gas is used in this. The H2O2 gas is used in this. Along with that, you know, electromagnetic radiations are there in this. Vacuum is there. Okay, low temperature is there, and all these factors, they produce what? Radicals, and because of that, ion formations or radicals, the sterilization happens. So this is what is the latest method termed as plasma sterilization. Is it fine, guys? Now, a 45-year-old man is recently diagnosed with systemic candidiasis. So, systemic candidiasis is something happening to somebody. Obviously, one thing is very clear, that the person is immunocompromised in some sense and is currently on a broad spectrum antibiotics. Which of the following statement is true? Okay, which of the following statements is true? So basically, the gram staining shows gram-negative oval budding yeast. This statement is wrong. It is not gram-negative, it is gram-positive. If at all you are gram-staining it. The colonies appears to be black, smooth and pasty. No, it is creamy. Creamy, pasty, but not so tasty colonies on SD agar. On cornmeal agar, the Candida albicans produces distinctive thick-walled chlamydospores. This is what is the correct statement. You know that on this nutrient-deficient media, it produces chlamydospores. And other than that, it shows up the germ tube formation also. Which one? The Candida albicans. The germ tube formation is an important feature which Candida albicans shows. Germ tube test is specifically done for Candida glabrata? No, I just told it is done for Candida albicans. So these are the factors which affects of the candidiasis and all. I already told up if somebody is developing of systemic candidiasis, so obviously that particular person is immunocompromised in some sense. That's why he is developing up the systemic candidiasis. Fine. Besides that, the question which recently came in the FMG exam, that because the board is same, it can come to you also, that a lady is there with having a discharge, thick curdy white discharge. By that you get the information about the vaginal candidiasis done by that. Along with that, what you need to know is, like in the Candida, you have hyphae, you have pseudo hyphae. Okay. Even you have yeast, yeast-like, means it can show the all forms of existence. Okay, got that? So it can form all sorts of existence. Which fellow? This particular fellow, which one? Candida albicans. Is it fine? Now, regarding the script typhus, if they are asking up which of the following statement is accurate. So basically, if we ask up this way, that which is the statement which is accurate, so let's see. The first one, it is also known as Rocky Mountain spotted fever. No, guys, it is not Rocky Mountain spotted fever. That is different thing. That is being done by whom? That is being done by Rickettsia rickettsii, whereas the script typhus is being done by Aurantia sussugamusi. The classical presentation involves an eschar, a black eschar, regional lymphadenopathy, and a maculopapular rash. Very right. This is what is the triad which is being observed in this particular one. Besides that, in the script typhus, you know, it is being transmitted by what? Trombiculate mite. Okay, it is being transmitted by mite, and the larval form of this is termed as chigger. So that's why the disease name also comes out to be what? Chiggerosis. Remember this particular one. And here, what I like to tell you, that it is common in the hilly regions and all. And in the hilly region and all, this particular one produces up the disease, and disease is what? Having a fever. Okay. Along with that, there is a myalgia, and as given up in the question, eschar along with regional lymphadenopathy and a rash. So these all are features of script typhus, and this disease is common in India also. Okay, this particular one is common in India also. Fine. Another thing is, for this you do a test that is termed as Wheel Phalanx test, and Wheel Phalanx test is what? OXK strongly positive. Okay, and that is regarding the scrub typhus. Okay, OXK comes out to be strongly positive, and that is where, that is for the scrub typhus. Is it fine, guys? Now, it is mainly reported for urban areas. No, hilly regions. It is reported mostly for the hilly regions, and in the rural area it can be. Urban areas less. Causative organism is anaplasma. No, I just told up the causative organism is Aurantia sussugamusi, and it is transmitted by what? Mite. What about the anaplasma? Anaplasma, this question came in the, what do you say, AIMS exam. Anaplasma phagocytophilum. As the name suggests, it involves which fellows? Phagocytes. Okay, it involves the phagocytes, and this particular disease is tick-borne. Okay, this particular disease is what? This particular disease is tick-borne. It is spreaded by the tick. Anaplasma phagocytophilum is the organism name, and this particular one does what? It does this. That is human granulocytic ehrlichiosis. Human granulocytic ehrlichiosis. This is what is the disease name, in which obviously what increases up? The granulocytes. Okay, as the name suggests. And where you like basically culture them? You culture them into the human phagocytes only, and there they have a morula-like appearance. This question came, and they all are tick-borne diseases. Now, coming to this, a 2-year-old girl presents to you with fever, sore throat, okay, and you suspect of the swollen lymph nodes here. An enlarged spleen on palpation is observed, and a monospot test is done. It comes out to be positive. What is the likely causative organism you are suspecting? So basically, the age 2-year-old girl is it can happen. Yes, it can happen in this age also. But mainly, what you will get in the exam is like a young age. Fine, because they are talking about the kissing disease. It spreads through saliva. Okay, common among the young age, but here also it can happen off. It is not so that it can't happen by in a 2-year-old girl. Okay, but obviously not by the kissing and all, by the salivary contact of any sort. It happened. So basically, this you know that it is being done by which particular virus? Epstein-Barr virus. And what is the number of the Epstein-Barr virus? HHV4. What does this affects of? It affects of the B cells. Why B cells only? Because B cells have on their surface CD21CR2, and that's why they are attracted towards it and leads to the polyclonal proliferation, and thereby leads to number of carcinomas. And this disease which is being discussed in the question, infectious mononucleosis, which presents with what? Which presents with sore throat. Okay, and sometimes in this disease, what can happen? A formation of pseudomembrane. So there is a formation of pseudomembrane in this particular one. This also you need to know. And in the case of infectious mononucleosis, even the CD4-CD8 ratio can reverse off. That is also an important point to be known. Is it fine? And for this, we do the PCR for the IBNA and the VACA. And VACA is viral capsid antigens. And the organism is herpes virus, HHV4, human herpes virus 4. Okay. Now coming to this one, wherever you see diabetic, immediately a lot of diseases should come in your mind. One of them is this, which is there in the question. Physician with a facial pain and a black necrotic skin lesion beneath the eyes. The patient is non-compliant to the medications, hence suspecting his blood sugar level to be poorly controlled. Okay. The physician advised for a skin lesion biopsy which reveals non-septate hyphae with wild angle branching. So obviously in the question itself, everything is being given off that they are talking about a diabetic patient which is immunocompromised in some sort, complaints of facial pain, black necrotic skin lesions. They are talking about an invasive lesion, rhinocerebral zygomycosis, okay, which can enter into the orbits and all. So basically, this is the rhinocerebral mucormycosis or zygomycosis. And for your information, I should tell that the third name is also there, that is termed as phycomycosis. And when this necrotic lesion, which is because of the angiothrombosis here, you take up this black necrotic lesion, okay, you take up this black necrotic lesion and this black colored lesion, black crust lesion, and put into 10% KOH or H and E stain, what you get this particular type of feature. Okay, and what is that? Aseptate hyphae, obtuse angled. Okay, obtuse angled aseptate hyphae. Fine. So this is obtuse angled aseptate hyphae, which mostly is found wide angled it is, and it can be in this form also that the angle is 90 degree, but this is for sure that this is aseptate. Got my point? And why we are talking about all this mucormycosis nowadays a lot? Because in the case of COVID, these infections, they were very common. And this you already know that this is not a black fungus. Mucor is not black fungus. Actually, it is a black fungal disease, which you can say. The black fungus is what? The black fungus is Phyllophora and Cladosporium. Got my point? This is not black fungus. If somebody says that mucor is black fungus, no. It causes black fungal disease. And why does it cause that? Because of angiothrombosis. Okay. The second option, which is aspergillosis, you know, in that you have dichotomous branching and angle of 45 or 60 degree, and this is having the septa. Okay, this is having the septa. Now, coming to this, while playing the street, a child was bitten by a dog on the both right leg at 2 sides, okay, and left arm at 1 side with constant oozing of blood. So there is a constant oozing of blood, and the sites are 3 round off in this particular one given. What treatment is required according to WHO guidelines? So you know guys, that is class 1 bites. It's just a licking over the intact wounds or intact skin. Second one, it is licking over the broken skin because of some lesion or some injury. There is a broken skin. Over that the licking happened up. That is class 2. And class 3 bite is this sort of bite in which there is a constant oozing of blood. And for the class 3, you know, it is not the observation because this is an emergency. Okay. So only wound management? No. Wound management along with rabies vaccine administration? Fine. Monitoring the dog's health for 10 days? This is okay. But important is wound management, rabies immunoglobulin immediately is to be given up. Which one? Either human or either equine one. Okay, the human is given in the units of 20 units per kilogram and equine is given 40 units per kilogram. Rabies vaccine administration, that is 0, 3, 7, 14, 28, that is being given off, and you have to monitor the dog's health for how many days? 10 days if this happens. So answer is D. This is class 3 bite managed in this particular way. For the class 2, you just give PEP after the wound management. If at all something is there, graze and all, you have to manage that particular thing. There is no oozing of blood. Whereas in the first one, class 1 bite, what happens? In the class 1 bites, just a lick over the intact skin. So you just have to clean it off. A patient presented with painful micturition. Painful micturition is a feature of UTI with increased urgency. Another feature, frequency. The clinician suspects the lower UTI. Okay, and he runs some lab investigations. He runs out some lab investigations, and according to that, the cause concept of significant bacteria, which statement is accurate here? So guys, a bacterial count of more than this, that is 10⁵, more than 1 lakh CFU per ml is deemed as significant. Very right. This is what is termed as significant bacteriuria. This is termed as which particular feature? This is termed as significant bacteriuria, also termed as asymptomatic bacteriuria. This is also termed as what? Asymptomatic bacteriuria. Okay. Means in this, like significant bacteriuria, this can happen, asymptomatic and all. But what you can say here safely, that the person is having the features. So you can't say it is asymptomatic, but this statement of this, that is more than 10⁵ CFU is deemed as significant for sure. Yes, it is there. And even you can say in those patients also very confidently, those who don't have the symptoms, means they don't have urgency, they don't have frequency, they don't have these features of painful micturition and all, they also should be treated because they will be getting this UTI infection very soon. You got my point? Okay. A bacterial count below this suggests an uncertain significance. So this is a wrong statement. The bacterial counts ranging from 10⁴ this are attributed to the presence of commensal bacteria. Not exactly. The criterion is rooted in the understanding that normal urine is not entirely sterile. Because of that only this is there, but not the complete statement. The complete statement is the first one. A bacterial count of this in the cause concept is deemed as significant. Okay, and you can say here the features were given up, that your job is easy. Otherwise, in the asymptomatic also you need to treat if this particular number is coming of E. coli, Klebsiella or any other bacteria. And what is CFU? Colony forming units. Okay, I hope this is clear. What are the screening tests for the UTI, guys? Can you tell me? Grease nitrite test, leukocyte esterase test, catalase test. These are the screening tests. And what is the confirmatory? Confirmatory is culture. Culture on which media? CLED. Why? CLED is preferred because it is non-selective. Got my point? Which of the following statements is incorrect regarding the pneumocystis pneumonia? Pneumocystis zerovicii pneumonia, obviously. Okay? The PCP is also termed as, PCP is also known as plasma cell pneumonia. This statement is correct. It is also termed as plasma cell pneumonia. The CT lung imaging typically shows ground glass opacities, that is GGO. True. This is also true. Okay. The causative agent is pneumocystis zerovicii, has a name only suggests pneumocystis. So that is, the causative agent is this only, but controversial it is. Some says it's a fungus, some says it's a protozoa because it exists in citral trophozoite. And even one more interesting thing is that it exists in like commensalism with whom? With trichomonads, that is Trichomonas vaginalis. So that infection also is common in these fellows. If obviously that's female and all. This particular infection is common with pneumocystis zerovicii infection. So this can come. It correlates with each other infection. The pneumocystis can't be cultured. Very right. It can't be cultured. Serological tests are used for diagnosis. No, guys. You know that the sample of choice is BAL, or another one is termed as gastric washings. So one is BAL and one is gastric washings. And what is BAL, guys? Bronchoalveolar lavage fluid. Okay. bronchoalveolar large fluid taken by the bronchoscopy and other gastric washings, and you put this particular stuff into what? You put it into the GMS. And what is GMS? Gomori methamin silver, and because of that, the cyst turns out to be black, and our trophozoite here turns out to be green. Okay, this is turns out to be green. So cyst turns black. Okay, cyst turns black, and the trophozoite turns green. That is G for G. Okay, and why the cyst turns black? Because it has glycogen in it, and one important thing is it has glycogen, and it looks like a crushed ping pong ball appearance. Is characteristic of the cyst in the case of pneumocystis cerevisiae pneumonia. At which CD4 count it happens? It happens at CD4 count of less than 200. And which drug of choice you use for this? That is cotrimoxazole. That is cotrimoxazole. Is it fine? Now coming to this, which of the following organisms responsible for causing cat scratch fever or cat scratch disease? This you already know, Bartonella Hansley. So Bartonella Hansley, I already told up in the class also that you were playing with your cat, that is the pet, and haste that she scratched you. So the Bartonella Hansley does the cat scratch disease, which is also termed as, this cat scratch disease is also termed as what, guys? This particular cat scratch disease is done by this Bartonella Hansley is having certain granules, which is being asked, that is the stellate granuloma. So stellate granuloma is seen in this, and there is involvement of the various viscera like liver and spleen in this particular one disease that is done by this cat scratch disease. Chaffinensis, Ehrlichia chaffinensis, this leads to human monocytic ehrlichiosis. Human monocytic ehrlichiosis, and as the name suggests, what is increasing of in this? Monocytes. Then have Rickettsia rickettsii. This leads to Rocky Mountain spotted fever, and this is a tick-borne disease. Okay. Coxiella burnetii leads to Q fever. Okay. Other than that, a potent question is, this associates with culture negative endocarditis. This particular one associates with culture negative endocarditis. Which one? The Coxiella burnetii. Okay. So these are the various important questions which you focus upon in this particular NEET PG, and you should read around these particular topics also. A lot of topics are there as such, but definitely they are the ones which are being repeated again and again. And if you focus upon these particular topics properly, along with my videos and notes, and stay tuned to the Alan Next YouTube channel. There we does previously also a lot of things, and in the future also we'll be doing a lot of activities regarding the NEET PG, because NEET PG is approaching up, so we'll be having some series regarding the important questions. Obviously there will be more than this, and it will be very beneficial because we try to cover up a lot of things in that particular session. Okay, so very best of luck from my side. I hope you have done good in this, and in the main exam also you will do wonders. So thank you so much. Take care. Bye bye.
Hello everyone, welcome to the discussion of pediatric questions that came in your CBoT 5. So let us start with the first question, and that is, which of the following is higher in preterm breast milk? So for this, we have to remember a mnemonic. I hope everybody is aware of that mnemonic, and this is SIP for intelligent CNS. So preterm milk Composition of preterm milk is very different from that of a milk coming from a mother who has delivered a term baby. So that means the composition of the breast milk also changes as the gestation proceeds forwards, right? So preterm milk is supposed to have more content of many things which are lesser in term milk. And what are those, constituents which are more in preterm milk? Let us see that. So for this, we have a mnemonic which is known as SIP for intelligent CNS, right? So S stands for sodium, right? Then I stands for iron, P stands for proteins, then F stands for fat. Then intelligent CNS, for this we will only pick up the I and C, right? So I stands here for immunoglobulins and C stands for calories. So that means in a preterm milk, iron is more, sodium is more, immunoglobulins are more, calories are more, and of course the proteins and the fat content is also more. So this is how you have to remember. I know a bit of difficult thing, but if you remember the mnemonic, it is very easy. So as you can see, the answer over here is going to be iron, because of all the more constituents. Calcium, vitamin D and vitamin K are not more. In fact, we should know that vitamin D content of the breast milk and the vitamin K content of the breast milk both are very, very low, and hence we have to supplement both of these vitamins from outside. Vitamin K immediately after birth by means of an intramuscular injection, and vitamin D we supplement as long as the child is, on exclusive breastfed, very importantly, and till the first year of life, the dose is 400 IU per day of vitamin D that has to be given. And after first year of life, then the dose of vitamin D can be increased to 600 IU per day. So this is how we have to remember that vitamin D and K are deficient in breast milk. Here I would like to add one more thing which most of the children go wrong on, and that is the vitamin C content. Always remember the vitamin C content of human milk is satisfactory. It is not low. The content is around 5 to 15 milligram per 100 ml. So vitamin C content of the breast milk is not low. Always remember that. Of course, you should know that vitamin C content of cow's milk is very, very low. So that is very, very low. In fact, we should write it is almost around 0.2 milligram per 100 ml. Can you see the difference between 5 to 15 milligram and something like 0.2 milligram? And moreover, vitamin C being a heat labile vitamin. So if you are supposed to boil the cow's milk, the moment you boil the cow's milk, the vitamin C content of cow's milk goes very, very down, because vitamin C is a heat labile vitamin and gets destroyed in the process of boiling. So, you usually get a question in the scenario, they build up a scenario like this. A child has been fed on boiled cow's milk and now has come with, inability to move his lower limbs and extreme irritability, and there is, some outpouchings or some prominence of the ribs. What are we dealing with? So, of course, they are going to give you the scenario of scurvy in this case, where prominence of the ribs would be something like scorbutic rosary, and not able to move the lower limbs is because of the subperiosteal hemorrhages, which is so very characteristic of scurvy. So always remember this. The vitamin C content of human milk again is not low. The only two vitamins which are deficient in human milk are vitamin D and vitamin K, right? Now, apart from this, we should be knowing about certain types of milk. You are often asked about, let us say you should know what is colostrum. So colostrum is the the milk which is secreted in the first 3 days of life. And remember, it is yellow in color, and it is rich in antibodies, it is rich in fat soluble vitamins, and it contains more proteins and more growth factors, right? So how do you remember? It is rich in antibodies, and since it is rich in antibodies, so there are more proteins present in this milk, and it is yellow in color. In fact, you should know one secretion of the body which is the richest source of IgA, and that is your colostrum. So this is one thing which you should be knowing. And of course, even the vitamins like A, D, E and K are also abundant in colostrum. So that is all about colostrum. Coming to the another kind of milk, what you should be knowing right now is the transitional milk. So transitional milk is the milk which is secreted, somewhat in between the after the colostrum and before the appearance of mature milk. So this transition which takes place from colostrum to mature milk, this takes place from the 4th day onwards till up till 2 weeks. So during this period, the milk, the breast milk which is secreted by the mother, it is known as the transitional milk. Now slowly and slowly what will happen, the immunoglobulin content and the protein content of the transitional milk, it goes on decreasing, remember this, and the fat content and the carbohydrate content goes on increases. So fat and carbohydrate content goes on increasing. This is how the transition takes place between the colostrum and the mature milk. Now coming to the mature milk, how does this this appear? So mature milk, usually it appears around 2 weeks after delivery. So after 2 weeks of delivery, mature milk appears, remember that, and this is more thinner as compared to colostrum, and this is more thinner. The composition is almost 75 to 80% composition is composed of water. But remember, although it is thinner, but it is although this is thinner, but it is best for the baby. Always remember this, it is best for the baby. So that is your mature milk, where the comparatively as compared to colostrum, the carbohydrate content and the fat content goes on increasing. So that is it. So I think we have covered this appreciably. Now let us move on to the next question. A pediatric resident gets a call as a female was about to deliver a baby. After the delivery of the baby, the resident calculates APGAR score at 1 minute of life. Which of the following is not true about the APGAR score? So let us see, let us analyze all the options. So it is calculated at 1 and 5 minutes of life. Is it a true statement or a false statement? We have to single out not true, that means a false statement is asked over here. So it is calculated at 1 and 5 minutes of life. Of course, this is a true statement. It is useful tool to guide the steps of resuscitation. This should be very clear, children, that APGAR score is never used to guide us for the resuscitation of the baby. You have seen that we have studied the neonatal resuscitation protocol, the NRP protocol as it is known, in detail, and the NRP protocol, nowhere over there the APGAR score is considered as a guide for future steps for deciding the steps of resuscitation. So that should be very clear. APGAR score. Now the question comes, फिर ma'am APGAR score calculate ही क्यों करते हैं? So this is just a retrospective way of seeing the wellness of the baby during shortly after birth, how good or how nicely the baby adapted to the external surroundings, and this has a bearing effect on the future development of the baby. And this is also a very important kind of information in the baby's document, where the other doctor can come to know, if the baby shifts to another area or another pediatrician. So the other pediatrician can come to know what happened immediately after birth. If you are not even going to mention in words, at least APGAR score will convey the information to the other doctor that, of course, if the APGAR score was lower at birth, so this child suffered some amount of asphyxial insult during birth, and hence probably that is the reason why now at, let us say, at 8 months or 9 months or maybe 6 months of age, the baby is having delayed development. So this is just a retrospective score, number one. Number two, only for, in conveying the information about what happened at birth and not for deciding the future steps of resuscitation. So therefore, this is the false statement, and this is probably going to be our answer. But let us see. If the score at 5 minutes is less than 7, then additional scores should be assessed every 5 minutes up to 20 minutes. So children, the C option is absolutely correct. This is taken straight from Nelson. In Nelson, we have this line written that at 5 minutes, if the APGAR score is less than 7, then you keep on, assessing the baby till at least 20 minutes. And then falsely low APGAR score can result from prematurity or drugs given to mother during labor. again, this is a very, very true statement which you should be knowing, that sometimes what happens that the baby is depressed, and because of which the APGAR score is low, not because of some innate problem or intrinsic problem with the baby, but because of the drugs given to the mother. Now, what all drugs can result in this? So you have to remember, drugs given to mother, let us enumerate that for you. So if the mother has been given magnesium sulfate, that is one of the drug that can result in the respiratory depression of the baby, and hence the low APGAR score of the baby. Other than any narcotics being given to the mother, or sedatives being given to the mother, right? Or any kind of analgesics given to the mother, even that can result in the baby having low APGAR score. And other than that, a very important feature of the baby that can result in low APGAR score is the presence of prematurity. So do we have any other causes wherein we can have falsely low APGAR score other than asphyxia? So we've already seen prematurity as one of the cause of low APGAR score, falsely low APGAR score. So falsely low APGAR score can be seen in. So prematurity can be there, then maternal drugs, which we have already enumerated. We will not go into details. Other than this, any kind of trauma to the baby. So acute cerebral trauma to the baby, or if the child is born with some lung anomaly or the CNS anomaly. So CNS anomaly or lung anomaly like diaphragmatic hernia. So in that also, congenital diaphragmatic hernia. Please remember, CDH over here stands for congenital diaphragmatic hernia, and not dislocation of hip. So lung anomaly, CNS anomaly, or any kind of precipitous delivery, or let us say airway obstruction in form of choanal atresia, or congenital pneumonia and sepsis, all this can give rise to falsely low APGAR score. So let me write it down for you. So congenital pneumonia or sepsis, and as I told you, some kind of airway obstruction like choanal atresia, all these can result in falsely low APGAR score, right? Now, even the precipitous delivery, as I was telling you, or precipitate labor, as we call it, precipitous delivery, or kind of any neuropathy also if present in the child, right? So we call it congenital neuropathy because we are talking about soon after birth. So even that can result in falsely low APGAR scores, right? Then sometimes we have falsely high APGAR scores. So what can be the reasons for the same? So let us enumerate that also for you, just in case you get these questions in your INI-CT exam. So falsely high APGAR score will be seen when there is maternal acidosis, or when there is high fetal catecholamine levels, right? And number 3 would be in some full term infants for no reason, full term infants, we can get to see falsely high APGAR score. That means, so that is why APGAR scores are never used as a tool for deciding the steps of resuscitation of the baby. Never ever in your neonatal resuscitation protocol you will see that you are deciding the other step, whether to go for chest compression or to begin with bag and mask ventilation, depending on the APGAR score. So that should be very clear to you, right? Correct answer is going to be the B option, that it is a useful tool to guide the steps of resuscitation. This is a false statement. Let us come to the next question. A 3-week-old infant is brought to a pediatric emergency with refusal to feed and lethargy. On examination, very importantly, the pulse is feeble with cold extremities and a capillary refill time of greater than 3 seconds. So that means the child is almost in your hypotensive state or shock, right? The child is also found to have ambiguous genitalia. Investigation reveal serum sodium of 118 milliequivalent per liter, that means low sodium is there, and serum potassium of 6 milliequivalent per liter, that means it is on the higher side. So what we are getting is hyponatremia and hypercalcemia, hypokalemia, and you have a blood sugar of 25 milligram per deciliter, that means hypoglycemia, and of course the child is having ambiguous genitalia and is in shock. Ambiguous genitalia with shock. Now, surprisingly, in this question, if you see, they have not mentioned the sex of the baby. So that means how can you determine the sexes if already in the question sometimes, looking at the genotype, if the sex has been mentioned, that is a female baby with ambiguous genitalia or a male baby with ambiguous genitalia. But here the sex of the baby is not mentioned. So whenever you have this kind of scenario, this is for sure, considered to be the hallmark of congenital adrenal hyperplasia. So we are dealing with a condition which is known as congenital adrenal hyperplasia. Now there are many enzyme deficiencies in the steroidogenesis pathway which lead to the production of the hormone secreted by the adrenal gland, and the enzyme deficiencies in this pathway results in the child developing CH, that is 21 hydroxylase deficiency. Now always remember two enzymes which result in hypertension, whose deficiency result in hypertension and not a shock. So they always begin with 1. Remember, that's mnemonic. So enzymes which are beginning with 1, okay, with numeral 1. So that means either 17 alpha hydroxylase deficiency or 11 beta hydroxylase deficiency. Both of these enzymes, they begin with 1. Can you see that? So in both of these, remember, the cardinal feature will be hypertension. Hypertension means obviously the blood pressure is high, and you can see over here the scenario given is totally opposite. That is, the pulses are feeble with cold extremities and the capillary refill time is more than 3 seconds, indicating a low blood pressure, right? So definitely your 11 beta and 17 alpha would not be considered here as a differential diagnosis. Why? Because all enzymes resulting in enzyme deficiencies resulting in CH, if beginning with 1, results in hypertension and not shock. But the scenario given over here is shock. So definitely what we cancel out is 17 and alpha. Now what about the rest? So let us see what are the rest of the enzymes. So one enzyme is 21 alpha hydroxylase deficiency, which is left. Another enzyme is 3 beta hydroxysteroid dehydrogenase deficiency, and the third enzyme is cholesterol desmolase deficiency. And there is one more enzyme which has absolutely same manifestation as cholesterol desmolase, and that is star enzyme deficiency. And if you want to see what is the full form of star, so you can see the fourth option given in your question, that is steroidogenic acute regulatory protein deficiency. So that is the full form of star enzyme deficiency. Now all these 3 or 4 enzymes that you are seeing, all of them result in shock. That is very clear. That should be very clear with you, that all results in CFT more than 3 seconds. Remember that. And peripheral perfusion compromised and cold clammy extremities. So sometimes they would not use the word shock, but it is for you to pick up that what is given in the question paper, that in the question that is suggestive of shock. So all these features are features of shock, and these all 3 or 4 enzyme deficiencies, as you can see, they result in the child presented to you with shock. Now the question arises, how do you differentiate among them? So definitely it all depends on the sex of the child. If it is a female child with ambiguous genitalia, so female pseudo hermaphrodite in this case will be having 21 alpha hydroxylase deficiency, while males will have normal genitalia, can also land with 21 alpha hydroxylase deficiency. 3 beta HSD, both female or male, both of them, either of them having ambiguous genitalia with shock can have 3 beta HSD. And of course, in cholesterol desmolase and star enzyme deficiency, it is usually the male children who present to you with ambiguous genitalia, while the females will just have delayed puberty. Remember that, right? So the same thing, has been very nicely tabulated in a table kind of thing, which you can see over here. Although, many years back, there was a question in the AIMS PG entrance examination when there was no INI-CT. The AIMS PG entrance used to be different as compared to your PGI entrance. Every big institute had a separate PG entrance exam. There they had asked a question on cholesterol desmolase deficiency, but otherwise these are the common enzymes, and of which the most common enzyme, more than 90% cases are because of the 21 hydroxylase deficiency. So the same thing what I have discussed with you, you can go through this table and you can understand. Now coming back to this, so since these are the three enzymes whose deficiency result in shock, and we know that the commonest enzyme deficiency resulting in shock with ambiguous genitalia, and specifically if the gender of the baby is not revealed, the true gender depending on the genotype, then what we are dealing with is 21 hydroxylase deficiency straight away. If you do not have any clue, but please don't do this blunder if in the scenario given what is mentioned is hypertension, because if hypertension is mentioned, then you have to consider either 11 beta or 17 alpha hydroxylase deficiency. But in this case, since it was shock with ambiguous genitalia, so aankh band karke your diagnosis becomes 21 hydroxylase deficiency. Remember that, right? So this is how we are going to attempt this question. Let us move forward to the next question, and that is the next question. A group of students in a school were evaluated for rheumatic fever. Which of the following is not the major criteria as per revised Jones criteria used for diagnosis of rheumatic fever in this school, where most of the students belong to a population where the prevalence of rheumatic heart disease is less than 1 per 1,000. So here we have to remember, as per the 2015 revised Jones criteria, which came in 2015. So in this case, at that time, it was proposed that the population has to be divided into two categories. And what were the two categories? Let us see that. One was your low risk population, right? And the other category was your moderate to high risk population. Right, these were the two categories. Now, how do you define these two categories? So this was based, the definition of low risk or keeping the population as moderate to high risk was based on the prevalence of the heart disease, and the second is incidence of the rheumatic fever in the school going children. So the prevalence has already been highlighted in your question. This is the same prevalence which is used to define the low risk population. That is, if the prevalence of the heart disease, right, in the population is less than 1 per 1,000, then it is a low risk population. Remember that. And anything above this will be considered as moderate or high risk population. Number one. Number two is the incidence of the rheumatic fever in the school, incidence of rheumatic fever in school going children, right? So if this incidence is less than 2 per 1 lakh children, right? So 2 per 100,000 children, school going children. If this is less than 2 per 100,000 children incidence, then we consider it as low risk population. Any incidence which is more than 2 per 100,000 children or 1 lakh children, we consider it as moderate or high risk population. And after division of the population, the criteria also have been changed. Definitely, what is the idea is that for a high risk population, the threshold for the diagnosis of rheumatic fever is to be low. So that means we consider many things as major criteria so that it is easy to make a diagnosis of rheumatic fever and we can go ahead with the treatment of acute rheumatic fever, right? So that is the idea, that in low risk population you keep your normal criteria, while in high risk population you ease up on the criteria, you include many more things in as a major criteria so that your diagnosis becomes simpler, easier, faster, and you can start the treatment early because the child is coming from a high risk population or a moderate risk population. That is the idea. Now coming to this, that once we have divided the population, how do the criteria differ? So what is the major difference that has come in the criteria? See, previously we used to see very clearly, say very clearly that major criteria is carditis, arthritis, chorea, erythema marginatum, and subcutaneous nodules. That's it. In 2015, they included many more things. So what were the many more things? Let us see. First, carditis, even subclinical carditis was considered as a major criteria. What do you mean by subclinical? That means clinically the child is not having any signs, but on echocardiography, if your getting features of carditis, please consider as, major criteria and go ahead with the treatment, right? Another thing which came in this thing is, before 2015, only polyarthritis, migratory polyarthritis was considered as the major criteria, and that continued as a major criteria for a low risk population. Now, if we have to compare for a high risk population, polyarthritis as well as monoarthritis, this is new. So, I am writing N for you. So, monoarthritis also can be taken as a major criteria. So, that you have to remember, but this applies only and only to moderate or high risk population. Remember that simultaneously. Another thing which was added in 2015 revised Jones criteria was that even if the child having polyarthralgia, remember before this, arthralgia, polyarthralgia all used to come in only and only minor criteria. But in 2015, polyarthralgia was also placed in major criteria only and only for the moderate to high risk population. So, that was another thing which was done. Now, coming to the minor criteria, in minor criteria, since polyarthralgia went into major criteria for a high risk population, so what was left for the moderate to high risk population was only and only monoarthralgia if present, that was considered as minor criteria, while monoarthralgia had no role when we were dealing with low risk population. So, that is it. So, I can write this monoarthralgia and I can then cross it for you, that no role over here, right? ESR, the high ESR was considered as more than 60 mm in the first hour, always for a low risk population. But for a high risk population, this cutoff was lowered, that even ESR which is more than 30 mm in the first hour is to be considered as a high ESR, and you can take it as, positive lab value. So, that was, these are the major differences while seeing whether the child is coming from a low risk population or a moderate to high risk population. Now, let us see the question. You can see very well the child is coming from a low risk population. The question given over here is that which of the following is not the major criteria if the child is coming from low risk population. So, let us see, is chorea major criteria? Yes, it is. If erythema marginatum? Yes, it is. Subclinical carditis, I told you, both for low risk population and moderate to high risk population, subclinical carditis is the criteria. What is not the criteria is polyarthralgia. Remember, polyarthralgia is considered as a major criteria if the child is coming from moderate to high risk population. Then only it is considered as a major criteria. Otherwise, remember, polyarthralgia in case of low risk population. So, if the child is coming from low risk population, then polyarthralgia will be considered as, very importantly, minor criteria and not major criteria. So, this is your odd man out, and this is the answer in this case, because they had asked which of the following is not the major criteria for a child who's coming with the prevalence of this, which is nothing but your low risk population, right? So, I hope you understood it. Yeah, I know it is a bit of tricky question, but you have to remember it. We can't help it in this case. So, let us come to the next question. A child presents with respiratory distress and failure to thrive. His sweat chloride levels are raised. Mother gives a history of cystic fibrosis in her elder sibling. Which one of the following is false about cystic fibrosis? So, cystic fibrosis occurs due to dysfunction of cystic fibrosis transmembrane conductance regulator protein. Yes, this is true. Very, commonly this is referred to as CFTR, and the gene, coding for the same protein is referred to as CFTR gene. So, of course, there's a mutation on the CFTR gene. We all know this is located on long arm of chromosome 7. Okay? So, this is located on, let me write it down for you, long arm of chromosome 7. So, this is your CFTR gene coding for this protein. Second, so this is a true statement. We are going for the false statement. So, this is true over here. Chronic metabolic acidosis is a common finding. Of course, no. What is a common finding is the metabolic alkalosis and not metabolic acidosis. So, definitely this is going to be a false statement. Probably this is the answer, but let us see the other options as well. Infection with Burkholderia cepacia is associated with high mortality. This is again a very, very true statement. Whenever whenever you see this organism, always think about cystic fibrosis, right? It usually, when the mucus becomes thick and tenacious, then Burkholderia cepacia, Pseudomonas aeruginosa are, common organisms resulting in pneumonitis in these children. It has an autosomal recessive inheritance, of course. Even if you are asked in your sleep, you cannot forget the inheritance pattern of cystic fibrosis. You have to remember it is autosomal recessive disorder, right? Now, so the correct answer over here is going to be the B statement, that is chronic metabolic acidosis is a common finding. No, the correct answer over here should have been the chronic metabolic alkalosis. That is the common finding in cystic fibrosis, right? So let us brush through the diagnostic criteria of cystic fibrosis quickly. So one of the following and one of the following should be there. So out of these three, 1, 2, 3, only one if present, and out of this again one if present, then you have a positive for diagnostic criteria for cystic fibrosis. So what are these? Let us see. Sweat chloride concentration of more than 60 millimole per liter on at least 2 occasions, or 2 CF causing mutation. We all know the commonest mutation which is seen in our population is delta F508. Although in Ashkanki's use, the mutation commonly seen is not delta F508, it is something different. But here in our country, it is delta F508. So any 2 CF causing mutations if present, abnormal chloride transport, which is assessed by measuring the potential difference across the nasal membrane. So any one of these 3 criteria and one of the clinical characteristics typical for CF, yes, Burkholderia cepacia is considered to be typical of cystic fibrosis, sibling with cystic fibrosis, or a positive newborn screening, which is assessed by a immunoreactive trypsinogen test. So this is how we make a diagnosis of cystic fibrosis. Remember these criteria. Rest assured, in every exam, you always get a question on cystic fibrosis. So please go through this topic very, very nicely, right? Let us come to the next question. A mother brings a 1.5-year-old child with complaints of epileptic spasms occurring in clusters, especially while the child is getting up from sleep. On examination, you notice global developmental delay. Skin findings are shown below. What is the treatment of choice for this condition? So there is a 1.5-year-old child, let us see, and the child is having this epileptic spasm occurring in clusters. We know this is very commonly referred to as infantile spasms. We know the diagnosis is infantile spasms in this case, and especially when the child is getting up from sleep or going to sleep or being put to sleep, even that time infantile spasms are very common, and they come in volleys, they come in clusters. Volleys as in you write it down like this, they come in volleys or clusters, one in the same thing, right? Both words, they mean one and the same thing. On examination, you notice global developmental delay. Of course, this is again a positive finding, and the skin findings are shown below. So what are we seeing over here? So this is nothing but ash leaf macules, very, very typical, of tuberous sclerosis. And this in the lower back, in the lower lumbar region, what we get to see a lesion like this, which is having, numerous pits. You can see, if I have to enlarge, this is numerous pits present over here, and this is referred to as shagreen patch. And when we see shagreen patch and ash leaf macules, what comes to your mind? Yes, you guessed it right. My diagnosis becomes tuberous sclerosis. Yes. So my diagnosis becomes tuberous sclerosis. Now, what is the drug of choice for infantile spasms and what is the drug of choice for infantile spasms and tuberous sclerosis? Both the things are different. I hope you know this. Drug of choice for infantile spasms is, yes, we give a pulse therapy with ACTH, a continuous 14-day or a 28-day therapy with ACTH, followed by steroids. This is what we do, and then we can go on to add other antiepileptics as well. Drug of choice for infantile spasms associated with tuberous sclerosis. Now there's a twist in the story. Everybody knows here the drug of choice becomes vigabatrin. So since in the given question the child is having features of tuberous sclerosis, therefore our drug of choice will not be ACTH. The drug of choice in this case is going to be vigabatrin, right? So therefore, the correct option is vigabatrin and not ACTH. Had these skin lesions not been mentioned, only global developmental delay must have been, if mentioned in your question, and these skin lesions, no comment on the skin lesions, then please go for the option of ACTH, right? So now let us move to the next question. A neonate is born with small head, small eyes, sloping forehead, cleft lip and palate, post-axial polydactyly and bulbous nose. He is also found to have hypoplastic ribs and low set ears. What is the diagnosis? बच्चों, every year, every exam, you get at least one question on syndromes, right? Down syndrome. So common syndromes you should be very well aware of. So let me, help you with the list of the common syndromes. So you should be knowing about Down syndrome, right? And then you should be knowing about Edwards. You should be knowing about Patau syndrome. Then even Noonan syndrome is very important. Turner is very, very important. Klinefelter, again, very important syndrome. So at least these syndromes you should be very well aware of. Of course, see, आने को तो फिर क्राइडू चैट and Rubinstein type B and sky is the limit. But at least these are the common syndromes which you should be aware of, right? So now let us see the figures given over here. You can see this cleft lip and even cleft palate you can make out is there, and the child is definitely having a bulbous nose, and there is polydactyly, that is very, very clear over here. And here also you can see there is polydactyly and some amount of overlapping. Now what are we dealing with? See, one thing is very sure that this child is not a case of Down syndrome, because in Down syndrome there are many other features. The child will be having something like sandal gap. So child will be having something like sandal gap, and the child will be having many other things like simian creases there. Then you have the mongoloid slant of the eyes, brush field spots on the iris, and then you have the commonest congenital heart defect seen in Down syndrome is endocardial cushion defect. So that kind of scenario is not given here. Even the face of the child does not look like that of a Down syndrome, which we are so aware of and so accustomed to seeing a child with Down syndrome. I hope I know every one of us is actually capable of making a diagnosis of Down syndrome. So definitely Down syndrome is not to be considered over here. What about Turner? That is also straight away struck off, because Turner syndrome, you will get a usually it is a female, and then the child will be having a shield chest, and if it is a adolescent female, then she'll be having, amenorrhea is there, short stature is there, and then, wide carrying angle is there. Then you have the commonest congenital heart defect over there as bicuspid aortic valve, and the second commonest being coarctation of aorta, and then hyperextensible joints can be there. Pectus excavatum, pectus carinatum will be there. So there are low hairline, webbing of the neck. So all these features are, they tell us that this is Turner syndrome, and we are all again aware of the child, a female who presents with Turner syndrome. Now, the biggest confusion over here is whether to go for Edwards or the Patau syndrome, right? Now, very importantly, you should know that we know Edwards syndrome is trisomy 18, right? And Patau syndrome is trisomy 13. Now, this is, again, this will not help you solve this question. This is just an additional kind of information. Now, what will help me solve this question? Let me see this. So, first of all, remember that if the nose is bulbous, then this is Patau syndrome. If the nose is narrow, then this is Edwards syndrome. So, we'll keep yes, there is, these differences are given, but still I would like to make, more informative kind of, table over here, so that you are able to solve in future also any questions that come on Patau or Edwards syndrome, right? So here we would write Patau syndrome, and here you would write Edwards syndrome, right? Okay. Now, the trisomy, we already know this is trisomy 13 and this is trisomy 18, right? If we have to see for the, survival rate, it is poor in both the patients. Still, if you want a comparison, so 88% they die by first year of life, and here 80% die by first year of life. So we know that the prognosis is very, 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 very poor in Edwards syndrome. Both are having VSD as the commonest heart defect. Right, now let us see what are the differences. So as I was telling you, very importantly, bulbous nose if present, that is more a feature of Patau syndrome, while here you will be having a narrow nose. Very, very important difference. Another thing is clinodactyly. Now, what is clinodactyly is when there is some defect in the middle phalanx of the finger, and because of it, what happens, the middle phalanx or the is more or less a wedge shaped kind of phalanx, and because of that the finger starts curving, and since the curve of the finger can be to that extent that it starts overlapping the other fingers. Now please remember, if there is just clinodactyly, then this is Patau syndrome. But if there is clinodactyly with, now clinodactyly can also have curving of, curving of fingers. I'll write it down more legibly for you. So, curving of fingers with overlapping. So, overlapping can occur when the curving is extreme. Now, this overlapping is a very important hallmark feature of Edwards syndrome. Remember, it can be seen in Patau syndrome also, but it is very, very, very specific and very, very, hallmark feature. Now, how do I remember that is? So, remember overlapping fingers, what happens is the index finger, it overlaps over the third finger, and the fifth finger overlaps over the fourth finger, right? So, polydactyly is a feature of both the disorders. So, if I have to write down, polydactyly will be seen over here also and over here also, both the disorders. But the inclinodactyly, if you are having the, second finger or the index finger overlapping the third finger and the fifth finger overlapping the fourth finger. So, you can understand the overlapping is from this side also and from this side also, right? So, if this is there, then this is very, very specific for Edwards syndrome, overlapping the fourth finger. Another important feature of Edwards syndrome, which will always be mentioned in your, question if they want you to make a diagnosis of Edwards syndrome, is the presence of rocker bottom feet. Rocker bottom feet again is a feature of Edwards syndrome. Another very important feature of Patau syndrome, which you have to remember, is cleft lip and palate. Now you will see this feature over here also. Here also, I'm writing cleft lip and palate, but see, in Patau syndrome, cleft lip and palate occurs to the extent of 60 to 80% of children with Patau syndrome will have cleft lip and palate, while here, the percentage has not been mentioned. So you can understand this is not a very significant feature of Edwards syndrome. So what is significant feature of Edwards syndrome, you have to remember, is the typical overlapping if mentioned in the question. Clinodactyly can occur both, overlapping can occur both, but the typical pattern of overlapping if mentioned in the question, think about Edwards syndrome. Another thing is the narrow nose over here, while here it is the bulbous nose, right? And of course, if there is rocker bottom feet mentioned, then to rocker bottom feet or the club foot, then to that is a feature of Edwards syndrome, right? Other than this, if I have to, tell you more differences between Edwards and Patau syndrome. So, Patau syndrome was over here and Edwards was over here. Yeah. So, another feature is in Edwards syndrome, you will have a very prominent occiput, मतलब पीछे का सर तो very prominent, and आगे you will have retrognathia or a micrognathia. That means this will be very small. This will be inside. The chin will not be so well formed as I am having, but it will be more towards the more depressed inwards. So retrognathia, or you can call it micrognathia. So that is again a feature of Edwards syndrome. In Patau syndrome, as compared to this, what you get to see is microphthalmia. That means very, very small eyes. And sometimes you will get to see something known as holoprosencephaly. And one more thing over here is in holoprosencephaly, very importantly, cyclops. What is cyclops is when you have such a facial feature where there is only one eye in the center. There are not two eyes, there is only one eye in the center. That is a feature of holoprosencephaly, and that is also known as cyclops. Okay? Other than that, you can have scalp defects like cutis aplasia that can be there in Patau syndrome, right? So these are, very important differentiating features. And last but not the least, if you can remember, in Edwards syndrome, you will get to see inguinal or any kind of abdominal hernias, while here in counterpart, what you get to see over here is renal anomalies. Although renal anomalies, nothing is specific, but of course this kind of presentation is seen in Patau syndrome, while the Edwards we have already diagnosed. Now let us come back to the question. So you can see over here, this child is having a bulbous nose, this child is having a cleft lip palate, this child is having polydactyly, right? This child is also having overlapping of features. But is this child having rocker bottom feet? Have they mentioned the finger, the second finger or the index finger overlapping the third finger, or the fifth finger overlapping the fourth finger? Have they mentioned like this? Have they mentioned rocker bottom feet? Have they mentioned hernias? Have they mentioned retrognathia? Have they mentioned, prominent occiput? If they have not mentioned these three, four things, then my diagnosis goes with Patau syndrome. Remember that. So I'll just show you the, features of Edwards syndrome too. Yeah? So this is micrognathia I was talking to you about. Very, very prominent occiput. If you can see over here, I'll show you once again. So now you pay attention. So this is just a very, very prominent occiput over here, right? And of course the renal defects and heart defects, all this can be here. And one more very important feature why I have specifically put this kind of picture is limited hip abduction. So limited hip abduction, that is also a feature. So that is why you are seeing like this, and you can see the feet like this. This is known as the rocker bottom feet. So limited hip abduction is a very important feature of Edwards syndrome. And of course the retrognathia and the prominent occiput, such kind of feature was not there in the question. So therefore my diagnosis becomes Patau syndrome. That is because of the trisomy 13, right? Let us move on to the next question. So this a 2.5-year-old child was brought to the pediatric outpatient department with complaints of discrete erythematous maculopapular non-pruritic rash starting from the trunk. There is a history of fever in the preceding 3 to 4 days with an episode of seizure during this febrile illness. Parents also reported that there has been no recurrence of fever after the eruption of rash. On examination, the child is afebrile and there are no signs of meningitis. The most probable diagnosis is, so see, the child had some kind of rash which started from the trunk. Important is non-pruritic. So the moment you say non-pruritic, yes, what goes out of my mind is varicella, chickenpox. This cannot be chickenpox because chickenpox lesions, they start from the trunk, but they are intensely pruritic. So this is not. And the illness started with rash again. So this is not measles over here. Why? Because measles illness, it starts with fever, and on day 4 of fever the child comes up with rash, and rash always starts from face, right? And very typically from behind the ears and from the upper part of the neck, and then comes and from the periphery of the scalp, and then comes and involves the face in a confluent manner. So is this description matching measles? No, it is not, right? So it is not measles. Then very importantly, there is no specific, because the rash is starting from the trunk, what is again striked off is erythema infectiosum. Why? Because this is the slap cheek appearance. That means the rash begins from the face and then goes and involves the trunk, and then undergoes central clearing to finally assume a lacy reticulated appearance. And why lacy reticulated appearance on the trunk? Because the rash undergoes central clearing because of that. So is such kind of description given? No. So erythema infectiosum is out. Then what about meningococcal meningitis? Meningococcal meningitis, yes, the rash can be there. It has to be a petechial rash, and the child will be very sick, and the sensorium will be clouded, and of course the child will be running high grade fever. It's a kind of very toxic illness. That is what is seen in meningococcal meningitis. RVC, and of course in meningitis, the signs of the meningeal signs will be there. But we can see over here the child is not having any signs of meningitis. The child is afebrile, and very typically what is mentioned in the fever is with the eruption of rash, the fever, there has been no recurrence of fever. So, this is definitely not meningococcal meningitis, and in fact, this is the cardinal feature of roseola infantum. The moment the rash erupts, the fever comes down. So, what we see in the clinical practice, if you can remember this, पहले बच्चे को बुखार दिखाने आए, and after 3-4 days the phone comes that okay, now the child is having rash, we want to visit you, and we see the child is totally active, playful, but the parents are very worried because rash aa gaya hai, and typically the fever is gone. So that is what we say, that this is roseola infantum. This is also known as, yes, we know this, exanthum subitum, right? And this is also known as the sixth disease. Remember this. Why sixth disease? Because it is caused by human herpes virus 6 or human herpes virus 7 infection. And this infection, this virus infection is also, responsible for high grade fever, and because of it, it is also associated with the occurrence of febrile seizures. So this child actually had a episode of seizure during the febrile illness, which indicates, yes, febrile seizure has occurred. No wonder in exanthum subitum, febrile seizures are very, very common, right? Okay. Other than that, what happens in this case is that these children, can have kind of what you call it, the ulcers at the uvulopalato-glossal junction. So these kind of ulcers can be there at the uvulopalato-glossal junction, and these are referred to as Nagayama spots. Remember Nagayama spots, if asked in your exam, this is a feature of sixth disease or exanthum subitum or roseola infantum. Another reason why it is known as, sixth disease, we have already discussed because it's caused by HHV 6 or 7. Another way of remembering is it is very much prevalent in the age group of 6 months to 3 years of age. This is the usual age group in which you get to see the sixth disease, and usually you have a very high grade fever, and which can or cannot be accompanied by febrile seizures, and fever usually lasts for 3 to 4 days, and following this there is abrupt cessation of fever and there is onset of rash. What can be accompanied is some kind of conjunctival redness can be there, cervical and occipital lymphadenopathy can be seen. So these are another other cardinal features of sixth disease. Very importantly, the rash is discrete maculopapular rash, which first appears on the trunk and then spreads to other parts of the body, that is namely the face, neck and proximal extremities. Importantly, the rash is non-pruritic and it fades in the coming 3 to 4 days. Very importantly, the infectivity is very, very low and the treatment is only symptomatic treatment. That is what is required in this case and nothing else. That means you just give paracetamol for controlling the fever, and of course if there are other features of running nose or cough, then you can give the medications accordingly, a cough syrup or maybe a decongestant for treating the running nose, right? Okay, then this is your typical, this is known as the slapped cheek appearance, and this is a feature of erythema infectiosum, also known as fifth disease, right? We know this. Then another, here you can see measles. So measles, the rash first appears on the face and neck, you can see, and then goes and involves the rest of the body. So this is very typical of measles, and the rash appears on the day 4 of fever, very importantly, or not after the fever stops. So that is it. So this is it for today. All the best. Keep on MCQing. The more number of MCQs you do, I'm sure you're going to ace it very well, right? And now with the date getting extended, postponed, you have more time to study. So as I always tell my students, study while others are sleeping, work while others are loafing around, goofing around, they are roaming around here and there. At that time, you should work, prepare while others are playing, and dream while others are wishing. So wishing you all the very best. Do well. So signing off, this is Dr. Deepali Gupta, your pediatrics faculty at Allen Next, and now the other faculty would take over with the question discussion. Thank you.
Hello, let us discuss anesthesia question of CBoT 5. So first question was on circuit, and it was asked that a patient was being operated in OT under circle system under controlled ventilation, and there were some issues in the circle system, which would be the Mapleson circuit of choice, which we can take the patient on. So patient is being operated on the circle system and patient is on controlled mode of ventilation. Now we need to change this to Mapleson circuit, which is the Mapleson circuit of choice. So one line, if I change the question, Mapleson circuit of choice for controlled ventilation, the answer has to be Mapleson D. So for controlled ventilation, the best Mapleson circuit is D, then your B equal to C and then A. And if the same question was on spontaneous, the best is A, then D and then B equal to C. So remember, D is best for controlled and the second best for spontaneous. That's why D is what is the commonest circuit which we keep in the OT. And the modified version of D is Bain circuit, which is the commonest kept in OT, right? Okay, next question was on emergency medicine question on patient coming to ER with palpitation and his pulse rate was 180 beats per minute and there was a complaint of palpitation and dizziness and his BP was within normal limit. The patient was hemodynamically stable. ECG, this was the ECG which was recorded. What is the first line of management? So this is supraventricular tachyarrhythmia and that is hemodynamically stable. So stable supraventricular tachyarrhythmia, right? Stable SVT. So if it is stable SVT, what is the first maneuver? We do the vagal maneuver. So 25% of SVT, they would convert into sinus rhythm with vagal maneuver. If it doesn't, then we give adenosine. Now adenosine, we start with 6 milligram. We can increase it to 12 milligram. Okay, we can increase it to 18 milligram. So this is for stable SVT. If it was unstable SVT, then immediately we had to do cardioversion, right? So remember, any tachyarrhythmia, if it is stable, we give drugs to control the rate. As in SVT, supraventricular tachyarrhythmia, we give adenosine after vagal maneuver. If it is AF or atrial fibrillation or atrial flutter, we give calcium channel blocker or beta blocker. If it is VT, that is ventricular tachyarrhythmia, then we give antiarrhythmic agent. If they are stable, if they are unstable, all tachyarrhythmia is managed in the same way, that is by cardioversion. So in this case, the answer has to be vagal maneuver, the first line of management. Next question. The advantage of spinal anesthesia over epidural are all except. So what are the advantages of spinal over epidural? Faster onset. We give the drug in CSF. So drug very fast blocks the number of segments. So yes, it has a faster onset. Less risk of systemic toxicity. Very small amount of drug is given for spinal compared to epidural. Yes. So we have a less risk of systemic toxicity. Dense block. Yes. Since CSF carries the drug, so uniformly most of the segment gets blocked. Hemodynamic stability. Spinal, since the block is fast, so more segment gets blocked faster. So there is more risk of hemodynamic instability. Epidural is more hemodynamic stable. So answer has to be the fourth one. So remember, for spinal anesthesia and epidural anesthesia, both blocks the spinal nerve root. What is the advantage of spinal? Fast, right? Dense, easy, right? And let's say easy block, fast, dense, easy, and less risk of local anesthetic systemic toxicity. Epidural, continuous, the benefits I'm only writing, continuous, more hemodynamic stability in epidural, right? And epidural, continuous, more hemodynamic stability. But major issue with epidural is we need to be very careful while giving it because volume is given more, volume of drug more, so more risk of local anesthetic systemic toxicity. And spinal, the major problem is more hemodynamic instability. Okay, so this is the difference between spinal and epidural anesthesia. Next patient, a patient of RTA with head injury was shifted to ICU. On examination, the patient opened his eye on pinching and could speak a few words but inappropriate. He withdrew his leg on giving painful stimulus. Calculate the GCS. So Glasgow Coma Scale. Now this scoring system is done in the neuro patient to assess the clinical status of the patient, the neurological status, and it is based on three things. It is based on the eye opening, verbal response, and the motor response. The value varies from 3 to 15. So 3 to 15. So let's see for eye opening what are the scoring. So if there is no eye opening on any kind of stimulus, it's 1. If there is an eye opening to pain, it's 2. Eye opening on calling the name of the patient, 3. And spontaneous eye opening, 4. Now best verbal response, right, we have to see if there is no verbal response, 1. Incomprehensible, 2. Inappropriate, 3. Confused, 4. Oriented, 5. And best motor response, no motor response, 1. Extensor response, then 2. Okay. So no motor response, none. Extensor response, 2. Flexor response, 3. Withdrawal, 4. And localizing to pain, 5. And obeying command, 6. So total score is 15. That's the maximum score, and minimum is 3. So in our patient could open the eye on pinching, so was responding to pain. So 2 given. Then could speak few words but were inappropriate. So 3 points given, 3 score given. And he withdraw his leg to the painful stimulus. So withdrawal response was there. So 4. So 4 plus 3, 7 plus 2, 9. So his GCS score is 9. Okay. So we need to remember the GCS scoring. This is very important for exam point of view. Next question. A 35-year-old male with road traffic accident with an estimated blood loss of 3 liters. On arriving at emergency, his blood pressure was 70 by 50 mm of Hg. Heart rate was 135 beats per minute. After attaching oxygen to the nasal cannula, an IV line of orange color was secured. What is the size of the cannula? Simple question. The orange cannula, what is the size? Right. So orange cannula is the thickest one with 14 gauge size. Okay. So 14 gauge is for orange, 16 is grey, 18 gauge is your green, and your 20 gauge is pink. Okay. So we need to remember the color coding of the cannula. Orange cannula, which is most commonly used in road traffic accident because we can give fluid very fast. It is a thick bore 14 gauge cannula. Remember, cannula 14 gauge, 16 gauge, 18 gauge, 20 gauge, 22 gauge, 24 gauge. Now 14 gauge, orange, 16 gauge, grey. Both used in trauma and cardiac surgery, most commonly cardiac surgery. 18 gauge is your green and 20 gauge is your pink. Both used in adult in perioperative management. 22 gauge is blue and 24 gauge is yellow, mostly used in pediatrics. Okay, yellow one is more commonly used in neonates, right? So this is what we need to remember about the cannulas. So these were the 5 questions which were asked in from anesthesia and emergency medicine in CBoT. I hope you have done all the questions correct. Thank you.
Hello students, so let's discuss the radiology questions for today's CBoT. So the first question is, which of the following has a low signal on T1 weighted image? So we are talking about hypo-intensity on T1 weighted image. That means structure appearing black or grey on T1 weighted image. Now at the back of our head, we know that water is black on T1. Okay, remember the mnemonic World War II. So World War II mnemonic was water white on T2. So the opposite of this is water is dark on T1 weighted image. So among the given options, if we just look at it, even if we don't know about the rest of the structure, so A, B and C, subacute hemorrhage, proteinaceous contents, gadolinium, even if we don't know whether they are bright or dark on T1 weighted image, we know that CSF is water and that will appear low on T1 weighted image, that is darker on T1 weighted image. So that becomes the answer right away. So the answer to the first question is CSF, it is low signal on T1 weighted image. Now just remember that the rest of the structures, subacute hemorrhage, proteinaceous contents and gadolinium, they are bright on T1 weighted image. Okay, they are, all these structures are bright on T1 weighted image. Okay, now where do we see these? So post gadolinium, gadolinium is given as a contrast in MRI, right? So remember, post contrast images. Where do we do post contrast images? For example, in infections, if we are suspecting meningitis, if we are suspecting a brain tumor, then we have to give a contrast. Post contrast images will always be T1 weighted. Always remember this. This is a question which has been asked. Post GAD images, post contrast images are T1 weighted image because gadolinium is bright on T1 weighted image. So the tumors, the inflammation, they will enhance on T1 weighted image, not T2 weighted image. Okay. Now proteinaceous content, where do we get proteinaceous content? So remember, craniopharyngioma has machine oil type of fluid within it on histopath. So that is T1 bright. Okay. Now let's come to subacute hemorrhage. Subacute hemorrhage is T1 bright. Okay. So any subacute hematoma, okay, subacute hematoma, be it intracranial hemorrhage, FDH, which is subacute in nature, all those will appear T1 bright. So just let's complete the list. Things that are bright on T1 weighted image will be fat, definitely. In fact, fat is bright on both T1 and T2 weighted images. Now next is hemorrhage. What kind of hemorrhage? It is subacute hemorrhage. Then proteinaceous content we have already done. Cholesterol, yes, and melanin, very important point. So melanoma is bright on T1 weighted image. And finally gadolinium that we have already discussed. Now just brief recapitulation of how different stages of hemorrhages look on MRI. So important for you to remember is things that are bright on both T1 and T2 weighted image. What kind of hemorrhage is bright on both T1 and T2? It is the late subacute hemorrhage. Late subacute hemorrhage is bright on both T1 and T2 weighted image. This thing you remember. Okay. Now let's come to the next question. A 50-year-old male presented to the medicine OPD with complaints of multiple episodes of dysphagia and chest pain. Okay, whenever you see these two words together, dysphagia and chest pain, always think of diffuse esophageal spasm. Okay, other causes of dysphagia like eclasia cardia, like CA esophagus. Okay, like a Zenker's diverticulum, they don't have chest pain per se. Zenker's will have halitosis, regurgitation. Eclasia also will have regurgitation and episodes of aspiration along with dysphagia. So would CA esophagus, it will have episodes of aspiration and weight loss. But whenever dysphagia and chest pain comes into picture together, okay, always think of DES or diffuse esophageal spasm as the first possibility. Now, barium swallow study is given to look for the cause of dysphagia, and which of the following is not true. So, we want to see the false statement. So, again, the barium swallow is given to us, and what do we see? We see corkscrew appearance of esophagus, correct? And we know that corkscrew appearance of esophagus is seen in diffuse esophageal spasm, correct? So let's just see what the options are. The first option is given condition is a diffuse esophageal spasm. Yes, this option is correct. A corkscrew or rosary bead appearance is seen on barium swallow. This statement is also correct. Now, primary peristalsis of esophagus is present in diffuse esophageal spasm. Now, what is primary peristalsis, secondary and tertiary peristalsis? So, whenever the food passes through the esophagus, there is a primary wave of peristalsis which pushes the food, a secondary wave then follows, and finally a tertiary wave of peristalsis follows to propel the food forward. Now, in diffuse esophageal spasm, this primary peristalsis is absent. That is why the food is not getting propelled. That is why there is dysphagia. Okay. Now, to compensate this primary peristalsis which is absent, there is tertiary peristalsis which increases. Okay, the tertiary peristalsis increases. But you know, tertiary peristalsis can never propel the food forward. It is only the primary peristalsis which propels the food forward. So, this tertiary peristalsis is first present and exaggerated. So, imagine this is the food stuck here. The tertiary peristalsis is trying to propel this food forward, but it is not able to. So, the esophagus goes into spasm and that causes the pain. Okay, so the tertiary peristalsis is present and that results in the corkscrew appearance of the esophagus. So, the corkscrew bead appearance occurs secondary to non-peristaltic tertiary contractions. Yes, it occurs due to tertiary contractions, and these tertiary contractions are non-peristaltic because they are not able to propel the food forward. So, this statement is also correct. So, the C option is false. The primary peristalsis is absent in diffuse esophageal spasm. Okay, I hope this concept is clear. Now, let's come to the next question, an easy one. Identify the imaging modality shown below. Now, tell me if this is a MCU, IVP or a plain KUB. Okay, so lupogram study we can rule out. Okay, lupogram study is done for small bowel after you do a resection and anastomosis. Okay, to see the distal continuity of the bowel. Sorry, after you make a loop out stoma out of in perforation, to do a resection and anastomosis to restore the bowel continuity, you do a lupogram study to see the distal bowel. So, mota we know that in lupogram study we want to see the small bowel and there is no small bowel here, so this option is false. Now, RGU, we know that it is used to see the lower or the distal urethra, anterior urethra we also call it. So, this option will also be ruled out. Now, MCU and IVP, what is the difference between the two on the imaging? So, we know that in IVP we give IV contrast that gets excreted through the kidneys or pacify the pelvic ileal system, ureters and the bladder. Now, in IVP you will not see urethra. Urethra is not seen because the patient is not maturating, whereas in MCU the urethra will be seen because the patient is maturating. Now, in this case you do not see any urethra, so the answer here is a simple answer, it is IVP. Now, how do you differentiate between these three important things which appear confusing, sometimes in the exam? So, the third image you are able to see the urethra, but why are you seeing the ureters and the pelvic ileal system? Because this is a MCU with VUR, vesico-ureteric reflux. Vesico-ureteric reflux is happening here. But this third image is MCU because you are able to see a urethra. Now, the second image, you are able to see the bilateral PCS, the bilateral ureters and the bladder. So, this is a IVP. Second image is that of an IVP. And the first image, you are able to see the bilateral renal pelvic ileal system. There is some shadow, okay, but you do not see any ureters, you do not see any bladder, and you do not see the kidney outline. So, there is no contrast which is getting excreted. You are only able to see some white radio opacity in the renal fossa. So, this is nothing but a plain KUB with staghorn calculi. Okay, I hope these three images are clear. Very important question and very confusing also in the exam. Now let's come to the next question. What is the likely diagnosis based on the given image in a 50-year-old male who presented with abdominal pain, distension and constipation for the last 3 days? So we are dealing with intestinal obstruction. Okay, there is pain, distension and constipation. Now, what do we see in the given X-ray? So we know that this is a plain coffee bean sign, and it is pointing to the right shoulder. It is pointing towards the right shoulder. So that means it is our sigmoid volvulus. Okay, tell me quickly, what sign do you see in intussusception on plain X-ray? You see claw sign. It is also seen on barium. In fact, it was mainly described in barium, but sometimes you can also see it in the plain X-ray as well. Cecal volvulus, you see C sign, and sometimes also you can see a coffee bean sign, but it is pointing towards the left shoulder, pointing towards left shoulder. An incarcerated hernia is mainly a clinical diagnosis in which the hernia is not getting reduced, it is getting strangulated, and slowly it will start perforating as well. So it's mainly a clinical diagnosis. The answer here is a sigmoid volvulus. Now let's quickly see how the cecal volvulus looks. So this is the cecal volvulus, and you see that this looks like a C. This looks like a C, or you can also, maybe for some of you it might look like a coffee bean, but it is pointing towards the left shoulder. So this is a cecal volvulus. Now the next image is that again of a plain abdominal X-ray in which you see this claw sign. You see here the claw sign. So this is how an intussusception looks like on plain KUB X-ray. Now let's come to the next question. What is the likely diagnosis based on the given image? So tell me first of all what kind of image this is. This is an MRI, a sagittal image, T1 image because the CSF is dark here, and post contrast. We have given gadolinium contrast because you can see contrast in the sinuses. So this is a post contrast image. I'll say it as post contrast T1 weighted sagittal MRI. This is the complete description of this image. Now what do we see? It's direct spotter. We see that the tonsils are getting herniated through the posterior fossa into the spinal canal. So straightforward, what is this called? This is known as Arnold-Chiari malformation, correct? So answer here is a plain Arnold-Chiari malformation, Arnold-Chiari syndrome. Now in Dandy-Walker syndrome, what do we get? We get this cystic posterior fossa. In Dandy-Walker, the posterior fossa is enlarged, whereas in Arnold-Chiari, the posterior fossa is small. The main difference is there. And there is cystic enlargement of the fourth ventricle. You do not see any cerebellum. In fact, there is cerebellar hypoplasia. This is the Dandy-Walker syndrome. Now, the third option, corpus callosum agenesis. Tell me what sign do we see on corpus callosum agenesis in MRI? We see raised scar ventricles, and we see colpocephaly. Colpocephaly meaning that the occipital horns of the bilateral lateral ventricles are enlarged. So colpocephaly means occipital horns of bilateral lateral ventricles enlarged. And on a coronal T2 weighted MRI, we see Viking helmet sign. This is seen on coronal T2 weighted MRI. These two are axial T2 weighted MRI in which we see raised car ventricles and colpocephaly. I'll write colpocephaly again. Colpocephaly. Now the third image is, this is how a pilocytic astrocytoma looks like. Pilocytic astrocytoma. First important pointer, its location is mainly in the cerebellum and it presents with a cyst plus nodule type of appearance. Cyst plus nodule appearance is that of a pilocytic astrocytoma. So this is the cerebellum, this is the lesion, this is the cystic part, and this is the nodule that we are talking about. This is the nodule and this is the cyst. Okay, so I hope this was clear. The radiology questions were almost straightforward and I hope you did good in your exam. Thank you.
So I hope you enjoyed this CBoT, and let us start with the discussion of surgery. So when we talk about the first question, the most important thing that we need to understand is some key points. 60-year-old female presented with itchiness and increased size of the pre-existing hyperpigmented lesion. What should be the next? So the age is on the higher side, the increase in the diameter. So this is an evolving skin pigmentation. At least you need to do an excision and do the biopsy. Why? Because this is a rule of ABCDE in case of melanoma. I suspect, I don't diagnose this until unless the condition is confirmed on the biopsy. So excisional biopsy is what is the management here. The next is 50-year-old female presents with progressive swelling of the right arm. She had history of breast cancer for which she has undergone mastectomy. The question finishes here. I'll not even read the question. I know that this is a case of Stewart-Reeve syndrome or lymphedema, and this is because of the lymphatic blockage which happens due to lymphatic dissection. So the answer will be D, lymphedema in this case. There is no need. Okay, let us try to understand the next question. A patient with a history of DVT. The patient has pain over the right leg, started with the anticoagulation. Within 1 hour, the patient experiences a significant increase in pain and swelling. Now this is worsening, and if you don't act at this point, the patient will have a risk of embolism. So already you have started with anticoagulation, so thrombolytics also might not be helpful. But anyways, either you can go for catheter directed thrombectomy in this case, you can start with the streptokinase, urokinase, or you can go for open thrombectomy with Fogarty's catheter. This is what is very important. So catheter directed thrombolytics is not given in this. So I would go for venous thrombectomy. This is what is the answer. Next is 45-year-old male with diabetes with a non-healing wound. You know that diabetes prolongs the phase of wound healing. And why? Because it dysfuncts, or there is a dysfunction of the neutrophil. And until and unless the neutrophils don't aggregate, the initial plaque or the callus will not form. And remember, that is why the wound healing is delayed. So why it is delayed? Decreased level of growth factors, secondary factor. Enhanced collagen, had it been, so the healing would have been more rapid. The third is impaired neutrophil function. Students, dear students, my lovely students, answer is option C. Let us understand the next question. And then increased level of pro-inflammatory cytokines, no, they decrease. Next is 20-year-old female with painless fluctuating mass in the lateral aspect of the neck. So this is the neck, lateral aspect of the neck, but located along the anterior border of the sternocleidomastoid. So painless fluctuating mass, so that is maybe a cyst. Now it moves with swallowing and trunk protrusion. Since it is enclosed within the pretracheal fascia, it must be. So what are the structures? In the midline, it could have been the thyroid, but thyroid doesn't protrude with the, you can say, with the protrusion of the tongue. Then ranula will not, dermoid cyst will not. Now what is the option? It moves with swallowing and tongue protrusion. There is no sign of inflammation and the patient reports no difficulty in breathing and swallowing. So it is not in the midline, it is in the lateral line. So thyroglossal duct cyst is also not there. However, if you would have not gone for the option segregation, you could have easily said that along the sternocleidomastoid, due to non-closure of the branchial clefts, you will have a branchial cleft cyst here, and this is what is the answer. So either you know the answer, you can solve it, or you know the other options, you can solve the answer. So these are the tricks that you need to understand. Next is, what is the best mechanism of injury in diffuse axonal injury? So DAI, it is due to sudden rotational acceleration and deceleration which causes super strain over the axons. So what is that? It is caused by the rotational stress, and this is going to cause coiling of neurons and they avulse off. Next is, which of the following statement is true regarding testicular torsion? Torsion is quite common in young individuals and it is generally the age of 13 to 18 years. So prepubertal males or the young males are associated. In testicular torsion, the cremastic reflex is lost. So it is written, it is present. It is characterized by rapid plus sudden onset pain. So we have excluded 3. It has to be C. Anyways, let us read. To save the damaged testicle, immediate surgery is required. This is what is very important. And in case when you do surgery and you do orchidopexy, derotation and orchidopexy, or in case the testicular, you can say, viability has been lost, still you have to do surgery. Why? Because there is a phenomenon which is known as sympathetic orchidopathy. Same way, you have an ocular trauma and we have a phenomenon known as sympathetic ophthalmopathy, that the contralateral eye and testicle will be destroyed. So surgery has to be done here. The next is, 63-year-old male comes to urology OPD complaining of LUTS. Now this is a very good question. With hesitancy, weak stream and nocturia. A distal rectal examination reveals an enlarged prostate. PSA was done, the PSA is 3.8. However, IPSS score is 20. Now what is IPSS, International Prostate Severity Score? There are 7 questions in which we give scoring from 0 to, you can say, 5 each question. So maximum is 35, minimum is 0. So 0 to 7 is mild symptoms, 8 to 19 is moderate symptoms, and 20 to 35, this is considered as bothersome. Now this is a very tricky question. What should be the initial line of management? Had it been what should be the best management here, since it is a bothersome, I would have marked the option as B, that is TURP or intervention. But what should be the initial? At least elfusocin, sildosin, tamsulosin you should start. So option A is far better than option B. If I change the question and say what is the best management right now, this patient is having bothersome LUTS, and that is why I would have marked for B, best answer. But still initial, I will start with tamsulosin. This is what is very, very, very important. Next is, a patient presents to gastroenterology with pain, steatorrhea, weight loss over the 6 months. Epigastric pain, amylase, lipase normal, CT confirms pancreatic calcification, atrophy and dilatation. This is a case of chronic calcific pancreatitis. And for chronic calcific pancreatitis, let us see what has been asked. What is the most appropriate initial? Conservative. Low fat diet, because the carbohydrates will not be able to be assimilated. So low fat diet and exogenous lipase. So we have Creon 15,000 to 25,000, or we have Enzar. It's a lot of brands are giving exogenous commercially available with PPIs. This is what is very, 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 very important. The next is 35-year-old male with history of splenectomy several years back, presents with fever, malaise. So what is this? This is OPSI, overwhelming or opportunistic post-splenectomy infections. I will not even read the question. Forget it. Now, what is it? Severe sepsis caused by gram-negative, viral infection that spreads after splenectomy, fungal overgrowth, no, infection by encapsulated bacteria is the right answer. This is what is very, 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 very simple. The next is 55-year-old female presents to ER with right upper quadrant pain, jaundice and dark urine. So this is a case of obstructive jaundice. Along with that, on palpation of the right upper quadrant, there is increased discomfort during inspiration. What is this? This is a Murphy's sign. So this is a suspected case of acute cholecystitis. Ultrasound shows A CBD dilatation. Students, ultrasound is not the investigation. MRCP is the investigation that should have been done here. Anyways, USG shows dilated CBD with clinical suggestive of acute cholecystitis. However, they have missed one thing in the question, that they have not given any ultrasonic feature of the gallbladder. So USG showing the classical dilated CBD with a profile of obstructive jaundice. What is the next thing? The diagnosis is choledocholithiasis with acute cholecystitis. This is what is very, 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 very important. The next is a 42-year-old female presents with incidentally discovered liver lesion which appears well circumscribed with a central scar. Liver lesion with a central scar, what is this? This is FNH and focal nodular hyperplasia. What is the next thing? Conservative. So conservative management with repeated periodic 6-monthly screening. This is what is important. The next is, what is the first line non-surgical management? Students, every medical student has this constipation because of stress. What is the next? Stool softeners and a high fiber diet. If that fails, then we have to use calcium channel blockers, topical calcium channel blockers, and this is known as chemical sphincterotomy. And if this fails, then we will go for the lateral internal sphincterotomy, that is LIS. This is how we go for. This is what is very important. Next question is BMI of 38. Patient had severe opacity, was suggested a bariatric procedure, and which is characterized by creation of a small gastric pouch. There are two surgeries where we create a small gastric pouch. One is the Roux-en-Y gastric bypass and another one is MGB, mini gastric bypass. MGB is not even an option. The answer is already done. And along with that bypass, so what is this? This is the Roux-en-Y gastric bypass. This is what is very, very, very important. The next is, what surgical is preferred for a patient of head neck surgery? Students, this is a classical Fowler's procedure. Fowler's, students, lithotomy is for the perineal procedures. Trendelenburg, what is Trendelenburg? Legs up, head down. This is Strep Trendelenburg, again for laparoscopic procedures towards the pelvis. Like if I'm doing hysterectomy, I will do a Trendelenburg. If I'm doing myomectomy, I'll do this. Prone position, of course, we do it for APRs and the back surgeries. So we are left with only Fowler's. If you knew the answer, you can solve it. If you don't know, you should know the other options. This is what is very, very, very important. Next is RTS. Which parameter amongst them? So RTS, remember RTS, R for respiratory rate, S for systolic BP, and T for trauma. So the best score for trauma is GCS. Now you will not need any other thing. So only GCS is given in the option. That is why this is. So I hope you like this exam. I hope you are enjoying CBoTs. So keep on learning and enjoying with Alan next.
Hello, dear students. I am Dr. Anupama Chaudhary Devgan. I'm the Physiology faculty at Allen Next, and I will be discussing the physiology questions in CBoT 5. So let's have a look at the first question. Consider the membrane action potential of a nerve as shown below. Which of the following is responsible for the part of the curve which is marked as B, right? Which is marked as B. Now, so A is the depolarization and B is what is known as the repolarization. Depolarization is because of the movement of sodium from outside to inside, which is known as sodium influx. It is through voltage-gated sodium channels. Repolarization, on the other hand, is due to closure of sodium channels and opening of potassium channels, which causes what is known as a potassium efflux. So what is going to be responsible for the repolarization phase? This is potassium efflux or movement of potassium out of the cell.
In depolarization, there is opening of fast voltage-gated sodium channels. For repolarization, there is closure of sodium and opening of slow voltage-gated potassium channels. And if the potassium channels open up, potassium will move from inside to outside. Potassium is in a higher concentration inside the cell, lower concentration outside the cell. So movement of potassium through a potassium channel will be from inside to out, or in other words, movement of potassium out of the cell. Movement of sodium into the cell is responsible for depolarization. Let's see the next question. A 45-year-old diabetic is brought to the emergency room in a comatose condition. So diabetic ketoacidosis. This is the reason for the coma. Blood sugar levels are 600 milligrams per deciliter. Which of the following types of breathing will be seen? In diabetic ketoacidosis, which is a metabolic acidosis, a metabolic acidosis causes a typical pattern of breathing which is known as Kussmaul's breathing. And what happens in the Kussmaul's respiration or the Kussmaul's breathing? There is an increase in the rate and there is increase in the depth of ventilation, which is also known as hyperventilation. So what happens? What is the reason for this kind of pattern of breathing? The reason is in metabolic acidosis, the increase in H+ will stimulate the peripheral chemoreceptors. And when the peripheral chemoreceptors, which are the peripheral chemoreceptors? The carotid and the aortic bodies. When these are excited, they cause an increase in the rate and depth of ventilation. So the pattern of breathing that you see where there is an increase in the rate and depth is known as Kussmaul. So your answer is option B. Let's see what can be the other reasons for or other causes of Kussmaul's breathing. So ketoacidosis, diabetic ketoacidosis, uremia, S. sepsis, S. salicylate poisoning. Basically anything which causes a metabolic acidosis. M. methanol poisoning. A. aldehyde poisoning. Nothing with U. L is lactic acidosis. So all these are causes of Kussmaul's ventilation. And what happens in Kussmaul's? Increase in rate and depth. Let's also have a look at the other patterns of breathing here. The first one where you have periods of hyperventilation, then apnea, hyperventilation, apnea. This is Biot's breathing. Biot's breathing is seen in cases of neuronal damage. So Biot's breathing has a very poor prognosis. So head injuries or conditions causing neuronal damage. This sort of option C, where there is a waxing and waning type of respiration, this is known as the Cheyne-Stokes respiration or the Kind-Stokes respiration. These are typically seen in head injuries and in cardiac failure, sometimes also in deep sleep. Option D appears to be a normal pattern of breathing. Right? So the answer to this question is option B, which is Kussmaul's ventilation. The mitral valve opens at the onset of which of the following phases of the cardiac cycle? Now, opening of mitral valve means that blood will go from the atria into the ventricles. In other words, opening of the mitral valve will happen at the beginning of diastole. So when you look at the ventricular systole and the ventricular diastole, the phases of ventricular systole are isovolumetric contraction, there is a rapid ejection phase. And number 3 is a slow ejection phase. Ventricular diastole, on the other hand, has got 4 phases. Isovolumetric relaxation, first rapid filling phase, diastasis, and the second rapid filling phase. And the second rapid filling phase is due to what is known as atrial systole. So isovolumetric contraction, rapid ejection phase, these are phases of ventricular systole. Now, mitral valve opens at the onset of which of the following phases? Mitral valve will open at the onset of the first rapid filling phase. First rapid filling phase and isovolumetric ventricular relaxation are phases of ventricular diastole. In isovolumetric relaxation phase, the ventricles are a closed chamber. So both the mitral valve as well as the aortic valve will be closed. Both the atrioventricular as well as the semilunar valves will be closed, and the ventricles function as closed chambers. So when does the mitral valve open? Mitral valve will open at the beginning of the first rapid filling phase. Which of the following helps in bridging the fibrin in a clot and stabilizes the clot? In other words, which of the following is known as the fibrin stabilizing factor? Now, the fibrin stabilizing factor is factor 13. And you can also have a look at which are the different factors which are involved in blood coagulation. And a little mnemonic for that: foolish people try climbing long slopes after Christmas. Some people have fallen. Right? So this is a mnemonic which can help you to remember which are these different factors. Factor 1 is fibrinogen, factor 2 is prothrombin, factor 3 tissue thromboplastin or the tissue factor, factor 4 is calcium, factor 5 is labile factor or the proaccelerin. Factor 6 is no longer included. So there are actually 12 factors, but they go up to factor 13. Factor 7 is the stable factor, factor 8 antihemophilic factor, factor 9 Christmas factor, factor 10 is Stewart-Prover factor, factor 11 plasma thromboplastin, antecedent, factor 12 is the Hageman factor, and factor 13 is the fibrin stabilizing factor. The role of fibrin stabilizing factor is to cause polymerization of the fibrin monomers, which form fibrin polymers, and then these are now stabilized to form a clot. Next, all of the following are examples of positive feedback except LH search is positive feedback. Depolarization phase of action potential is also an example of positive feedback. Uncompensated shock is due to positive feedback. But BP regulation by baroreceptors is an example of negative feedback. See, the most important feature of negative feedback is there is a reversal of the initiating stimulus. And negative feedback mechanisms are stabilizing. They help to maintain homeostasis. So that means if the blood pressure increases due to any cause, the baroreceptor mechanism will tend to lower the blood pressure, will tend to bring the blood pressure back to normal. And similarly, if the blood pressure falls due to any cause, the baroreceptors to bring up the blood pressure to the normal level. So that is what is known as a reversal of the initiating stimulus. If the blood pressure increases, baroreceptors will bring it back to normal by lowering the blood pressure. If the blood pressure falls, the baroreceptors will try to bring the blood pressure back to normal by increasing the blood pressure. So reversal of the initiating stimulus. But this does not happen in the positive feedback mechanism. Firstly, what are examples of positive feedback? To remember them, remember claps. C. Clotting. Calcium release from the sarcoplasmic reticulum during muscle contraction. L. LH surge and milk let down reflex. A. Depolarization phase of action potential and activation of inactive pancreatic enzymes to the active form. P. Parturition. S. Uncompensated or decompensated shock. See, how is LH surge an example of positive feedback? Normally, LH levels are very low throughout the menstrual cycle, and this is because of a negative feedback effect of estrogen on LH. But just before ovulation, this negative feedback of estrogen switches to become positive feedback. That means estrogen increases LH, which increases estrogen, which increases LH, so that I get a sharp increase in LH secretion, which is known as the LH surge. What causes this switch of the effect of estrogen on LH from negative feedback to positive feedback, we do not know. But we have to remember that it is the positive feedback of estrogen on LH which is responsible for LH surge, and without the LH surge, ovulation cannot take place. Again, the LH levels will come back to normal because of negative feedback of estrogen on LH. So LH surge is due to a positive feedback effect of estrogen on LH. The second option was the depolarization phase of the action potential. Now, in neurons, the resting membrane potential is minus 70 millivolts. When I give a stimulus, opening of voltage-gated sodium channels, influx of sodium causes the potential of the cell to change from minus 70 and to less negative values, and the moment it reaches minus 55 millivolts. Now, what is minus 55 here? Minus 55 is the threshold potential or the firing level. When the potential reaches minus 55, now the opening of sodium channels is by a positive feedback mechanism. That means influx of sodium causes opening of more sodium channels, more influx of sodium, and a sharp change in potential, which is known as depolarization, and this is due to positive feedback. Then the closure of sodium channels, opening of potassium causes the repolarization phase, and this is your action potential. The depolarization phase of the action potential is due to positive feedback of sodium on sodium channels. Influx of sodium causes opening of more sodium channels, so there is a very sharp change in potential from threshold potential to right up to plus 30 millivolts. Uncompensated shock is another example of positive feedback. So let's take an example of hemorrhagic shock. There has been blood loss. Hemorrhage will cause a decrease in cardiac output. Decrease in cardiac output will decrease the coronary flow. Decreased coronary flow means decreased supply of oxygen to the cardiac muscle cells, decreased supply of oxygen, nutrients to the cardiac muscle cells. There is also accumulation of metabolic waste. This now causes a decrease in cardiac function. Contractility of the heart will suffer. So what happens to cardiac output? There is a further decrease in cardiac output, which in turn will decrease the coronary flow, which decreases supply of oxygen and nutrients to the cells of the heart, which decreases cardiac function, reducing cardiac output even further. This is what is known as a vicious cycle. And where is this going to terminate? This is going to end in death. So this is what is known as an uncompensated shock. This is an example of positive feedback. Here, the decrease in cardiac output is worsening even further. It is not being corrected. There is no reversal. It has become even worse. So this is known as a positive feedback mechanism. If there is an increase in extracellular sodium, what will be the RMP? Sodium has nothing to do with RMP. It is not responsible for the resting membrane potential. So whether we increase the extracellular sodium or decrease it, there will be no change in the resting membrane potential. What is resting membrane potential due to? It is due to the movement of potassium from inside to outside the cell. Why does potassium move from inside to outside at rest? This is because the cell membrane at rest is most permeable to potassium. On increasing the dietary potassium intake, which part of the nephron helps in maintaining potassium balance by excretion of the iron? So the moment you increase the dietary intake of potassium, this causes an increase in the plasma potassium levels. And if there is an increase in the plasma potassium levels, it directly increases the secretion of aldosterone. And what is the role of aldosterone? Aldosterone increases sodium reabsorption in the collecting duct, late DCT and the collecting duct, and it also increases the potassium secretion in the same areas. So remember, plasma potassium levels have a very narrow range of normality. The normal plasma potassium level is between 3.5 to 5 millimoles per liter. Very, very narrow range. So anything which increases the plasma potassium levels, like for instance, in this case, by increasing the dietary intake of potassium, increase in plasma potassium will directly increase the secretion of aldosterone from the adrenals, and which in turn will increase the potassium loss in urine. And which part of the nephrons does aldosterone act on? It acts on the P cells in the late DCT and the collecting duct. It causes increased potassium secretion by the P cells. A 43-year-old woman with a BMI of 30 presents with a history of gallstones, presents with excruciating pain in the right upper quadrant. The woman has also got jaundice. Ultrasound suggests obstruction of the common bile duct. Which of the following is responsible for the patient's complaints? So this is obviously a patient of gallstones or cholelithiasis. The clinical scenario suggests the patient has got gallstones. And what is causing the pain here is a hormone which causes gallbladder contraction, and that is cholecystokinin. If I look at the other options, what is the role of gastrin? Gastrin will increase the HCl secretion in the stomach. It has nothing to do with gallbladder contraction. Pepsin is an enzyme which will act on proteins. Somatostatin decreases the HCl secretion. So options B, C, D have nothing to do with the gallbladder. It is cholecystokinin which causes contraction of the gallbladder and is responsible for the pain in this patient's condition. Next, left ventricular wall tension can be decreased by an increase in which of the following? Now, here we will use what is known as the Laplace's law. Laplace's law for a sphere says that T is equal to PR by 2W. What is T? T is the wall tension. What is P? P is the distending pressure. What is R? R is the radius and W is this wall thickness. So the tension is equal to distending pressure into radius divided by 2 into the wall thickness. So let's look at the options. If I increase the distending pressure, what will happen to the wall tension? It will increase. So this is definitely not the answer. If I increase the radius, what will happen to the wall tension? Again, it will increase. If I increase the afterload, what is afterload? Afterload is the total peripheral resistance. This is the resistance against which the left ventricle has to pump blood. This is the load which is acting on the heart after it begins to contract. So more the afterload, more will be the wall tension. But if I increase the wall thickness, what will happen to wall tension? Wall tension will tend to decrease. And we can actually apply this to a clinical situation. For example, a patient of uncontrolled hypertension. In a patient of uncontrolled hypertension, there is an increase in the total peripheral resistance, which in turn increases the left ventricular wall tension. There is an increase in the afterload. There is an increase in the left ventricular wall tension. To reduce this left ventricular wall tension, the body compensates by increasing the wall thickness. LV wall thickness increases. So if there's an increase in the LV wall thickness or a left ventricular hypertrophy, this will help to reduce the left ventricular wall tension. So left ventricular hypertrophy is very commonly seen in patients with uncontrolled hypertension. And we can explain this on the basis of physics, Laplace's law. T is equal to P into R divided by 2W. Next, which of the following best describes the reflex and muscle response on the stimulation of the Golgi tendon organ? The Golgi tendon organ reflex is a bisynaptic reflex and it will result in the relaxation of the muscle. It is also known as the inverse stretch reflex. So let's see the Golgi tendon organ response or the Golgi tendon organ reflex, which is also known as the inverse stretch reflex, or also known as autogenic inhibition. Here, what is the stimulus for the Golgi tendon organ response? This is going to be an increase in muscle tension. The receptor here is the Golgi tendon organ. The afferent or sensory fibers are 1B, center, spinal cord. The efferent fibers are A alpha. The response is muscle relaxation. And the number of synapses that you see in this reflex are 2. This is a bisynaptic reflex. Let's try and understand this reflex response in a diagrammatic fashion. Whenever there is an increase in muscle tension, and what can cause an increase in muscle tension is, for example, when you're trying to lift a very heavy load. This will stimulate the Golgi tendon organ. The sensory fiber from the Golgi tendon organ is 1B. It enters into the spinal cord. It now synapses with an inhibitory interneuron, which now inhibits the A alpha motor neuron to that same muscle. So the response is a muscle relaxation. This is a bisynaptic reflex. So let's have a look at the next question. It says a 30-year-old man presented to the emergency after a bike crash. His medical history is significant for the intake of anticoagulants for a heart condition. On arrival at the emergency room, he complained of severe headache and ipsilateral hemiparesis. On examination, right eye ptosis, dilated right pupil with down and out gaze was seen. He developed the following posture. Now, when you look at this posture, the lower limbs are extended. The upper limbs are also extended, and in fact, they are pronated. And if you can see this, the neck is also extended. So this is a severe extensor rigidity. And this is typically seen in decerebration. And what is the cause of the decerebration in this case? The decerebration is probably due to an uncal herniation which has happened here. Here is a patient with head injury, and probably the uncal herniation has resulted in a decerebration where there is a severe extensor rigidity. So let's see the options. The first is damage is at the mid-collicular level. This is a true statement. Now, when I look at the colliculi, you have these two superior colliculi and the two inferior colliculi. So if it is a mid-collicular damage or a mid-collicular section, this results in a decerebration. And what happens in a decerebration? There is loss of cortical control as well as a loss of midbrain control over the lower areas. But if the damage is above the superior colliculus, rostral to the superior colliculus, then this results in a decortication. That means there is loss of the cerebral cortical control over the lower areas, but midbrain control is still intact. Decortication results in a moderate extensor rigidity. And what happens in decortication is upper limb is flexed, lower limb is extended. So in decerebration, severe extensor rigidity; in decortication, moderate extensor rigidity. In decerebration, neck is extended, upper limb is extended, lower limb is extended. Whereas in decortication, upper limb is flexed and lower limb is extended. In decerebration, there is loss of cortical as well as midbrain control, whereas in decortication, only the cortical control is lost. So A is true. Lesion interrupts corticospinal tract, but rubrospinal tract remains intact. Rubrospinal means it arises from the red nucleus, and red nucleus lies in the midbrain. In decerebration, both the cortical as well as the midbrain control is lost. So both corticospinal and rubrospinal tracts will be interrupted. So this is false. In this, alpha motor neuron of the extensor muscle gets directly activated without involvement of gamma motor neurons. This is also a false statement because gamma motor neurons are definitely going to be involved in a decerebration. There is in fact overactivity of gamma motor neurons. Gamma motor neurons are responsible for muscle tone, right? The A gamma motor neurons are responsible for muscle tone and especially which muscles? Flexors or extensors. This is responsible for mainly the extensor muscle tone, but especially in the lower limbs, because remember, the lower limb extensors are involved in erect posture. So A gamma is responsible for extensor muscle tone. Now, which are the tracts which control the A gamma motor neurons? A gamma motor neurons are under the control of tracts arising from the reticular formation. And reticular formation is divided into a pontine reticular formation and a medullary reticular formation. So the tract which arises from the pons will be called the pontine reticulospinal tract, and from the medulla will be called the medullary reticulospinal tract. The pontine reticulospinal tract is an excitatory tract. The medullary reticulospinal tract is an inhibitory tract. The pontine tract will increase the A gamma activity and the medullary tract will decrease the A gamma activity. The cerebral cortex sends excitatory impulses to both the pontine and the medullary areas, and the fibers are known as cortico-reticular fibers. The pontine area receives collaterals from all the ascending tracts. Ascending tracts are the sensory tracts. They give collaterals to the pontine area and they excite the pontine area. So when there is a decerebration, there is loss of cortical control as well as the midbrain control. So excitatory fibers from the cortex to the reticular formation, these are damaged. So no excitation of either the pontine or the medullary area from the cortex. But the pontine area continues to receive excitatory impulses from collaterals arising from the ascending tracts. So what happens is the medullary reticular formation is no longer active. There is loss of inhibitory control over the A-gamma motor neurons. So there is a relative overactivity of the pontine area. A-gamma activity relatively increases. So there is an increase in muscle tone. Which muscle tone? The extensor, and especially the lower limb extensors. So what you see in decerebration is a severe extensor rigidity with the neck extended, upper limb extended and pronated, and lower limb is also extended. And definitely the gamma motor neurons are involved. Let's have a look at the next question. Which two dyes together provide the best measurement of the interstitial fluid volume? Now, interstitial fluid volume measurement is an indirect measurement. Interstitial fluid volume is ECF volume minus the plasma volume. And for measurement of ECF volume, we use substances such as inulin, mannitol, sucrose, or radioactive sodium. And for measurement of plasma volume, we use Evans blue or radioactive iodine labeled albumin. So my best answer here is going to be inulin and Evans blue. Inulin for the measurement of ECF and Evans blue for the measurement of plasma volume. D2O or deuterium oxide or heavy water is used for the measurement of total body water. Evans blue, of course, for measurement of plasma. Tritium oxide, again for total body water. Inulin for ECF. D2O for total body water and mannitol for ECF. But I want ECF and plasma volumes, so inulin and Evans blue. This is because the interstitial fluid is ECF minus the plasma volume. Let's look at the next question. What is the second messenger used by TSH for its action on the thyroid gland? TSH is secreted by the anterior pituitary. This uses the cyclic AMP pathway. Now, please remember the anterior pituitary hormones are growth hormone, prolactin, ACTH, FSH, LH, and TSH. So ACTH, FSH, LH, and TSH, they use cyclic AMP as the second messenger. But growth hormone and prolactin do not use a second messenger because they act via the JAK-STAT pathway. And another way to remember this is growth hormone and prolactin secreting cells, these are acidophilic cells. They are secreted by cells known as acidophils. Whereas the ACTH secreting cells or corticotropes, FSH, LH secreting cells or gonadotropes, and TSH secreting cells or thyrotropes, these are basophilic cells. So remember, growth hormone and prolactin, they act via the JAK-STAT pathway, but ACTH, FSH, LH, and TSH use cyclic AMP as a second messenger. Growth hormone and prolactin do not need a second messenger. Other hormones which do not need a second messenger are insulin, IGF-1. They do not need second messengers. So these were the questions of your CBoT 5. If you have any queries regarding these questions, please feel free to send me a mail at dranupamadevgan@gmail.com and I will be more than happy to answer your questions. Thank you very much and all the best.
Hello students, welcome to CBoT 5 for NEET PG exam 2024. I am Dr. Harmeet Goyal, your Obs and Gynae faculty. Today I am discussing the Obs and Gynae questions. Hope you have done the questions well. Now, first question is a 30-year-old woman, Gravida 5, Para 4, L4, A1 comes to you at 38 weeks of gestation. So, it should be Gravida 6 because if these are 4 and abortion is 1. So, 5 pregnancies have already been there and this is the 6th time she is pregnant. Okay. So, she comes to you at 38 weeks of gestation with complaints of bleeding per vaginum, decreased fetal movement for 1 hour prior to presentation. She has history of rupture of amniotic membranes 1 hour ago, after which bleeding started. Bleeding is painless in nature. On the fetal Doppler, there is no heartbeat. Patient has an old ultrasound report showing low-lying placenta and aberrant vessels overlying the internal os of the cervix visualized on Doppler ultrasound. Which of the following is not a risk factor for this condition that the patient had caused bleeding and intrauterine fetal demise? So, first of all, it is a case of APH, antepartum hemorrhage, because there is, like painless bleeding and which is occurring, and on doing the fetal Doppler, there is no fetal heart rate and there are aberrant vessels overlying the internal os. So, that means it is a condition where there is, like vasa previa. Vasa previa, that is also a type of APH. So, in this question, which of the following condition is not responsible for this case? The options given to me are filamentous cord insertion or filamentous insertion of placenta, bilobed placenta, battledore placenta or succinturita placenta. So, first of all, this is a condition of antepartum hemorrhage where fetal demise has taken place because there was a bleeding and ultrasound Doppler showed that there is no fetal heart rate. Filamentous insertion of placenta is the most important cause for vasa previa. Vasa previa, the blood is fetal in origin because it is a cord blood which the patient has been losing. Bilobed placenta is also responsible for this kind of presentation, and succinturita lobe can also be responsible for this kind of presentation. So, battledore placenta, where umbilical cord is attached to the margin of placenta, is the answer to this question, since this condition of is not being caused or a risk factor of battledore placenta. So, battledore placenta is umbilical cord is attached to the umbilical cord is attached to the margin of placenta. So, this is found in 7 to 9% of the single term pregnancies and 24 to 33% of the twin pregnancies, and this can be a risk for fetal distress, preterm labor and IUGR. Whereas filamentous insertion of placenta, where umbilical cord is attached to the fetal membranes, and as you can see in this image, the umbilical cord is getting attached to the fetal membranes. So, whenever during pregnancy, like the presenting part goes down, there is laceration of these vessels or the fetal membranes take place. So, that presents as bleeding, which is a cause of antepartum hemorrhage. So, the risk factors include nulliparity, assisted reproductive techniques, obesity, single umbilical artery, smoking, hypertension, etc. So, this condition mostly presents with vasa previa, but it can also lead to placental abruption or postpartum hemorrhage. So, this condition of vasa previa can be predicted, and we can do the ultrasound Doppler to predict this condition, and an elective cesarean section can be done in time. Now, succenturiata lobe means there is accessory lobe of placenta, and usually it is a cause of secondary PPH, but it can also cause a condition like vasa previa. Bilobe placenta can also be a cause of antepartum hemorrhage. So, among the four options, I will select battledore placenta, which is not usually associated with a type of vasa previa, a type of antepartum hemorrhage. Next question. A 23-year-old primigravida woman at 34 weeks of gestation comes with the complaints of labor pains for 4 hours. On Doppler, there is fetal bradycardia associated with contractions. On performing the per vaginum examination, the cervix is fully dilated, soft and irregular parts are felt. Irregular parts may be a breech presentation. It can be a breech presentation, because if it is written as hard globular part, I would have thought of a cephalic or a vertex presentation. So, this is irregular soft fetal parts which is felt through the fully dilated cervix, and patient gives you a history of oligohydramnios from the previous ultrasound scans. What is the preferred mode of management of labor in this case? Patient is on per vaginum examination, full dilatation of cervix, and there is irregular soft fetal parts felt. Irregular soft fetal parts felt, and on per abdomen examination there is fetal heart rate bradycardia, and the ultrasound shows there was a oligohydramnios in the previous ultrasound report. Now, the options given to me are administer 2 doses of steroids followed by an emergency cesarean section, perform external cephalic version followed by normal vaginal delivery, administer 2 doses of steroids followed by external cephalic version and then normal vaginal delivery, allow spontaneous breech vaginal delivery with provision of emergency cesarean section. First of all, whenever we give any steroids, that is to be given in the antenatal period, not during the advanced labor. Moreover, for the steroids to act, it requires almost 24 to 48 hours to cause lung maturity. So, in this case, this will not be applicable, okay, because the reason is patient is almost in the second stage of labor, that is cervix has been dilated fully, that is 10 centimeters of the dilatation. Next option is external cephalic version followed by normal vaginal delivery. External cephalic version is never done in second stage of labor. It is done around 36 weeks during the antenatal period. Okay, so this option is also ruled out. Number 3, administer 2 doses of steroids followed by external cephalic version. Again, this is not applicable. So, the most appropriate answer is allow a spontaneous breech vaginal delivery with the provision of emergency cesarean section. If anyways the fetus is not able to deliver, we can perform an emergency cesarean section. But most of the time, the obstetrician, if the obstetrician is very experienced, then he can conduct the assisted breech vaginal delivery. Next, a 28-year-old G3P2 woman is in active labor at 39 weeks. Okay, the cervix is dilated by 10 centimeters and a male newborn is delivered without any prenatal problems and with appropriate Apgar scores. Tapping the umbilical cord during the placental delivery encounters significant resistance. So, it means the placenta is attached. Okay, placenta is attached. Baby has already been delivered and there is severe bleeding following the manual placental separation. That means manual removal of placenta might have been tried, but the patient has missed multiple antenatal visits for the current pregnancy. Which of the following is a false correlation with this case? Let us see the options given to me. Maternal alpha fetoproteins will be raised during the second trimester. This is a true statement. Rh positive mothers will have to receive anti-D immunoglobulin if the fathers are Rh negative or unknown in case of vaginal bleeding. This is a false statement. The patient will require a cesarean hysterectomy, true, because it may be if manual removal of placenta has been tried and if you are not able to find a plane of cleavage, that means it is a condition called as placenta accreta or adherent placenta, which requires hysterectomy, because usually the deciduum basalis, okay, is been formed, but in cases of the placenta accreta or adherent placenta, there is a deficiency of the deciduum basalis and there is absent Nietterbuck's membrane. So we will not be able to find a plane of cleavage during the manual separation of placenta, as this has caused the bleeding that is called as third stage PPH. Third stage PPH, the manage is manual removal of placenta, but manual removal of placenta is failed. So a possibility of placenta accreta should be kept in mind. And in this case, the previous scenario was that we have to take out as much placenta as we can, and if the small part is left, we can left it behind, and then during the shedding of the decidua, this will be shed off. But nowadays, since this is a multigravida patient, placenta accreta or adherent placenta in the multiparous lady is an indication for hysterectomy. So this statement is also true. Now next statement, placenta will show multiple irregular lacunae as moth-eaten appearance of placenta. This is also true statement. Now I would like to elaborate upon this present finding. We have never heard that if Rh positive mother is there and the husband is Rh negative, then there is any role of anti-D injection. Anti-D injection, which is anti-D immunoglobulin injection, is usually given to Rh negative mother who has delivered an Rh positive baby, and she should be ICT negative. ICT negative means indirect home test negative. That means there are no antibodies being produced. So Rh positive baby means the red cells have got D antigen on its membrane. So this D antigen can enter this RBC, fetal RBC, during the process of delivery, can enter into maternal circulation and cause antigenic stimulus. Before it can cause antigenic stimulus, you give immunoglobulin which blocks these antigenic sites. This is to protect the next future pregnancies, okay, so that no production of antibodies can take place, and if the antibodies are formed, then they can cross the placenta and cause hemolysis in the next pregnancy. So this is very, very wrong statement. Anti-D immunoglobulin should be given to Rh negative mother, not to Rh positive mother. Next question. So placenta accreta I have already explained. Placenta accreta is when the chorionic villi invade the superficial layers of myometrium. Placenta increta is when it invade the full thickness of myometrium, and placenta percreta is it invade till the serosal layer. Now risk factors for placenta accreta is if there is a scarred uterus and in the present pregnancy there is placenta previa, then there is a very much possibility of placenta accreta. Next question, which of the following condition does not cause acquired coagulopathy in pregnancy? That means they are asking about DIC, disseminated intravascular coagulation. Let us see what are the options: abruptio placentae, amniotic fluid embolism, gestational diabetes mellitus, and retained dead fetus. So we have always heard that DIC occurs in two ways, that there is consumptive coagulopathy, and there is fibrinolytic coagulopathy. So most common cause for coagulopathy in obstetrics is abruptio placentae. Then there is the severe preeclampsia or eclampsia, then amniotic fluid embolism, dead fetus, and septic abortion. But we have never heard that diabetes can cause the DIC. So why DIC occurs in abruptio placentae, amniotic fluid embolism, dead fetus, or in PIH, severe PIH eclampsia, or in septic abortion? Now what happens that there is in abruptio placentae, there is retroplacental clot. So this clot formation is consuming the platelets and clotting factors. So there is a platelets and clotting factor deficiency that takes place, okay, so leading to the increased chance for DIC. Now in cases of amniotic fluid embolism, the thromboplastin rich liquor enters into the maternal circulation, and this blocks the pulmonary arteries, and then the clotting system gets affected, and there is clotting factor deficiency leading to DIC. Next question. 22-year-old married female presents to you with complaints of severe dysmenorrhea during the menstrual periods associated with heavy bleeding and inability to conceive. So there is a history of dysmenorrhea in a 22-year-old married female, and there is also a history of heavy bleeding, that is menorrhagia. So there is a history of dysmenorrhea, there is a history of menorrhagia, and there is a history of infertility. This is available, and there is a constant dull aching pain, pelvic pain radiating to the left thigh. Pain is increased after her menstrual cycle. On ultrasound, there is an ovarian cyst in the left ovary. So there is a history of ovarian cyst in the left ovary measuring 3 cm by 2.5 cm. On further question, you elicit history of laparoscopic appendectomy 1 year prior, where she was incidentally diagnosed as a case of endometriosis. So it's already given in the question, the diagnosis of this patient. Now, what will be the best suggested choice of treatment in this case? Okay. Now, the options given to me are danazole, Dynogest, leuprolide, and LNG IUCD. Frankly speaking, all of the following are the treatment for endometriosis, but she has inability to conceive, she has severe dysmenorrhea. Danazole in a young patient I will not prefer because it is an androgen derivative. It is an androgen derivative and it causes androgenic side effects like acne, like oily skin, then hirsutism. In long run, it can cause breast atrophy, and it can also lead to secondary amenorrhea. So this is not advisable in young patient. Moreover, she may be planning to conceive because it is written in the question inability to conceive. So again, I will not give IUCD in this case because IUCD will provide a contraception which is not needed in this case. Now, leuprolide again is a GnRH analogues, and long run it cannot be given because it is known to increase the anti-estrogen side effects. Anti-estrogen side effects like hot flushes, sweating, palpitations, and also in long run it causes bone resorption. So there is increased chance for osteoporosis. So it cannot be continued for longer duration. So preferred answer is Dynogest, which is a progesterone in this case. Next, which of the following is not a part of CDC? CDC means Center for Disease Control 2015 guidelines for the definitive diagnosis of the PID, pelvic inflammatory disease. Now, what is pelvic inflammatory disease? Pelvic inflammatory disease is, like ascending infection. It is ascending infection to the uterus, that is called as endometritis. Ascending infection to the tubes, that is called as salpingitis, and then infection spread to the ovaries, that is called as oophorytis. Okay, oophorytis. So this is what is PID. Infection of upper genital tract of the female. Lower genital tract is resistant, so vagina is resistant to any PID infection. The causative agents for PID includes the chlamydia, the gonorrhea, the mycoplasma, etc. Now let us see which is not included in the definitive criteria for diagnosis of PID according to CDC guidelines. Transvaginal ultrasound or MRI showing thickened tubes, fluid-filled tubes or tubovarian masses. This is true. Now, Doppler studies suggest a pelvic infection. That is also true. Then histopathological evidence of endometritis. This is also true. Lab documentation of cervical infection with Neisseria, gonorrhea or chlamydia. This is false. This is a false statement because that is not included in the definitive criteria. Okay, that is not included in the definitive criteria. So there is additional criteria, minimal criteria, and definitive criteria. Now, minimal criteria is when you do clinical examination of the patient, there may be a finding of adnexal tenderness because there may be tubo-ovarian masses or tubo-ovarian inflammation. So that is leading to adnexal tenderness. There can be cervical motion tenderness or there can be uterine tenderness. That signifies there is endometritis, salpingitis and oophorytis. So this is minimal criteria. Additional criteria include that we are doing some basic investigations like temperature is raised, abnormal mucopurulent discharge, abundant WBC in saline microscopy, that is a finding when it is a chlamydia infection that has been suspected, but it can also be a finding in other PID causative agent infections. There is increase in the ESR, increase in CRP, C-reactive protein, and there is lab findings suggestive of chlamydia or gonorrhea infections. So this point is in the additional criteria, not in the definitive criteria. The definitive criteria include the specific investigations like we take the endometrial biopsy and send it for histopath showing endometritis. We can send for an ultrasound to check for the tubo-ovarian masses or inflamed tubes. Then there can be laparoscopic finding which is suggestive of the hyperemic or inflamed fallopian tubes or tubo-ovarian masses or hydrosalpinx, etc., which is also a gold standard investigations. Now next, which of the following statement is not true for modified radical hysterectomy? Modified radical hysterectomy is also called as Werdheim's hysterectomy. Werdheim's hysterectomy is usually the treatment for the cancer cervix or cancer endometrium. So which is wrong statement? Uterine artery is ligated at the point where it crosses the ureter. This is true. That is at the level of internal os. The cardinal ligament is divided at pelvic wall. 2 to 3 centimeters of vaginal cuff is removed. The uterosacral is divided more anteriorly. This is also true. This is also true. This is a false statement. Cardinal ligament is ligated at the level of pelvic wall. That we do it in cases of radical hysterectomy, not in cases of Werdheim's hysterectomy. In cases of Werdheim's hysterectomy, suppose these are the McEnroe's ligament. These are the McEnroe ligament, and suppose this is the uterine artery and ureter is posterolateral. Ureter is posterolateral. Okay, so here is the point where we ligate the uterine arteries. This is true statement. Then uterosacrals is divided more anteriorly. This is also true. Vaginal cuff is removed. That is also true. But cardinal ligament is not ligated at the pelvic wall. It is not ligated near the pelvic wall. It is ligated, like away from the pelvic wall. So this is a wrong statement. Next question. 64-year-old woman presents to the OPD with the chief complaints of postmenopausal bleeding. So there is a history of postmenopausal bleeding for 6 months. She is diabetic for 10 years, hypertensive for 8 years, also dyslipidemia. So already risk factors are present. There is postmenopausal bleeding, diabetes, hypertension, dyslipidemia. On examination, the BMI is 37.8, blood pressure is 150/100, uterine enlargement on abdominal palpation, speculum examination, there is bleeding per vaginum. You recommended a transvaginal scan to check for endometrial thickness, which is also increased. Cutoff value for endometrial thickness in a menopausal lady is 4 mm. So it is increased, and surgical staging is done for this. That means biopsy must have been taken, and it has been done, and it shows a stage 2 cancer endometrium with lymphovascular space invasion with grade 2 histology. So that is moderately differentiated lymphovascular space invasion and stage 2 cancer. Stage 2 cancer means the endometrial cancer has involved the cervix. So cervix, extension to the cervix is stage 2, but also a finding is there. There is, it is moderately differentiated, plus there is lymphovascular space invasion which is seen. So lymphovascular space invasion itself carries a high risk. So this patient is a high risk case of endometrial cancer, but it is moderately differentiated. What is the treatment of choice you recommend in this case? So this is a stage 2 cancer endometrium with moderate differentiation, and there is lymphovascular space invasion. So hysterectomy with sentinel lymph node biopsy, hysterectomy with lymphadenectomy followed by medroxyprogesterone acetate, hysterectomy with lymphadenectomy and chemotherapy, hysterectomy with lymphadenectomy and vaginal brachytherapy or external beam radiation. So I would like to select in this case the post-operative radiotherapy. For stage 2, the treatment is surgery in the form of hysterectomy plus lymphadenectomy and followed by post-operative radiotherapy is the treatment of choice in this question, because it belongs to high risk. Now, what are the high risk cancers? High risk cancers is, here the histopathological finding is not clear that it is endometrioid adenocarcinoma. Most probably we presume that this is endometrioid adenocarcinoma with stage 2, that is extension to the cervix and lymphovascular space invasion. So apart from hysterectomy, post-operatively I would like to give a vaginal vault radiation. Okay, so that recurrence, the most common site of recurrence of endometrial cancer is vaginal vault, or I would like to give external pelvic radiation. Now this is endometrioid adenocarcinoma. 80% of endometrial cancer is well differentiated endometrioid adenocarcinoma. Clear cell carcinoma are containing the Hobnail cells, which are solid tumors, and usually there is myometrial invasion, which is common. They are fast spreading tumors. There is always lymphovascular space invasion in this case, and it carries usually a poor prognosis. So less than 5% of endometrial cancers are clear cell carcinomas, and some variety is papillary serous, which is also a high risk case, that is type 2 endometrial cancer. Now, next question. A 67-year-old female presented to you after noticing a small growth in the vulva 8 months ago. Okay. So it is painless and hence patient did not present earlier. However, for last 1 month, the lesion grew in size and she noticed a blood-stained discharge. On examining local lesion at the vulva, which is measuring 5 centimeters in size adjacent to the perineum and vagina, FIGO staging was done and shows 5 centimeters tumor with extension to the lower 1/3 of vagina, and 2 positive inguinofemoral lymph nodes, which is usually less than 5 mm. According to the FIGO stage of vulval cancer, what will be the FIGO stage? Stage 2, stage 3A, stage 3B, or stage 3C. So it is categorized as stage 3A. Let us see. Stage 1 is tumor confined to the vulva. Stage 2 is tumor extension to the lower 1/3 of the vagina, but lymph nodes are negative. Okay. Stage 3 is where there is extension to the upper 2/3 of the urethra as well as upper 2/3 of the vagina, bladder mucosa and rectum, and regional lymph nodes are less than 5 mm. So this is stage 3A. If the lymph nodes are more than 5 mm, then we will consider as it's 3B. If there is extra capsular spread, then it will be considered as 3C. So, but presently this will be less than 5 mm, the femoral, inguinofemoral lymph nodes. So, it will be considered as stage 3A. Next question. A 28-year-old woman presents to OPD with complaints of vulval itching, vaginal discharge. There is inflamed and edematous vulva. There is pain during micturition. There is a foul smelling greenish frothy discharge with strawberry vagina. So greenish frothy discharge with strawberry vagina, and saline microscopy shows flagellated organism. So it is no other than trichomoniasis, which is a protozoa. Causative agent is Trichomonas vaginalis. There is a foul smelling greenish vaginal discharge. There is strawberry vagina. So this is trichomoniasis, and the drug of choice for trichomoniasis is metronidazole 400 milligram BD for 7 days to both partners because it is STD. So this is the correct answer. Now, very commonly they ask you the Amsel's criteria as well. So what is Amsel's criteria? Amsel's criteria is seen in bacterial vaginosis. Bacterial vaginosis is not STD and there is no itching. Whenever the lactobacillus are being replaced by other microorganism like Gardnerella vaginalis, like Haemophilus, like Mycoplasma, then bacterial vaginosis occurs. So Amsel's criteria includes when the pH is more than 4.5, there is clue cells present, there is musty odor or fishy odor, vaginal discharge which is seen, and there is whiff test which is positive. Whiff test is we take the vaginal discharge on a slide and we put QH, there is a fishy smell. That is Amsel's criteria for bacterial vaginosis, and the drug of choice is metronidazole, but we don't treat the partner since it is not STD. If there is thick curdy white vaginal discharge, then that is candidiasis. Thick curdy white vaginal discharge, then that is candidiasis. Now next question, a couple married for 3 years presents to you with difficulty in conceiving. On taking the detailed history and examination of the female partners, there is no abnormality. On examination of the male partner, the left testicular size is enlarged than the right, and on palpation there is bag of worms feel on the left testicle. What is this condition or which is causing infertility? Cryptorchidism or chitis, mixed gonadal dysgenesis or varicocele. So whenever we used to study the surgery during our final year MBBS, and we were shown this case, bag of worms filling with one testicular enlargement, this goes in favor of varicocele, where the lymphatic drainage from the testis is affected and there is pampiniform plexus which is being dilated. So this requires a surgical correction. Surgical correction. For that, the patient has to be referred to the surgeon. So according to the history and the examination given to me, I would like to mark the answer as varicocele. In cases of mixed gonadal dysgenesis, there may be dysgenetic gonads, maybe in the, like in the testis, or that is in the genital inguinal region, or in the, like there can be a male genitalia. Now, next is, which of the following is not true for the ovulation? Triggered by LH surge, release of oocyte from the ovarian follicle on day 14 of the menstrual cycle. The oocyte released has completed a second meiotic division and second polar body is extruded. The oocyte is haploid. Oocyte is always haploid. Okay, this is true statement. Triggered by LH surge, that is also true. Release of the oocyte from the ovarian follicle occurs on day 14, that is also true. But the false statement is oocyte is released, has completed the second meiotic division, that is wrong. Second meiotic division is completed and the release of the second polar body occurs at the time of fertilization. At the time of ovulation, it is the first meiotic division. It is the first meiotic division, plus there is release of the first polar body that take place, not the second polar body. Next question. An intern is given a case scenario of 4 pregnant patients in which he has to rule out whoever of the following patients can continue pregnancy and would not need the termination, therapeutic termination of pregnancy, means which is not an indication for MTP. Which of the following has been chosen as an answer by him? A 28-year-old female with pulmonary artery hypertension. Pulmonary artery hypertension is always an absolute contraindication for pregnancy. So it is an indication for MTP. 25-year-old female with Eisenmenger syndrome. Eisenmenger syndrome is also an indication for MTP because in Eisenmenger syndrome there is reversal of shunt. There is reversal of shunt, there is pulmonary artery hypertension, and in Eisenmenger syndrome there is right to left shunt. So pregnancy should be strongly discouraged. Also there is chances of systemic thromboembolism. So MTP is recommended by suction evacuation method because maternal mortality is nearly 50% and perinatal mortality is 60 to 70%. Next option, a 26-year-old female who is a known case of previous peripartum cardiomyopathy. This is also an indication for MTP, and when the peripartum cardiomyopathy occurs, which usually occurs, like in the last month of pregnancy or after the delivery, so there is left ventricular function dysfunction occurs. Okay, so pregnancy is strongly discouraged. Now 27-year-old who has undergone a prosthetic valve replacement is not an indication for MTP. Other contraindication or indications for MTP includes the severe mitral stenosis, severe aortic stenosis because there is a fixed cardiac output and there is usually hypotension. Then there can be Marfan syndrome with aortic valve involvement. Then there can be uncorrected coarctation of aorta. So what are the indications for MTP? Pulmonary artery hypertension, Eisenmenger syndrome, peripartum cardiomyopathy, severe mitral stenosis, severe aortic stenosis, Marfan syndrome with aortic valve involvement. Then there is aortic dilatation and there is coarctation of aorta which is uncorrected. Next question. A pregnant female at 12 weeks of gestation presents to the obstetrics OPD with complaints of weakness and fatigue doing daily household activities. The physician orders a complete blood testing which reveals hemoglobin of 9.1 gram per deciliter. Which of the following statement is incorrect about anemia in pregnancy? In physiological anemia of pregnancy, MCV is decreased. Reticulocytic count. Reticulocytosis is the earliest hematological response to iron therapy. This is true statement. Rise in hemoglobin with parenteral and oral iron is same. Yes, that is rise of hemoglobin is 0.7 to 1 gram per deciliter occurs if you give oral or parenteral iron, and this effect is seen in 2 weeks of iron therapy. Less than 7 gram per deciliter hemoglobin in the third trimester is an indication for blood transfusion. This is also true. In physiological anemia of pregnancy, MCV is normal. It is not decreased. So wrong answer in this question is A option. Okay. Physiological anemia of pregnancy occurs due to hemodilution of blood where the hemoglobin is 10 gram %, but MCV is usually normal. Peripheral smear shows normocytic normochromic anemia. RBC count is normal 3.2 million per cubic millimeter. So these are the normal parameters of physiological anemia occurring during pregnancy. Next question. During an obstetric viva, a professor asks a student about point marked A and B in the following diagram by giving 4 statements. Ask him to identify the wrong one. Which of the following would have been chosen by the student so that the professor is satisfied with the answer? Now, what is measured in this question? From the sacral promontory, that is S1 vertebra, to the lower border of symphysis pubis, this A part is a diagonal conjugate. So, diagonal conjugate is the one which we clinically measure. Diagonal conjugate is the one which is clinically measured and it is nearly 12 centimeter. Then from the sacral promontory to the midpoint of symphysis pubis is point B. This is obstetrical conjugate. This we cannot measure clinically. This is nearly 10 centimeters. So we can measure the diagonal conjugate and subtract 2 from it. We will get obstetrical conjugate. From the upper border of symphysis pubis to the sacral promontory, this will be the anatomical conjugate, which is usually 11 centimeters. So let us see what are the options. Point A is the only conjugate we clinically measure, that is true. Normal range for point A and point B is 12 and 11 centimeters false. For point B, it is 10 centimeters. A point A is less than 12 centimeters. Yes, that is also true. So the wrong statement in this question is B, since the obstetrical conjugate is not 11 centimeter, it is 10 centimeter. Next question. A 24-year-old G2P0 presents to you with 16 weeks of her pregnancy. She gives you a history of previous abortion at 20 weeks. Okay, now she is 16 weeks. On performing the transvaginal ultrasound, cervical length is 20 mm. So normal cervical length is 25 mm. So there is shortening of cervical length plus there is previous history of mid-trimester abortion. So from this, I make the diagnosis of cervical incompetence, which is most likely cause of abortion in this case. Also, there is funneling of cervix. What will be the next step in management? Start the patient on progesterone, cervical encerclage only, progesterone along with cervical encerclage, lash technique. Lash technique is to do surgical management of the cervical encerclage procedure. Okay. So, progesterone along with cervical encerclage is the answer I would select. Now, if the cervical length is more than 2.5 centimeters, then you give progesterone. If the cervical length is less than 2.5 centimeters, we give progesterone and do cervical encerclage. Next, if progesterone can be given only in two conditions, if the cervical length is less than 2.5 centimeter or there is history of second trimester abortion. Now, cervical encerclage is done in two conditions, history of 2 second trimester abortions or there is 1 second trimester abortion plus the cervical length is less than 2.5 centimeters. So, in this question, the answer would be progesterone plus cervical encerclage operation. Next question, which of the following is a risk factor for secondary PPH? First of all, that is very, very important for you to know what is secondary PPH. What is PPH? PPH is any amount of blood loss that affects the general condition of the lady after delivery or a drop in the hematocrit to 10%. Okay, so PPH can be a primary PPH, that is postpartum hemorrhage occurring within 24 hours of delivery. Secondary PPH, postpartum hemorrhage occurring after 24 hours of delivery within 12 weeks of delivery. That is what is very important questions nowadays. And the most common cause for secondary PPH is succenturital lobe, that is accessory lobe of placenta or retained bits of placenta. So all of the following are risk factors for secondary PPH. Which is the risk factor? Obesity, instrumental delivery, obstructed labor or retained placental tissue. So the correct answer is retained placental tissue. Which type of placenta? That is succenturital lobe, which is accessory lobe of placenta. So that is why it is very, very important for you to examine the placenta after the delivery. There may be a missed cotyledon. So if you examine it after the delivery, the conditions like secondary postpartum hemorrhage can be prevented. So that's all from Obs and Gynae discussion. Thank you and all the best, and prepare well for your upcoming INI-CET and NEET PG exam. All the best.
Hello friends, now we discuss psychiatry questions. First question. A 25-year-old laborer presented in psychiatry OPD with sadness of mood. First symptom is sadness of mood. Tiredness means decreased energy, second symptom. Wakes up early in the morning, is unable to fall asleep again. This is early morning awakening. Early morning awakening or insomnia, sometimes called terminal insomnia. So third symptom, his appetite has markedly reduced. Fourth symptom of depression, no interest in daily activity. Fifth symptoms of depression. You all know, in depression, according to DSM-5, if 5 symptoms are present for more than 2 weeks, then diagnosis is depression. I am leaving this question for the time being. Just to tell you, mnemonic is EMI gaps cause depression. Low energy, sadness of mood, decreased interest, guilt, appetite, decreased psychomotor activity, sleep, decreased sleep, early morning awakening, terminal insomnia, suicide, concentration. Out of these, if 5 symptoms are present for more than 2 weeks, then the diagnosis is depression or major depressive disorder or unipolar depression. Unipolar depression. You all know. Suppose a patient came to me having depressive symptoms and 5 symptoms are there, criteria of depression is fulfilled, I will say this is depression. Okay. This patient is treated. Now this patient develop again one more episode of depression. Then at this time, I would say that patient is having recurrent depressive disorder, means depression is occurring again and again. Recurrent depressive disorder, more than one episode of depression. So in this question, till now, if I ask you what is the diagnosis, definitely you will say the diagnosis is depression. Diagnosis is depression or unipolar depression. He reported that these symptoms started in winters and he had similar episode for last 3 years, means more than one episode of depression, recurrent depressive disorder. But they have mentioned that every time these symptoms appear in winters. So again I come to this, if symptoms are occurring again and again and every time these symptoms occur in a particular season, just like they have given winters, and the cause of depression is winter, circadian rhythm is changed, then it is seasonal affective disorder. Seasonal affective disorder. So I repeat, if depressive criteria is fulfilled, depression, unipolar depression or major depressive disorder, if depression is occurring again and again, recurrent depressive disorder, more than one episode, recurrent depressive disorder. If depression is occurring in a particular season every time, then it is seasonal affective disorder. So in this question, they have mentioned that these symptoms are occurring, these episodes are occurring for last 3 years, which start with winter and remit during spring. Means this, up to this, yes, point out, till this diagnosis I made depression. Now if question is up to this, yes, up to this, then I will say seasonal affective disorder. Why I am telling you like this? Because questions are asked and they can change language, and if language is changed, answer is changed. So up to this, answer is seasonal affective disorder, but they added further. After taking the detailed history, it was found that he remains unemployed in winters as the factory remain closed. Means every time depression is occurring in winters, but winter is not the cause. And if winter is not the cause, then it is not seasonal affective disorder. It is not seasonal affective disorder. It is RDD. Yes, ICD-11 clearly says, yes, seasonal pattern should be differentiated from an episode that is coincidental with a particular season but predominantly related to psychological stressor that regularly occurs at that time of the year. Seasonal unemployment. So if seasonal unemployment is there, then it is recurrent depressive disorder. If this is due to winters or particular season, that is a seasonal affective disorder. So in this question they have given, this is the reason stressor is unemployment. So answer is yes, recurrent depressive disorder. So in this question they have asked what is the most probable diagnosis. Yes, two options, major depressive episode with seasonal pattern. Okay, they have asked the diagnosis of current episode. Okay, this is little bit confusing, although they should ask the diagnosis, and in this diagnosis best answer would be recurrent depressive disorder, but recurrent depressive disorder option is not given, so I will prefer to mark that. So answer would be major depressive episode. Okay, this episode is major depressive episode, not seasonal pattern. Okay, so best answer recurrent depressive disorder not given in the option. Best answer is B. It can't be said that it is due to seasonal pattern. Got the point? Other option, dysthymia. If a patient came to me having depressive symptoms are there, 5 symptoms are not there, means depressive criteria is not fulfilled. Depressive criteria is not fulfilled. 3 symptoms are there, 4 symptoms are there, not 5 symptoms, and these symptoms continue for 2 years. Then it is dysthymia. Dysthymia means subsyndromic symptoms of depression. Clear? What is cyclothymia? If a patient came to me, having depressive symptoms, manic symptom or hypomanic symptom, depressive symptom, manic hypomanic symptom for 2 years, again 2 years, but these symptoms never fulfill the criteria of hypomania, mania or depression. Means fluctuation of mood, cycle change. I usually remember by a mnemonic, just like the mood of HOD. You go to HOD in morning and he's very happy, say you are the best resident I have ever seen and he's very happy with you, he's smiling. You thought in the evenings, yes, I should meet my HOD in evening. What are you doing? Yeah? Every time you come here, means kabhi khush, kabhi gum, kabhi khushi, kabhi gum, but never fulfill the criteria of depression, mania or hypomania. That is cyclothymia. So in this, cyclothymia is not the answer, dysthymia is not the answer. This can't be a seasonal pattern because this every time in winter symptoms occur, but not due to winter, but due to stressor. Got the point? Second question, a middle-aged man has been drinking 700 ml alcohol daily basis for past 15 years. For a long time alcohol is being taken, and you know alcohol has adverse effect on liver may be gone. Okay, I point out for the timing. Now he claims that even drinking 200 ml of alcohol can have same effect. Means previously he used to enjoy 500, 700 ml. Now he enjoy only 200 ml. Patient is happy, doctor is happy, but no need to be happy. It is end organ damage. It is called reverse tolerance, and it indicate end organ damage. Means liver is gone. Alcohol is metabolized by liver. When he will take a small amount of alcohol, will not be metabolized, will remain in blood and will give the same effect as 700. So no need to be happy. So this is reverse tolerance. You all know question has been asked, what is tolerance? Means suppose a person start taking alcohol. When you start taking alcohol, a small pack give you pleasure. But to get the same pleasure, after 2-3 years, multiple years, you take half bottle, yes, means increase amount of substance to get same pleasure. Increase amount of substance to get same pleasure is tolerance. And decrease amount of substance to get same pleasure, reverse tolerance. It's not a good thing. It is indicative of end organ damage. Other option, withdrawal symptom, you all know, if you are taking for 15 years and now you stop, you have tremors. Yes, tremors, question has been asked. This is earliest and most common withdrawal symptom. Other than generalized tonic-clonic seizures may be there. Other than delirium tremens, Usually questions are asked, delirium tremens usually occur on 2nd to 3rd day. Less than 72 hours, usually, not always. In delirium tremens, there is, yes, delirium means altered sensorium, plus tremors, plus history of alcohol. And the treatment of delirium tremens is IV lorazepam plus IV thiamine plus IV dextrose. Point it out. Question has been recently asked. Dextrose should be given after thiamine, or thiamine is given before dextrose. Why? Because you know dextrose carbohydrate metabolism require thiamine. So if thiamine is less in alcoholic patient, absorption of thiamine is less, patient is already having thiamine deficiency, and if you give dextrose, all the thiamine of the body will be utilized by that dextrose and there would be acute precipitation of thiamine deficiency. So question has been asked, yes, thiamine first, then dextrose. So withdrawal symptom, few questions are there. I have discussed. What is Mellanby phenomena and cross tolerance? Yes, Mellanby phenomena, when you start taking alcohol and you are enjoying alcohol, blood alcohol concentration is increasing. Your intoxication effect will be more. Suppose at 200 milligram per deciliter, you are having slurring of speech, blackout. Yes, means blood alcohol concentration is increasing. Another person who is having same blood alcohol concentration 200 milligram per deciliter, but now the alcohol concentration is decreasing, he would have less symptom of alcohol intoxication. Means symptom of alcohol intoxication is more when blood alcohol level is rising and less when blood alcohol concentration is decreasing if seen or at the same level. Means at 200 milligram per deciliter, yes, at this point symptoms would be more because alcohol concentration is increasing. At this point symptom would be less as alcohol concentration is decreasing. This is Mellanby phenomena. Cross tolerance means tolerance to the effect of one drug produces tolerance to another drug. It usually happens when two drugs have similar pharmacological action, just like alcohol and benzodiazepine. That is called cross tolerance. Next question. A male patient exhibit skin lesion on his forearm and chin. Okay, chin means face, I point out. Okay. He informs you that these lesions are result of frequent desire, urge to pick the skin. Yes, urge means he has desire, urge to pick the skin, usually face, yes, forearm. Okay. Until there is lesion. Before picking, he experienced some sort of stress. After picking, he experienced some satisfaction. Although he is guilty of this behavior, he was unable to change it. Means intense urge is there, picking face, lesion is there, excoriation disorder. Yeah, this is excoriation disorder. Okay. Now, this is recently asked topic, recent change in classification, very potential topic. So you must have an idea. I just described excoriation disorder, urge to pick skin again and again, leading to tissue damage. And most common site is face. Okay, excoriation. This is part of OCRD, obsessive compulsive and related disorder. OCRD, according to ICD-11, few changes are there. These are the disorder which have been included in OCRD. Mnemonic is hobby. In hobby, you do things again and again. Whatever hobby you have, you do things again and again. Yes, so which is done again and again. So in all these disorder, you will find, means when clinical scenario would be there, you will find that things are being done or thoughts are coming again and again. So hoarding disorder, H for hoarding and hypochondriasis, O for OCD and olfactory reference syndrome, B for body dysmorphic disorder and body focused repetitive behavior disorder. Body focused repetitive behavior disorder include two disorder, excoriation and trichotillomania. Excoriation means scratching again and again till the tissue damage, most common sign face. Trichotillomania, pulling hair again and again, intense urge. Yes, so in these two, body is the focus. In excoriation, skin is the focus. In trichotillomania, hair is the focus, and repetitive behavior is being done. That's why both of these are included in body focus repetitive behavior disorder. Recently asked question in INICT, trichotillomania was previously classified as impulse control disorder. Impulse control disorder in ICD-10. But in DSM-5 and ICD-11, it is part of OCRD. Got the point? Second question, hypochondriasis is also included in OCRD. Yes. So in this question, answer is excoriation disorder. What about other option? OCD, you know OCD, obsessive compulsive disorder, recurrent and intrusive thought. Patient want to stop these thought, unable to stop thought. And most common obsession is contamination and compulsion is hand washing. And second most common obsession is pathological doubt. Okay. So most common obsession, that is contamination. Compulsion is washing. Second most common obsession is pathological doubt. This question has been asked, that they ask most common obsession. Yes, contamination was not given the option. Answer was pathological doubt. Very important point. Most common compulsion is not washing. Most common compulsion is checking. This is important point. Most common compulsion. Okay. So obsession, contamination, compulsion, washing. But most common compulsion is checking. Most common obsession, contamination. Dermatitis artifacta or factitious dermatitis, disorder in which skin picking is usually deliberately for producing self-inflicting injury. The morphology of factitious dermatitis lesion often bizarre, linear, with clear-cut, angulated, geometric edges like that. Okay. Yes, Magnan phenomena or formication or cocaine bug. Cocaine bug. Yes, that is tactile hallucination. Tactile hallucination. So, skin picking behavior may be seen in Magnan syndrome or Magnan phenomena, but in this history of cocaine use would be there. So, this is not the answer. So, answer is excoriation disorder. Now, this question. A 30-year-old woman arrives at OPD complaining of stomach pain, abdomen, okay, backache, headache, multiple symptoms are there that have been present for 1 month, okay. There are several scars on abdomen observed during journal physical examination. This is important. Multiple scar mark on abdomen. Yes, patient was eager to receive diagnosis and insisted on having a treatment or some sort of examination carried out. Okay, the patient history was lengthy and complicated, involving numerous doctor visits and procedures. What is the medical diagnosis? Okay, first of all, you can rule out schizophrenia easily, because in schizophrenia there is delusion, hallucination for more than 6 months. Out of 5 symptoms, 2 symptoms or more than 2 symptoms should be present for more than 6 months. This is ruled out. Malingering, yes, can be ruled out, because in malingering there must be some financial incentives, avoidance of legal case or tough job, and patient usually don't cooperate. So, means in this question, there is no hidden or materialistic gain, okay, no secondary gain appears. Now we come to factitious disorder and hypochondriasis. Hypochondriasis, I tell you that minimal or no symptom are considered sign of deadly disease. Hypochondriasis, another name is illness anxiety disorder. Illness anxiety disorder. Illness anxiety disorder. Minimal or no symptom are considered sign of deadly disease. What does it mean? Suppose a person came to you, Dr. Saab, you know that I had yellowish discoloration of urine yesterday. You know, yellowish discoloration of urine occur in jaundice. Jaundice occur due to liver disease. Liver disease may be due to liver cancer. Dr. Saab, I may be having liver cancer. Means deadly disease, lethal disease. In this question, patient is not concerned about the lethal disease. Patient presented with few symptoms, but not concerned with lethal disease. So in this, patient would present with minimal or no symptom. When patient would present yellowish discoloration of urine, you will do examination, you will try to elicit sign, you will find no sign. No sign. You will investigate, all investigation normal. Investigation normal. And patient will visit multiple doctors. So in this question, they try to confuse that patient is visiting multiple doctors. Okay. So, and they gave some symptoms, but in hypochondriasis or illness anxiety disorder, patient consider minimal or no symptoms as a sign of deadly disease. You will find no sign, all investigation would be normal, multiple doctors would be visited, but they are concerned with lethal disease, just like cancer, HIV, myocardial infarction. So in this question, it is not like that. So this is not hypochondriasis. Factitious disorder is the answer. What points suggest about factitious disorder? You can see that multiple scar mark over abdomen. Factitious disorder, patient produce fake full symptom. I write here, patient produce fake full symptoms to get medical attention. Medical attention. Okay. Means patient would come to you, Doctor, I am having pain abdomen, right iliac fossa. You will palpate, you will find that rebound tenderness. You will say you might be having appendicitis. He would say, Doctor, operate. You will say ultrasound. No, Doctor, operate. You operated. He enjoyed the company of doctor. Company of doctor, not nurses. He enjoyed the company of doctor for a few days. Means research was conducted why they are coming again and again and being operated, and it was the finding that they get unconscious pleasure. What I said, unconscious pleasure in the company of doctor, that is primary gain. Whatever gain you get at unconscious level, that is called primary gain. So factitious disorder patient get primary gain. In malingering, patient get secondary gain, materialistic gain. This question has been asked. Okay, so in this primary gain, patient get unconscious pleasure in the company of doctor. That's why he is being operated again and again. And sometimes you will find that the abdomen is having multiple scar mark. What I said, multiple scar mark which appear grid iron abdomen. Grid iron abdomen. Okay. So this is factitious disorder. Patient would come again and again, visit doctors, and will procedures, surgical procedure may be done. And another name of factitious disorder is Munchausen syndrome. Munchausen syndrome. There is a story on Google. You will find that there was a French soldier who was having this factitious disorder named Munchausen. He was having this disorder and he was having so many scar marks on his abdomen. His fellow soldiers thought that he might have gained all these scars in fight. And he was promoted to Commander General. Later on, he was found to be having this factitious disorder and was kicked out of the army. So this is factitious disorder, Munchausen syndrome. Okay. Now, last question, which of the following describe a 26-year male who prefers to be disconnected, avoid social situation, spend lot of time alone, means prefer solitary activity. Prefer solitary activity. Yes, does not experience pleasure. This point I keep here. Okay, is more interested in introspection, his own fantasy world, and himself. What would be the most probable diagnosis? Yes, this point is not suggestive of this schizoid, but most of other points are suggestive of schizoid. Okay. Schizoid personality. First of all personality. Why I'm saying this point is a little bit confusing, because all personality disorder are egosyntonic. Egosyntonic. Agreeable to self. But avoidant personality disorder is ego dystonic. Okay, not agreeable. So for the time being, yes, all these symptoms are suggestive of schizoid. Mnemonic is shy. Just like a shy person, although they are not shy, but just like a shy person, prefer to remain alone. Prefer to remain alone. Prefer solitary activity. You can remember any of your friend who in MBBS days who is sitting in library since morning to evening without girlfriend. Okay, that is means he is enjoying reading himself. Okay, he is emotionally cold and detached, means no emotions. He remained detached, indifferent to praise or criticism. You will sometimes praise him. Yes, oh, so much of stuff you are reading. No response. Criticism. What will you do after reading so much? Indifferent. Little interest in sexual activity. If marriage occurs, divorces, sure, these are schizoid personality disorder, and they are happy with their personality, because all personality disorder are ego-syntonic. So in this schizoid personality disorder, most of the symptoms suggestive of schizoid personality disorder. Other option, paranoid personality. Paranoia means suspiciousness. Suspiciousness means they are suspicious over friendly act. You may remember any of your childhood friend who is paranoid, suspicious, who is suspicious over friendly act. I do remember one person, and I ask my students to remember any of your friend who is little bit suspicious, and I make a story. Yes, your childhood friend who now you gave him 2 movie ticket because your girlfriend denied that I don't want to go to movie. So you thought, what will I do with these movie tickets you gave to your friend, paranoid friend? Friend said, why he is giving me ticket worth 1,000 rupees? Means it was your friendly gesture, but he is suspicious over friendly act. Friendly act. They keep grudges for long time. Long time. Means remember your childhood days, your best friend, when you were in 4th class, you ask your friend, or your friend ask you, better to say, your paranoid friend ask you, friend, please tell me answer of this question. But your parents told no cheating, no cheating. So you ask your paranoid friend, no cheating, no cheating. Time flies, you enter 10th class, 12th class, MBBS, second year, glomerulonephritis question was there. You thought that if you get hint of this question, which type of glomerulonephritis they are asking, you will definitely write, you ask your paranoid friend, friend, just give me a hint. Your paranoid friend would say, remember 4th class, no cheating, no cheating. They keep grudges for such a long time. So now you will never forget these 2 features. They believe in conspiracy theory, Crime Patrol, Savdhan India. These are the most favorite serials they usually watch. The paranoid personality. Okay, so this is nothing in this question, nothing like that. OCPD. OCPD, obsessive compulsive personality disorder. Symptoms are they are preoccupied with rules and regulation. Yes, just like Parampara, Pratishtha, Anushasan. Yes, movie, you remember Amitabh Bachchan. In that movie, yes, he was so preoccupied with rules and regulation. No sense of humor. You never seen him smiling. Perfectionism that slows them down. This question is many times asked in personality disorder. They give clinical question that this person is not completing his project on time. Though perfectionism, they do things in perfection. That's why it take more time. So they don't complete their task on time. They are stubborn and inflexible. You remember that Aishwarya died, daughter died in In spite of that, he did not change. Means stubborn, inflexible, never seen him taking laser activity. So no laser activity. This is OCPD. Yes. Mohabbate Amitabh Bachchan or Three Idiot Virus or any professor of your MBBS days, there must be at least one professor you have never seen him smiling and he is cutting your numbers on small mistakes. That is OCPD. Okay. Schizotypal, schizophrenia के type का. Yes, type of schizophrenia, not like that. Yes, schizotypal according to ICD 10-11. Yes, these personality disorder I am discussing according to DSM-5. But ICD 10 and 11 said, okay, all these personality disorder we do agree, but schizotypal is not. Why? They said that schizotypal is having odd and eccentric thinking, magical thinking. What is magical thinking? 1, 2, 3. I tapped 3 times. So there would be brain in Bombay. Just like of magical thinking is there. Illusions are there. Momentary hallucinations are there. So ICD 10, 11 said, both of them said, yes, why we are considering it as personality, we should classify them as psychotic disorder. Psychotic disorder. But DSM, it is personality disorder. Schizotypal, you will remember. So, in this question, answer is not schizotypal. You know the symptoms. OCPD, you know the symptom. Yes, best answer is schizoid personality disorder. So, these are the questions of CBoT. I have tried to discuss few other points relevant for your exam, and during this preparation phase, be positive, be confident. Whatever you have studied will remain in your mind. Don't feel that you are forgetting. Everything is present in your mind. If you will remain confident, remain positive, everything will come at your conscious level in your exam. So during this preparation, always be positive. Thank you.
Ladies and gentlemen, welcome to the CBoT 5 of Ophthalmology, and leading you through this minefield of questions is again your friendly neighborhood ophthalmologist, yours truly, Sashwat Ray. I'm sure many of you will be fed up of my ugly mug by now. But what to do? We can't all be as handsome as you people are. During a fight in the college, a young adult got punched in the left eye. Dear me, that sounds bad. After which he noticed drifting black specks, strings and cobwebs upon moving the eye, along with general blurring and a reddish tint of vision. Now, there's too many clues here. See, there's a lot of floaters here, okay? And the reddish tint of vision with blurring of vision, okay? Now, that points to what? That points to vitreous hemorrhage, is it not? Reddish tint, sudden painless loss of vision, floaters should be clear in your mind as we're talking about a vitreous hemorrhage. The ophthalmologist suspects vitreous hemorrhage, guilty. Which diagnostic method is preferred for further investigations? Is the electroretinogram incorrect? ERG cannot help you because ERG measures the potential difference of the retina. There's no role for ERG in this condition. We would do ERGs in retinitis pigmentosa and other cone rod dystrophies. Ultrasound A scan can be used for vitreous hemorrhage. However, ultrasound A scan, remember, is primarily for biometry, for calculating the IL power of the intraocular lens that we are going to insert in a cataract surgery. Though it can be used, remember, it can be used for detection, but it is not the ideal modality. The ideal modality, ladies and gentlemen, is ultrasound B scan. B scan, B for brightness, and OCTs are not indicated for a vitreous hemorrhage. You see, ultrasound B scan is used, and you can see it here. This is how it looks like. You must recognize this. Okay, this is what you see. These various, scattered hyperechogenic areas. This area is this area. This is the vitreous hemorrhage. This is the vitreous cavity, the retina here. Okay, so the V scan is often used not only for vitreous hemorrhage, for detection of retinal detachments, particularly when there's a cataract and you cannot see the detachment because the cataract is in the way. For retinal detachments, for choroidal detachments, for vitreous hemorrhages, various things like that. We require ultrasound B scan. B for brightness, A scan is for A for amplitude. A scans are mostly for calculating IL powers. Here it is B scan. Okay? And remember, whenever the media is not clear, that means you have a cataract, you have a corneal opacity, and you want to see what lies in the retina and the vitreous, we would choose B scan. Question number 2, often used very commonly nowadays, the critical angle of the air cornea interface. Air cornea interface is 32 degrees, 46 degrees, 64 degrees, and 28 degrees. Remember, this is often a question beloved of any set papers where they want to know the exact critical angle of the air, and this is 46 degrees. Remember this. This is a memory question. You see what happens is, why we cannot see the structures of the angle. Okay, we cannot see the structure of the angle simply because of a phenomena called as total internal reflection. When the angle structures, the rays of light pass from the angle structures, this is the iris and this is the cornea. So this is the angle. Okay, so see what happens. The rays of light, they come from the angle. So what happens when they comes to the air cornea interface, because this angle is steeper than 46 degrees. It is not. It's more than 46 degrees. So the phenomenon of total internal reflection, and it reflects back into the eye, it cannot come to the examiner's eye. So simply because the air cornea interface is more than 46 degrees, okay, so it reflects back. So for it to come out, we have to change the air cornea interface to be less than 46 degrees, steeper than 46 degrees, and that is what we do by indenting the corneal plane by a gonioscope. We make the angle less than 46 degrees so that the rays of light get reflected out. They escape this total internal reflection, and the rays of light come out and can be seen by the examiner. The angle is 46 degrees, I mentioned, and that is the correct answer. You see this? This is a better diagram than mine. So the structures lying here in the angle, rays of light get total internal reflected because the angle is more than 46 degrees, air cornea interface. So however, when we place a gonioscope like this, as you mentioned here, you will see the rays of light now, they overcome the steepness, because it's not, this is almost 90 degrees, it's not here. This is less than 46 degrees, so rays of light goes out and they can be seen by the examiner, and that is why we can see the angle of the eye. So this is a very critical angle, and that is exactly why we call it a critical angle of the air cornea. You have to memorize this, there's no other way out of this. I'm so sorry to say. During examination outreach camp, a 12-year-old girl is diagnosed with this abnormality. So you have to look at this picture carefully, ladies and gentlemen. What are the most frequent locations for observing this condition? So first of all, you have to look at this condition. If you look at this picture, I hope this is clear. If you look at the pupil, this pupil is not round like this. Not. Those of you have difficulty looking at the picture, look at that. The pupil appears to be like this. Okay, it is coming like this. Okay, this is an incomplete pupil. This is called a coloboma. The word coloboma means a defect. Okay, and this is iris coloboma. The iris coloboma. So colobomas occur due to the embryonic fissure not meeting together. Okay, the embryonic fissure does not fuse together, so it leaves some defect. This can be anywhere on that. It can be in the eyelids, it can be in the iris, it can be in the lens, it can be zonules, it can be the retina, it can be in the optic disc, it can be in the choroid. So there are multiple levels of colobomas where there's a defect because the embryonic fissure is not fusing. So again, you can have multiple colobomas, right from the eyelid to the iris, to the ciliary body, to the zonules, to the lens, to the retina, choroid, and optic nerve. And this coloboma, as you can see here, so what is the question is, once we've diagnosed the abnormality, the first part is what to diagnose, which is a coloboma. The most frequent location for observing this condition happens to be infranasal. Please remember, infranasal colobomas of the iris. Okay, infranasal, this is the most common. And remember, whenever it is infranasal, we always call it typical coloboma because it is the commonest location. When it is not infranasal, it's somewhere else. Could be infratemporal, could be supranasal, supratemporal. Then we call it atypical coloboma. So kindly remember, infranasal colobomas are the most common, called as typical coloboma. And you can see it here. Look at the picture here, and you can see the iris. The pupil is not circular because there's no fusion here. So the pupil appears to be like a keyhole like this, and it's infranasal. This is the nasal area, you see, infra and the nasal area. So this is the typical location called infranasal, which is called a typical coloboma. Very well. I'm sure there's a lot of new information coming. Let's go to next question. How would you classify the disease in a 70-year-old patient with diabetes and hypertension? Remember, so both diabetes and blood pressures, both of them, exhibiting soft exudates, flame-shaped hemorrhages, silver wiring, disc edema, but no other alterations. Well, you don't need any other alterations. You have plenty of them already. Is it not? So you have soft exudates and flame-shaped hemorrhages. Remember that these can be both seen in diabetic as well as hypertensive retinopathy, though slightly more in favor of hypertensive retinopathy because flame shapes and soft exudates are seen mostly in hypertensive, but they can be in diabetic retinopathy. However, look at the silver wiring. The silver wiring is definitely a sign of hypertensive retinopathy. And disc edema. Remember, you do not have disc edema in diabetic retinopathy. So, this is a question based on classification of hypertensive retinopathy. So, is it grade 4? Is it grade 3? NPDR or PDR? We already discussed that is not a classification of diabetic retinopathy. So, it has grade 4 or grade 3. Remember the answer, because of the disc edema, it becomes grade 4 hypertensive retinopathy. Okay, because as soon as disc edema comes, please remember it becomes grade 4. As you can see this, look at the disc edema here. So, grade 4, remember this is the classification. We have many classifications of hypertension, the oldest being the famous Keith Barker Wagner classification, with the medicine people love to use, but it's a dinosaur of a classification way back in 1936. So, what we use in ophthalmology, because we are more modern, ophthalmology, we are much more modern than the medicine people, and we use this thing called the modified, we use this classification, which is the modified Shee's classification, okay? Modified Shee's classification, where grade 1, which is the most popular, the grade 1 is, what is what? That is just barely detectable narrowing. You see, as hypertension begins, the blood vessels start to spasm. So, there is the grade 1 is barely detectable narrowing, so difficult that in fact some of us ophthalmologists also miss it. Okay? So, grade 1 is very, very difficult to detect because barely detectable narrowing. A few years pass, it becomes grade 2. In grade 2, now it's obvious narrowing. Now you can make out, there's no difficulty making out the obvious narrowing. So, there's obvious narrowing of the arterioles and with the focal changes also, okay, focal changes. Another few years pass, it goes to grade 3. And now apart from the narrowing, which is obvious now, grade 2, plus now you have hemorrhages, like what? Flame-shaped hemorrhages, it could be dot and blot hemorrhages, with exudates, like what? Soft exudates, hard exudates, this is grade 3. And finally, after about 15-20 years of uncontrolled hypertension, now you're in grade 4 hypertensive retinopathy, which is the disc edema. So, you have grade 3 plus disc edema, which now means you have grade 4 hypertensive retinopathy. And remember, as soon as you get disc edema, you have to grade 4. There's no doubt about this at all. Okay. So, grade 1, again to summarize, modified Shee's classification. First, again, the grade barely detectable narrowing of the arterioles. Grade 2, now there's easily recognized detection or obvious narrowing of the vessels with focal irregularities. Grade 3 is grade 2 plus either hemorrhages or exudates, and finally grade 4 is grade 3 plus disc edema. So, this comes into grade 4, that's A. Next question is 30 hours post cataract, 30 hours, that means about a day and a half after cataract surgery, the patient is with pain, redness and visual disturbances in the affected area as shown in the image below. Okay. What is the appropriate management for this condition? And let's look at that. So, you have first of all pain, redness and loss of vision after cataract surgery, and you can see in the picture there's a clear hypopia on here, you can see that. So, this is undoubtedly the feared complication called as endophthalmitis, is it not? Remember, the word endophthalmitis is infection of the vitreous cavity following or during a surgery. Usually, these are post-operative. They could be post-traumatic also, but mostly they are post-operative. The most common being cataract surgery. Okay? So, endophthalmitis is the diagnosis on looking at the clinical condition and the picture. And endophthalmitis, what is the treatment of choice? The question is, intravenous steroids, incredible. That's not an answer. You would not give a steroid in an infectious condition. Intravenous antibiotics, incorrect. Why? Because if you give intravenous, there's not much passing into the vitreous cavity. Bandage and padding of eyes, absolutely incorrect. You never pad and bandage an infective condition of the eye. It increases the temperature, worsens the condition. So, the treatment is the fourth and the final choice, intravitreal antibiotic. So intravitreal, because the infection of the vitreous cavity, so we go straight through the pars plana and into the vitreous cavity. We inject depending on the organism. Most common organisms are usually gram positive, so we inject intravenous vancomycin, intravitreal, beg your pardon, vancomycin. But sometimes it can be gram negative also, like caused by Pseudomonas, E. coli, Serratia. In that case, the drug of choice becomes intravitreal. We can give amikacin, or we can give intravitreal ceftazidime. Okay, so this is the question here. There is intravitreal antibiotic. There's no doubt about this. I hope you're all getting this correct, and you've seen this. The intravitreal antibiotic. You can clearly see that we have measured about 3.5 to 4 millimeters from the limbus. Taking a vernier caliper, we measure 3.5 to 4 millimeters. That is where and you go straight down perpendicular to the sclera. You are passing through the pars plana, which is the correct place to go. In fact, it's the only place to go and inject into the vitreous cavity. This is the pars plana, and the location is 3.5 to 4 millimeters in a phakic eye. That means an eye which has its own lens. In pseudophakics and aphakics, the diameter changes slightly more. So this is the drug of choice, is intravitreal antibiotic. Very well. Next question is, a 30-year-old lady complains of frequent itching, irritation, burning, redness, mucous discharge, and decreased contact lens tolerance after wearing contact lenses for 15 years. What is the most likely diagnosis? Is it atopic conjunctivitis? Incorrect. Vernal catarrh? Incorrect. Vernal catarrh is not only about contact lenses but about the weather. Bacterial keratitis? Incorrect. There is no pain here. The best answer is giant papillary conjunctivitis, GPC, giant papillary conjunctivitis, which means this is the most common, one of the most common reasons for discontinuation of contact lenses. In fact, it is the single most common side effect of wearing contact lenses. And you can see that here, giant papillae, which are elevations of the conjunctiva like this, and they have their small and reddish and velvety because of you have this blood vessel core going right up till there. So this is the blood vessel, and giant usually means that they're more than 1 millimeter in diameter. A normal papillae is about 0.3 millimeter in diameter. When it goes more than 1 millimeter, we call it a giant papillae. And this is a type of allergic conjunctivitis. And you see, because the contact lens edge is constantly, as you blink, the contact lens edge is hitting against the eye almost 8,000 times a day. Imagine something hitting your eye, the most delicate part of anatomy, 8,000 times a day, okay, as you blink like that. So this edge of the lens, it causes irritation and it forms giant papillary conjunctivitis. GPC, kindly remember, is the single most common complication of contact lens wear. Okay, sometimes they want to ask a question, contact lens use corneal ulcer. In that case, remember, the question changes because now you will have pain and loss of vision also. But if you see here, neither is there any pain mentioned, nor is there any loss of vision mentioned. So they are not talking about a contact lens here, which is why we can rule out bacterial keratitis. The answer is GPC. So can you remember, there are multiple complications of contact lens wear, but the two most common is GPC followed by corneal ulcer. It depends on what kind of question you're given. Look at the symptom and diagnose accordingly. And I'm sure all of you got this correct. Very well. A 40-year-old female presents to the ophthalmology clinic with complaints of blurring of vision and difficulty adapting to bright light. Okay. On examination, anisocoria, remember anisocoria means difference in the diameter of the two pupils, with the affected pupil appearing larger than the unaffected pupil. So there you have a young lady, reasonably young, 42, remember, with one pupil dilated, the other normal. Now, does that give you something? Yes, it does. It tells you something, does it not? The young lady comes to you with one pupil dilated, the other normal. There's poor pupillary constriction in response to light, but the constriction is more pronounced when the patient focuses on a nearby object. That's even more familiar, not? So we have this light negative and accommodation positive. So when you accommodate and look at a near object, your pupil is constricted, but when you are flashing a light here, it is not constricted. So light negative and positive. So remember, this is one of the many causes of LND. Remember, we all call this light near dissociation. So let's look at so now we know LND. Orbital trauma, incorrect. There is no light near dissociation in orbital trauma. Diabetes mellitus, incorrect. You do not have LND or light negative accommodation positive here. AD sit-down pupil is the correct answer. AD is pupil, remember. Young lady comes to you with a pupil dilated. Idiopathic, could be post-viral, could be post-traumatic, okay. But most is idiopathic or post-viral. And one pupil dilates, the other remains normal, which is exactly what, and the famous light negative accommodation positive. Look at that. This pupil is dilated. AD is pupil, often found in young ladies. We don't know the reason exactly why not men. Sometimes bilateral, but more commonly unilateral. So, well, in light negative accommodation positive, also known as light near dissociation. Okay. So, this is the famous AD's pupil, and we will confirm our findings by doing the pilocarpine test, which you must remember that when you put pilocarpine, very diluted pilocarpine, okay, 0.125% pilocarpine, remember, then when you put 0.125%, ideally pilocarpine constricts the pupil. This pupil will constrict, but the normal pupil will not constrict. That is the test. The normal pupil does not constrict because the concentration is too diluted. Okay, so that is why normal pupil does not constrict. Why does the AD's pupil constrict with 0.125, which is 1/8 of concentration per 1%? Because of a physiological concept called as denervation supersensitivity. Since the nerve is denerved here, is damaged here, so it is supersensitive to even very minute amounts of pilocarpine, which is 0.125. The answer, ladies and gentlemen, as you all got it correctly, is AD's tonic pupil. A 3-year-old baby on examination was noted to have an eyelid ptosis. You can see it here since birth. Okay, so it's a congenital ptosis. Which of the following abnormal examination findings is like this? Remember, it's a congenital ptosis. That means the child has ptosis from birth onwards or within 1 year of age. Defect in LPS could be a defect, which could be a right from birth onwards. Trigeminal ocular synchysis is incorrect. Trigeminal ocular synchysis is seen in something called as Marcus gantosis, where we'll mention that the lid opens, or when you open the mouth also. Abnormally high upper lid crease is incorrect. This is in senile ptosis, when the abnormally high lid crease is also incorrect. Reduced frontalis function is also incorrect. Last, ladies and gentlemen, is congenital ptosis, where the main problem is LPS. There's a defect in the LPS from birth. It's a dysmorphic or a dystrophic LPS. So, the patient is born with the LPS, which is defective from birth onwards, okay, for whatever reason. And because LPS is defective, so it's not able to open the lid. And that is why these children have ptosis. It is important for us to know, because when we treat this condition, because congenital ptosis, since the muscle itself is dystrophic, so we have to do more LPS dissection. Remember, you may have a congenital ptosis with LPS damage, and you may have an acquired ptosis also because of LPS weakness. However, we require, what is important for us is that in congenital ptosis, we require to cut more of the LPS. We have to resect more because this is dystrophic right from birth onwards. In acquired ptosis, the reason is not because of LPS dystrophy. The reason is just LPS weakness. So, the amount of resection is correspondingly less in acquired ptosis, but it's slightly more in congenital ptosis. That is why we need to know, because the management depends upon the congenital or acquired. Okay. And with that, ladies and gentlemen, I have to thank you for your very major patience in listening to my blatherings. Thank you very much, and all the best. And I hope you have all done very well.